Yes, it's on YouTube. All right. So good morning, everyone, again. I'm Senator Saud Anwar. I represent the 3rd Senate District, the towns of East Hartford, South Windsor, Ellington, and East Windsor. I'm here today, one of the co-chairs for the Public Health Committee. Welcome to the first Public Health Committee public hearing on February 3rd, 2025 for the 2025 session. Couple of things we want you to be aware of. Make sure you look at the exits where if you need to exit the room. And also, there are individuals who are online. You will get an invitation to become a panelist. So please accept that invitation. Only when you are going to be a panelist, you will be able to participate in the testimony. And I will invite my co-chair to make any comments.
Thank you, Senator Anwar. Welcome, everyone. Happy Monday. We are very happy to see you here in person for our hearing, and also we're happy to see those of you online. We'll be consistently reminding you to accept the invitation to join as a panelist. I know Senator Anwar, even if he did say it and I wasn't listening, I'll repeat, we do have a 3-minute time limit for all folks testifying. Okay, there we go. We are definitely being recorded. We are also being streamed on YouTube, so we're all set. But just again, the reminder that we will certainly have questions. So those of you who have 3 minutes, some of you will probably be getting extensive questions as well. So again, thank you to all of you for being here. Thank you, Senator Anwar.
Thank you, Representative Claire Dieter.
Thank you, Mr. Chair. Good morning, everybody. Welcome. Looking forward to hearing some robust conversation on our list of bills today. Thank you, Mr. Chair.
Thank you. And just as a reminder, for the first hour, we are going to have some of our elected officials and representatives for the administration who are going to be able to speak on the bills. And then after the first hour, we will alternate between the public. And so first person on our list is Representative Robin Comey. Representative Comey, you're on. Welcome.
Hi, good morning, everyone. Welcome. Thank you so much to the Public Health Committee for allowing us to have this voice today. I'm State Representative Robin Comey. I represent Branford, the 102nd District. And today I am in support of Senate Bill 1191. That is an act establishing a pancreatic cancer screening and treatment referral program for the residents of our state. This bill came to my attention from a constituent, Linda Kowalski, whose husband, Mark Galuli, passed away from the disease last September after a long battle. And you're going to hear testimony today from a lot of folks who are going to talk about how insidious pancreatic cancer is. And too often, I've lost several people with this devastating disease. And by the time a person has symptoms that you get to the doctor, it is too late. So among cancers here in Connecticut, it is actually the second leading cause here behind lung cancer, the type of cancer. So today you're going to hear from a lot of testifiers talk about the use of some promising programs such as genetic markers that can be the basis for screenings of the disease. So thank you for the work this committee has done in the past with the screening services for folks who are at risk of higher risk of breast cancer, cervical cancer, and lung cancer. So I wish you a very informative hearing. I would just like to cede the rest of my time to introduce Dr. Brett Shipper. He is a surgical oncologist in Hartford Hospital, and I believe he is there in the room with you.
Thank you. Please, do you accept the yield, Dr. Shipper? Please, welcome. You can turn the lights. Yes, you're on.
Senator Anwar, Representatives McCarthy, Vahey, Senator Somers, and Representative Clarita Deteria, and members of the committee. My name is Brett Shipper. I'm the Chief of Surgical Oncology at Hartford Hospital and the Co-Physician-in-Chief of the Digestive Health Institute. I've lived in Farmington, Connecticut with my wife and 5 children for the last 12 years, and I'm a pancreatic surgeon who's devoted my career and training to the treating and battling patients battling pancreatic cancer. I'm here today in support of Senate Bill 1191, an act establishing a pancreatic cancer screening and treatment referral program. Pancreatic cancer is the second leading cause of death behind lung cancer in Connecticut. According to the American Cancer Society, In 2024, there were an estimated 67,000 new cases of pancreatic cancer diagnosed in the United States and a staggering almost 52,000 deaths from pancreatic cancer in the same year. The 5-year survival rate is about 12.5%, with only 14% of people being diagnosed early with localized disease to the pancreas with no spread to the lymph nodes or beyond. We know that survival, if discovered at a localized state, is 44%, but quickly falls to 16% for regional disease and down to 3.1% for distant disease. The key to survival is early detection. That's why Hartford Healthcare has partnered with Project Purple, a not-for-profit based locally here in Connecticut committed to the fight against pancreatic cancer, to establish the state's most extensive high-risk pancreatic cancer screening program. Thanks to a generous donation from Project Purple, we have established a program that identifies individuals who are at high risk for developing pancreatic cancer and screening them to hopefully catch its development in the earliest stage to try and achieve the best survival possible for our residents here in Connecticut. According to the NIH, screening is advised for high-risk individuals with a strong family history of pancreatic cancer or specific genetic mutations, typically starting at age 50 or 10 years earlier than the youngest affected family member, using a combination of MRI and endoscopic ultrasound. Results from multi-center trials looking at pancreatic screening, including the CAPS-5 study, show this type of screening found a high incidence of resectable stage 1 disease. We know early detection saves lives in pancreatic cancer. By using the footprint of Hartford Healthcare's clinical locations, our screening program will blanket the state of Connecticut, allowing for all residents to have access to this life-saving program. We have various cohorts in our program, including those with genetic predispositions such as BRCA, PALB2, and ATM, as well as others who have a family history of pancreatic cancer, with no known genetic predispositions but significant penetrance of pancreatic cancer in the family, as there may be other genes that we are not yet aware of. It is legislation like this that will help us support this incredibly important work to truly make a difference and save lives here in Connecticut. Thank you for listening to my testimony today. Senate Bill 1191 is a life-saving proposal, and I would be happy to answer any questions you may have.
Thank you so much, Dr. Chipper. I do have a few questions I wanted to. So in general, we are not doing these markers on individuals or genetic tests on individuals. So what would be the indication to do it? And at what age you're thinking that those blood tests be done or genetic tests be done?
So genetic testing is very readily done at this point for any patients with cancer. Anybody who has pancreatic cancer automatically qualifies for genetic testing. If you have a family member who has had pancreatic cancer, you also still qualify for genetic testing. There are also many other cancers such as breast cancer and ovarian cancer that all get genetic testing and frequently find patients with things like BRCA and other modalities. So there's a lot of genetic testing going on as a routine with any cancer diagnosis.
Let me rephrase my question. For people who do not have any cancer history, is that something that they can look at and see if there's a high risk and then they would be part of a screening process, or it's only if they have had a family member or immediate family member with it?
There are places in the state of Connecticut that you can get genetic testing done without a family history.
And is insurance covering this?
It is.
It is covering this at this time. Okay. And I'm going to see if any of my colleagues have, yes, Representative Clarice Jeter has a question or a comment.
Oh, thank you. Thank you for being here, Doctor. I'd like you to elaborate. They say that they claim that there's not one technical screening test that you could take for pancreatic cancer, but can you elaborate on the prevention services?
Sure. So as far as what we use for screening, what we're proposing for screening. So you're right. Unlike things like colon cancer, we have colonoscopies, or breast cancer, you have mammograms. One of the struggles in pancreatic cancer has been finding the optimal screening test. We know currently, based on NIH recommendations, that the best method right now is alternating MRI and endoscopic ultrasound. We know MRI has higher sensitivity than CAT scan, and endoscopic ultrasound has an even higher sensitivity as it directly looks at the pancreas itself. So typically what we do for patients who meet our criteria for our screening program, the NIH standard is to alternate yearly an MRI and then an endoscopic ultrasound every other year.
Okay, thank you. And just to reiterate, you said if you qualify to get the genetic testing, that typically is covered by insurance companies.
Correct.
All right.
Thank you. Representative Daphne, did you?
I didn't, but I will.
Okay.
Thank you.
Thank you.
Just so insurance is covering it. So what are we looking for? What are we asking for here? I'm trying to just be really clear.
Sure. So in order to do this screening successfully, you need a couple of important pieces. You first need the data management side of these protocols. You need to be able to have a large data bank of these patients. We have patients who have genetic predispositions, but that may not have a family predisposition, so we keep them in our data bank. I think there are folks who don't have insurance, who may not have the ability to pay for their screening program, whether it's an MRI or an endoscopic ultrasound, so they may need financial support as well.
Thank you.
Thank you. So if people are listening to you right now, which they are, what would you say to the general public? What would you say to the people who have had a loved one who had a pancreatic cancer? And then how would you be able to connect with them about what they could do?
I think the key to success in pancreatic cancer right now is early detection. Unfortunately, the surgeries for pancreatic cancer haven't changed in years. The chemotherapy options are limited. So we unfortunately don't have any new advances in those areas. The biggest advance we can make right now in pancreatic cancer is early detection, is identifying people who are at high risk for developing pancreatic cancer and figuring out ways to screen them early. We know through studies like the CAPS-5 trial that have done this work that if we screen patients, we will find them at earlier stages. And as I mentioned earlier in my testimony, we know if pancreatic cancer is detected at the earliest stage, the survival is significantly higher than if it's found at more advanced stages.
And when you say that endoscopic ultrasound, that's almost like an ERCP level?
No,
Okay.
so it's basically an upper endoscopy, except at the end of the upper endoscopy probe, there's an ultrasound probe at the end. So unlike an ERCP where they cannulate the bile duct and go up into the biliary tree, this is just an upper endoscopy, and the pancreas anatomically sits right behind the stomach. So with the probe, they can look through the wall of the stomach directly at the pancreas and be able to identify the most subtle of lesions, as well as biopsy the lesion. Where MRI can only see the lesion, during an endoscopic ultrasound, you can also biopsy the lesion.
Good. This is very helpful. Thank you so much, Senator Gordon. Very timely entrance.
I tried, Mr. Chairman. I'm in the middle of another public hearings, but I did want to come over and thank you for testifying. And with regards to pancreatic cancer, I forget the bill number that it is, 1191. My day job when I'm not a senator is I'm a hematology oncology doctor. So I deal a lot with pancreatic cancer. And as we know, pancreatic cancer is, I do tend to say, one of the worst ones, because we have, by the time we find it in the average person, it tends to already be spread. And it can be very difficult, even with a lot of advances in treatment, to actually treat it for very long periods of time. And I've always wondered about what we can do more to screen for it, because as you know, if we can find it early, we actually have quite an opportunity to cure people.
Absolutely.
But the trick is you got to find it early. And many times it doesn't present itself with symptoms until it's already advanced stage and the horse is out of the barn. One of the questions I have for you is, have you been finding in your experience the advent of a lot of the technology that's out there with a lot of the blood tests, a lot of the particular the functional imaging studies that we have nowadays, just not the x-rays and the CAT scans, about being able to find these cancers earlier, especially when they're operable, which is a foundation of cure for pancreatic cancer. Have you been seeing that with regards to your own experience? Because to me, that tends to be very exciting technology and opportunities we have to make a difference in people's lives, including when they have a positive family history and we want to go looking because of their risk. And we can test all sorts of genes nowadays and find their risk. But I'm just interested in your perspective on that, because I certainly support whatever efforts we can do to try to find pancreatic cancer early. At the same time, continue to develop the wonderful treatments that we have overall in the oncology world.
I think your point is great. I mean, as we know, the only true cure for pancreatic cancer is surgical resection. Chemotherapy, radiation, those modalities can slow down the advancement, but the only cure is surgical resection. And as you mentioned, unfortunately, the majority of patients are found beyond the time when they're candidates for surgical resection. I think, as we're talking about today, the holy grail for pancreatic cancer is finding ways to find these patients at earlier stages. I think based on NIH standards right now, MRI and endoscopic ultrasound have become the gold standard. But to your point, there are a lot of amazing advances going on. We have things like circulating DNA, where we can do a blood test and potentially find DNA markers of a cancer in someone's bloodstream, potentially even before we can find it visually on imaging. We have other types of functional scanning, as you mentioned, like dotatate scans, where we can pick up neuroendocrine tumors in the pancreas, far earlier than before they cause symptoms. The pancreas is a very interesting organ because depending on where in the pancreas the tumor is, you may have no symptoms. In the back half or tail of the pancreas, you can have a tumor grow incredibly large there before anybody knows anything's there. In the head of the pancreas where the bile duct is, we tend to find them sooner because they obstruct the bile duct and you get jaundice, which is one of the telltale signs of pancreatic cancer. But, back to your question, I think that's what a lot of research is going on right now. There are studies going on looking at the microbiome flora of your mouth and studying the bacteria, and there are indications you may be able to find cancers early that way. I think, there's certainly a lot of new techniques that are going to be coming down the pike in the next few years. And I think they need to be vetted because there are costs to these things and, sensitivities and specificities that we need to make sure are adequate to use as testing. Another is CA19-9 that has been talked a lot about as a blood test that's elevated in pancreatic cancer. I think we also have to be sensitive to cost and performing tests on patients that may not give the results that we need. So I think at the moment, MRI and endoscopic ultrasound are the gold standard. But I think in the next few years, we are going to be seeing other things like circulating DNA and other functional imaging tests being used. In my personal experience, I don't think they're standard of care. I haven't seen them used on a daily basis, but I do see promise in their future.
Thank you, Mr. Chairman. I would just echo in my own practice as an oncologist, these are a number of things that I do look into, and there are cases where I do use them, even though they may not be fully, quote unquote, 100% vetted through, but there are many times we can find these things early, especially those who are increased risk. So I very much do support the bill and the effort, and thank you.
Thank you.
Thank you. Oh, Representative D'Amico.
Thank you, Mr. Chair. Thank you, Dr. Schipper, for coming. This is a great idea for all the reasons that you just expounded on. However, I anticipate, and perhaps I'm wrong, but I anticipate that whatever pushback you might get here is going to come from the Department of Public Health, who is already overburdened with all kinds of responsibilities and all kinds of expenses. So just wondering, could you give us some idea of the financial aspect of this? What's it going to cost in both money and resources, and how? I think you have to do more convincing of them than you probably of this committee. I could be wrong.
So I think, the resources are not huge. We're not asking for millions of dollars here. We're asking for enough money to cover the uninsured, enough money to make sure that we have the appropriate database and technologies in place so that we can adequately track these patients, treat these patients, and make sure they get the care that they need. I would defer to others as far as the exact dollar amounts needed, but I think in the scheme of other programs, this was not going to be an extensively expensive program. This is really just about getting the support to be able to find these patients early so we can help, hopefully get better survival for pancreatic cancer here in Connecticut.
Thank you very much. Thank you, Mr. Chair.
Thank you, Dr. Schipper. Seeing no other questions, we appreciate you coming in, and thank you for all your help.
Thank you.
Thank you. The next person on our list is Representative Vincent Candelora. Welcome. Candelora, sorry.
Thank you, Mr. Chairman. And thank you, Representative Chairman McCarthy-Vahey and Nicole Claridis Detria, Ranking Member. I'm also here to testify in favor of Raise Bill 1191. And just to be brief, I think you're going to hear from people that know far more about this than me. We were the first in the country to implement the ADL screening on newborns a number of years ago, and I think many states have followed our lead. We did that despite the fact that DPH had vehemently opposed that legislation, and we found that in the long run, screening newborns for that disease saves the state money but also improves the quality of lives for those individuals. Similarly, I think with the issue of pancreatic cancer, having known a number of people and having a loved one that's going through this right now, early detection makes all the difference in the world. And I think I applaud the way the bill is drafted because it does focus on our underinsured, sort of underrepresented population in Connecticut, because those individuals that don't have access to healthcare are more likely to receive that death sentence if they're not getting access to detection for pancreatic cancer. So I support the bill wholeheartedly. I think it could help lead to new technologies and new sciences on how to cure this terrible cancer. And that's it. I'm happy to answer any questions, non-technical in nature.
Thank you, Representative Candelora, for your testimony and your support of this bill. And seeing no questions or comments, we will move to the next person who is here in person, Commissioner Andrea Barton Reeves. Commissioner, welcome.
So just checking the clock. So it's still technically good morning. Good morning. Good morning, Chairs Senator Anwar and Representative McCarthy-Vahey, and Ranking Members Senator Summers and Representative Clarice DiTria. My name is Andrea Barton Reeves, and I am the Commissioner for the Department of Social Services. I am here today to ask the committee to approve the necessary authority to implement the all-payer health equity approaches and development, also known as the AHEAD innovation model. You do have I hope, have my written testimony in front of you, but there are just a few high points that I wanted to raise for you and then answer any questions that you might have. So currently, as you know, our state uses a Medicaid fee-for-service model. That is that services are delivered by healthcare providers, and then we reimburse based on a specific payment code that they submit. This does give hospitals some of the financial incentive to provide some services, but it also does not provide a holistic approach to care, which is what the AHEAD model is designed to do. So the AHEAD model will move from the fee-for-service model to a more global budget payment model for hospitals that choose to participate. It is important to know that this program is indeed voluntary. And for some hospitals, this will offer more stable and predictable financing and give hospitals a financial incentive to invest more money in prevention and in care coordination. Again, I wanted to raise up that this is completely voluntary. The state of Connecticut was actually approached by CMS, and specifically the Center for Medical Innovation, to apply for this grant as part of the cohort. We will receive, and having been approved for the grant, $12 million in federal grant funds to design, plan, and implement the program. And that will include the hiring of staff and contractors to design and oversee the implementation of the program model. We then, as a state, have the responsibility to engage in monitoring of that model, and that is according to the terms and conditions of our agreement. We saw this as an opportunity, and it's very important for me to raise this up, that this was it is a partnership. I won't even call it a collaboration. It is a very tight partnership with the Office of Healthcare Strategy. So, and Commissioner Gifford is here today. When we saw this opportunity arise and we were approached by CMS and CMMI, we had a lot of conversation about applying, what it would mean to just apply. The window to apply was very short. The application was very long. And so there was a lot that needed to be done. But when we saw that it had an opportunity to provide innovation, not just in the payment model, but it would be a way for some hospitals to especially shift away from the fee-for-service model and offer a more comprehensive care model. It made all the sense in the world for us to apply for it. And we were very fortunate to have received it because the competition, even though we were asked to apply, the competition was actually quite stiff. So we are in the very early implementation stages right now. But one of the things that's necessary in order to implement this model is to have statutory authority to move away from the fee-for-service model and include the authority to create this hospital global payment model. And that's why we're in front of you today. And that's why I'm here testifying in support of House Bill 6836. And so thank you. And I'm open to any questions.
Thank you so much, Commissioner. Commissioner, can I clarify a few things?
Certainly.
In the recent past, we have seen the federal government reassessing their priorities to the point that there was this conversation that some of the existing federal funding would be stopped or changed. Stop was the first thing, and then there's a question of change.
Right.
How does it, because this ahead model dates back a few years ago.
Yes.
How is this going to change? Do you have any insight?
We have been in communication to the extent that they were allowed to communicate with us with CMMI. We have every indication from them that the grant is moving forward. They have not asked us to stop. They've not issued any instructions that any state that's engaging in the HUD model should cease engaging in that model. So we are continuing in the work that we're doing.
Thank you for that.
Thank you.
And Commissioner, if there are two hospitals and one chooses to move with a HUD model, would the reimbursement for the second hospital change at all?
No, it would not. It's a completely voluntary model.
And it would not decrease. It's not like there's funding that's going to be less for one or versus the other.
No, there wouldn't be.
And the hospitals have different parts to it. There's sometimes one hospital, big system may own more than one hospital. Can they pick and choose which areas it would be more beneficial?
They can. We'd prefer if the entire system were involved because it makes creating a hospital global budget more complex. But yes,
It's doable then.
it's doable. It's not preferable, but it's doable.
As I was trying to understand this, some of the thought was that if you have a chronic disease very high in certain communities, this model is more effective because you have more funding and opportunities to be able to prevent the illness, to get hospitalizations. So it would be work very well in that end. And another area or a hospital where you're managing surgical interventions and so on, it may not be as effective. Am I thinking right, or I was not reading it?
Thank you, Senator. I think I would describe it differently. So when we were contemplating the applying for the grant for this model, we were really thinking about hospitals that are located in areas where the fee-for-service model is not as robust for them because the catchment area where they are and the people that they serve don't allow that hospital to have as rich of a payer mix as hospitals that are in other areas. So for example, if you're in a certain part of the state and I'll just say, for example, it's more rural, then you're going to have less cardiac operations, less hip and knee replacements, the things that create more of a commercial mix and a Medicaid mix and a Medicare mix. So that's really what we were thinking about. And then, but with the global hospital payment model, then hospitals can decide where they want to invest rather than feeling like they have to invest or have to chase a particular type of treatment in order to remain financially stable. So that's why I'm sort of hesitating in answering your question about specific areas because it really is up to the hospital to decide. If they find that in the area that they're in, they are treating many more cardiac patients and far fewer patients that, let's say, need some sort of joint replacement. And they also have patients that need extraordinarily more primary care than they would provide because they're seeing an uptick in their ED. Then they would, under the hospital, the global payment model, be able to readjust their resources to meet those needs rather than feel like there's a limitation on how much they can spend in each ED because they need a particular payer mix in order to stay financially viable.
Thank you, Commissioner, for that. That really is helpful. Can I also clarify? So if this bill moves forward, and are there going to be regulations that will be looked at to go into much more specific terms? Because at that time, a number of concerns will come because there are models of a HEAD program that went well, but did not go well in all aspects of care.
Right.
So if there was an opportunity to further fine tune it, to learn from other states' example, what opportunities would we have? Do we need to fix that in the bill, or would that get fixed in the regulations that would come after the law
So I think, Senator, it would depend on what arose. And you may be referring to Maryland, which is the state that's really referenced the most when we talk about the global payment, the hospital global budget. And Pennsylvania is not the state. But those states are unique in two respects. One of which is that they're both managed care states and we are not. And the other is that they've used a different, what I somewhat facetiously call, especially Maryland, a voluntold model. So all of their hospitals are in. Our model, as we're proposing it and have been approved by CMS, is a voluntary model. So there may have been changes that may have been needed from a regulatory standpoint for some of those states that might not be necessary here, and vice versa. But it's really early for us to tell. But right now, because it is voluntary, we are not, meaning OHS and we're not looking to be overly prescriptive in how hospitals participate in this process. We're really trying to create incentives for hospitals to participate because we know that there are at least a few and maybe more that would like to be able to step in, and they wouldn't necessarily be interested in a requirement to participate and in a model that feels overly burdensome in what it is that they're trying to accomplish. We're trying to encourage a different approach to payment and care.
Thank you. And you referenced $12 million.
Yes.
Is that the total amount or is that just a starting point? Because that's for the Medicare is like
Yes,
a
that
few
is
hours is enough, right?
It is the total amount of money that's been provided for planning, for staffing. It is a very large endeavor, and it seems like it's a small amount, especially over the period of time in which the implementation will take place. But we've budgeted carefully, and we're not expecting that there will be more dollars coming our way. But right now, we have a small but mighty team. We may add a few more people to it. But we think that these resources, as we currently have them, are the resources that we will use to move forward with the model.
Thank you. I'm sorry I'm asking too many questions.
No, please.
Is there in DSS, would there be some support available to have an opportunity for a healthcare system to look at it and then go a little bit deeper to understand if it's a right choice for them to opt in or opt out?
For the hospitals themselves?
Yes.
Yeah, well, that's part of the infrastructure that's built with the $12 million is to build up some staffing so that assessment can happen. And it would happen in part also at OHS. So we would do that in partnership. It wouldn't just be at DSS. We, as you know, we play the role of the payer under the fee-for-service model. And this really, I think, in many ways would represent a more cohesive approach to the ways in which we look at how hospitals deliver care, not just how much we pay, but really what the outcomes are. And that's really the beauty of this model is that we have this dual approach now.
So they will have an opportunity to do some data analysis internally or in collaboration with DSS to understand if this would work for them.
Yeah, so the way that it works now is that CMMI in DC, under CMS, they have a model for a hospital global payment structure. And that it's an overall model. And then each state, as they participate in it, sort of, they customize it, right, for that particular state. And then hospitals have an opportunity to weigh in on what that customization looks like. We've actually already had a preliminary meeting with CMMI. I think it was a little bit before the election. We had maybe a little bit after that. We already had a preliminary meeting with CMMI and our hospital partners so that they could ask questions about the model itself, about what CMMI's role is in that. I know that Commissioner Gifford may be able to answer some more of the specific questions about that, but it's done in partnership. It's not where we decide what the model is and then we just foist it off on the hospitals. It's done together.
This is very helpful, Commissioner. Representative Claridis. Actually, should I have my co-chair? Let's go ahead, Madam Co-Chair.
Thank you very much. Thank you. And I imagine, yes, Representative Citria and others are going to have questions. Thank you, Commissioner, for being here and the information that you and the Office of Health Strategy have provided. Just to follow up on a few of the things that Senator Anwar was asking, you said this is truly a voluntary model, not a voluntold, which is, I think you were referring to Maryland in that case.
Yes, Maryland has a very different models and, they, for many reasons, and obviously every state is a sovereign state, they can make their own decisions about how they move forward, felt that it was best that all of their hospital systems be involved and created a program design where that is in fact the case. and I believe with very, very few exceptions, but it's virtually every hospital. Here, it's a very different state. We really wanted to acknowledge the fact that we're not just trying to replicate what another state is doing. We have a different population. We have sort of different geographic regions than Maryland does. So we've learned from some of the things that they've done in terms of maybe Senator Anwar, this is a better way of answering your question, of what has worked in their global payment budgets and what hasn't, things that we might do differently. But again, we're in the very early stages. But in the end, we decided that a voluntary model would be best here to give the hospitals an opportunity to vet and participate as they see fit.
Thank you for that, Commissioner. I think one question or concern that we've heard is that it's voluntary now. Will that remain? And, voluntold or mandatory.
Right.
And if there were to be any kind of shift in that direction, would there be additional statutory changes needed, or would that be something that you would be able to do as agencies as things progress through this timeline?
I don't think that we could do that unilaterally, but allow me to please check on that. I'm not sure that, and again, that's not the intent. What we're hoping is that for the hospitals that voluntarily participate, that the others that haven't or have made a different decision at that point will see the benefit that the hospitals that have participated receive from being a part of the model and perhaps then join as well.
Okay, thank
Okay.
you for that, and would love that clarification because I think we will be
Certainly.
asked that question
Sure.
by others. You said that you mentioned in your answers to Senator Anwar that there were a few hospitals who were interested in stepping in. So have you had conversation with specific hospitals about this? And I'm not asking you to name who those hospitals are, of course, but just to give us a little bit more sense of that conversation.
Certainly.
And a little more detail on that.
Well, we've had continuing discussions with the Connecticut Hospital Association in general. So we've spoken to all of the CEOs of CHA. We've engaged in enormous amounts of stakeholder. I don't even know if stakeholdering is a word, but that's what we've done, right? So we've talked to every stakeholder that you can possibly imagine. We've had many conversations with hospitals individually, in groups, with CHA. And yes, some have expressed a stronger interest than others. I would have to say that that in general, CHA continues to remain a partner that's open, and we have some specific hospitals that would like to be more deeply engaged.
Thank you for that. And one more, because I'm sure Rep. Claridis teacher has some great questions to add as well. So we are always looking to save money when it comes to being good stewards of our taxpayers and neighbors' dollars. So obviously that is part of this conversation. When we look at the why behind this, just in those few bullet points, what's some of the other why behind the look at this program?
Yeah. So the why, the one that we feel really drives this the most is that it gives hospitals, and I'm talking about care in a larger sense, right? Not, we think about hospitals as the places where we go when something is more acutely wrong. But many of our hospital partners have said, we'd like to be more of a partner along that entire continuum of care. But the fee-for-service model really limits their ability to be able to do that. And this is where I think your point about saving money comes in. If you can intervene in the earlier parts of someone's healthcare, then you have cost avoidance that happens in the later part where they actually are so acute that they need hospitalization. If you have a hospital that's working on a hospital global budget, they can make the decision, right, without having to think about what adverse impact is this going to have on my fee-for-service model, to more deeply invest in primary care, because they're making the decision as the hospital to say, under my global budget, I think I'm just going to pull a percentage out of the air. Out of my 100% of my global budget, where I am and the constituencies that I serve, I'd like to spend 60% of my budget in primary care. Now I can design a program that allows me to do that. It can include case management, community health workers. It can look very different than it does now. And I don't have to worry about whether or not I have a number of people who are coming onto, different floors and different wards in order to be able to remain financially stable. That's a big difference than the fee-for-service model, where it is necessarily driven by the number of people who come and the number of people who actually then end up being admitted and have different kinds of care that might be more expensive. That, I think, is really where states like Maryland and Pennsylvania and Vermont to a certain extent have seen their cost savings is where they've allowed hospitals to invest where they know that the patients that they serve in their areas really need the care, and then be able to direct those dollars towards that care.
Thank you. Actually, I appreciate that. So I think your answer spoke to some of the cost savings, but it also spoke to what we heard in the first two testimonies, which was the ability to incent and prioritize preventive care and preventive services.
That's right.
And I think that not only saves costs to our system, but it saves people's lives, and it saves a lot of anguish and pain and suffering that people have as well. So I will ask one last question at this point. Pennsylvania is a different cohort, right? They were the first part of the first cohort.
That's
we're part of the
correct.
second cohort.
Yes.
Is that, and are they all inclusive as well? Is it everybody in? I can't remember if you answered.
Don't know the
that.
answer to that question. I don't know. Yes, this is Dr. Mehul Dalal, who was a practicing physician at Yale, and now he's the chief policy advisor at the department.
Again, Mehul Dalal, Chief Policy Advisor at DSS. The Pennsylvania model was a model that was focused on rural hospitals, and it was also voluntary for rural hospitals. They were successful in the end of, I think, recruiting 14, don't quote me directly on number, but just to give you a sense of scale, 14 rural hospitals to participate in our model.
Okay, so it's definitely not all the hospitals in Pennsylvania.
That's
It's a
correct. It's
small-
not all of
okay,
them.
Gotcha. That's helpful. Thank you very much. Thank you, Commissioner. And thank you, Senator Elmore.
Thank you, Representative Claire Teacher.
Thank you, Mr. Chair. Thank you for being here today. You had mentioned that this is a federal program and it was $12 million.
Correct.
Is that, how long does that $12 million last, and is that reoccurring annually?
It is not. It is it's essentially, because it's a 10-year model, it's like 1.1 or a little bit less than that every year. So it's not a huge amount of money over time for the planning and implementation, but it's one time. It's the 12 million that we invest.
And is there any,
invest.
thank you for that answer. And is there any investment that the state has to put in?
No, the model was designed at this point for us, for this 12 million, to cover our costs, which is why we're designing it with that in mind.
Okay. Thank you. And you mentioned that this is a voluntary program, but is there a minimum number of hospitals that need to be in this program? And will it affect the federal is there a federal requirement with it?
Did you want to answer that, Dr. Law? Yeah.
The requirement the federal government set forth is that they want 10% of the Medicare revenue to be covered under global budget by the first year of the program where we launch, which is 2027. And they want 30% of their Medicare fee-for-service budget to be under global budget by year 3. So that's the minimum requirement that they've set forth. That's on the Medicare side. On the Medicaid side, they have not said that there's a specific percentage that they would like to meet. But I think that we would track closely with that.
Okay, but from at a 4th grade level, for those of us that don't understand, does that affect how many hospitals would be part of this program?
That would mean that we need to target enough number of hospitals to have enough patients to meet those revenue percentage targets.
And do you have any idea how many hospitals that would mean, roughly, that we would have to have in this program?
We can get back to
Yes,
you. I
we
don't have
can.
that
Yes, because we're hesitating because it depends on the size of the hospital, because if the much larger ones that have much more revenue, if they participated, they would mean fewer hospitals would have to participate, and smaller ones would mean more. But I think we have that modeling. We can get that for you.
Okay, thank
Yeah.
you. I appreciate that.
Yeah.
And my last question, Mr. Chair, what would be a reason why a hospital would not want to opt into this model?
There are at least one reason would be that Connecticut is new to this model, right? And so even though there are other states where it's been quite successful, there may be hospitals that may feel that it may be too risky for them, particularly if they already feel that they have concerns with financial stability and the fee for service reimbursement level. That is the primary reason that we've heard that hospitals may choose to participate or may have some concerns about participation.
Okay, thank you, Commissioner. Thank you.
Thank you, Commissioner. Seeing no other questions. Oh, Senator Marks just popped up on the virtual. Go ahead, Senator Marks, you're on.
Thank you, Commissioner. Just one question. Is there any data from the other states that have implemented this program on how it's affected the care of those states?
Yes, there is, and we can get all of that data for you. We didn't want to overwhelm people with what we found in our own research, but we do know that particularly in Maryland and Pennsylvania, there have been very, very good health outcomes as a result of this. Dr. Dullo, was anything you wanted to add specifically to that? Yes, but we can get you the specifics by state.
Thank you. I appreciate that.
Certainly.
Sorry, Representative Kennedy.
Thank you, Mr. Chairman. Welcome, Commissioners. Nice to see you as always. I'm right up here. Sorry.
Sorry.
Very confusing.
Okay.
It's been a long morning already, right? Just for clarification, you had stated in the beginning that with the grant, it would include being able to hire personnel.
Yeah.
Did I understand that correctly?
Yes.
And what would happen with the personnel when the grant is through?
Yes.
Are they absorbed into your budget then, or are they let
No,
go?
we are hiring staff with the expectation that it is a grant. So we're
Mhm.
being very transparent about that. And then when the implementation process is complete, then if there's another opportunity within state service that's under our budget and they're qualified for that and they go through the process, that transition could happen. But no one is being made any guarantees that they.
Okay,
are
thank you for the
retained.
clarification.
You're
Thank you,
welcome.
Mr. Chairman.
Thank you. Now, seeing no other questions or comments, thank you so much, Commissioner,
All
for
right.
your testimony and
Thank
your
you.
entire
Appreciate
team
it.
for the work you do.
Thank you.
Next is Commissioner Nancy Navarrete. Welcome.
Good afternoon. Good afternoon, Senator Anwar, Representative McCarthy-Vahey, and Representative Claritas Ditria, and distinguished members of the Public Health Committee. I appreciate you raising HB 6834, an act concerning the Department of Mental Health and Addiction Services and recommendations for various revisions to the mental health and addiction statutes. I'm Nancy Navarrete. I'm the Commissioner for the Department of Mental Health and Addiction Services. I think you all are familiar with the work that we do. We are responsible for working with adult individuals with mental health and substance use concerns. So this bill contains our recommendation for changes to statutes related to our work and is comprised of four main components. The first is sustaining our pretrial intervention program, which you may know by the name PTIP. The second is reducing stigma through recovery-friendly language. The third is making a technical fix required for compliance with the federal opioid settlement agreements. And the fourth is updating an outdated reference to opioid drug and then making a change for clarifying language. So starting with PTIP, that's a diversion program for certain individuals arrested for operating a motor vehicle under the influence of alcohol or drugs or the possession of a controlled substance. And it's funded by fees collected by the court for an individual's participation. If you are indigent, those fees can be waived. And then DMHAS is mandated to pay the cost of the education and substance use treatment that is required. So we've seen over the past couple of years an increase in waived fees, which has resulted in the program running at a deficit for us. And so we've been able in the short term to cover that shortfall, but it is not sustainable in the long term. So to mitigate that, we are seeking to make DMHAS the payer of last resort. So if a person is deemed indigent but still has some kind of public or private insurance, that insurance can be accessed for these services. We would still cover any co-pays or deductibles, so there would be no out-of-pocket expense for individuals who could not afford that. Sections 3 through 11 include a number of updates to our statutes to promote person-centered recovery friendly language. So substance use, it's taking substance abuse and replacing it with substance use. Substance use is a more neutral term that doesn't carry as much judgment, allowing individuals to seek help without shame or labeling. It reflects a spectrum of behaviors, including both occasional use, problematic use, and focus on the health and well-being of the person. The substance abuse language can perpetuate negative stereotypes, and you will see in the bill, we've just replaced that language. Section 12 proposes a technical fix to the Opioid Settlement Advisory Committee, or OSAC. So last year, Public Act 24-50 added the chairs of the public health, the ranking members of a probes and public health committee. That was 4 seats. We are required to add an equal number of municipal seats, and so we'll fix that this year by adding those 2 that were left out. Finally, sections 13 through 17 relate to an outdated federal reference in the definition of opioid drug. So we worked with DCP and Department of Public Health to review all the sections of the statute where opioid drug was referenced to see if we could find a different federal citation. And we did in the US Code, which is exactly the same as the previous definition that no longer exists and would continue best practice. In our review of that statute and that code, we did find that one section, that's section 13 of this bill, would benefit from additional clarity. This makes changes, clarifying changes, which specifies when telehealth providers can prescribe controlled substances for MAT. Specifically, the goal of this change is to ensure the current access individuals have to buprenorphine. It was just a very long run-on sentence that made it difficult to understand. And so this clarifies that practitioners can continue to offer this treatment through telehealth. So we don't want that to be interrupted if folks were looking on that at that sentence. There's no policy change that's involved in that wording. So we respectfully ask for your support of this proposal, and I am open to any questions that you may have.
Thank you so much, Commissioner. Commissioner, can I just clarify something on the first part about the funding change and having the copays by DMHAS to be? Some of the times these individuals are going through a lot of difficulty, and we have known, at least from our existing services, that the state services do not create the barriers that sometimes the insurance industry does. And most of the time it's a coordination and difficulty around that. Do you anticipate people will not get the access that they need because of this change?
We actually reached out to some of the providers who do this work to say, do you anticipate any problems, or is this, and it is actually beneficial to the providers. It's a higher reimbursement rate through insurance. And this is something that they do every day with the individuals that they serve. So I don't anticipate any problems there.
Thank you so much. I think Representative Gilchrist has a comment or a question.
Thank you, Senator, and good to see you, Commissioner. Nope, I was going to ask a similar question, so thank you.
I'm just thinking the same thing. Representative Kristen McCarthy.
Thank you very much, Commissioner. I just wanted to say thank you. And just to clarify, from a policy perspective, it's really adding the 2 members to the OSAC and the change in the reimbursement. Otherwise, it's really language changes. Is that the best way to summarize that?
Actually, it's a fix on the OSAC. So we are required by the settlement agreements to have equal members, and that inadvertently got left out last year. So we're adding that in.
Thank you for clarifying that. Essentially, the policy change was made last year. We're fixing it to make sure that the full change is happening. So it's a partial leftover change, and in addition, 1 change, and the rest is language. Okay. Thank you. Thank you for all the good work that you do in the department and for all those who work alongside you.
Thank you all for your support.
Thank you so much. Seeing no other questions, we'll move to the next person on our list, which is Honorable Evelyn Daly. probate judge. Thank you, Honor. Welcome.
Thank you.
Good afternoon, distinguished chairs, Senator Hanwha, Representative McCarthy Fahey, distinguished ranking members, Senator Summers, and Representative Claridis Ditria, and all the honorable members of the Public Health Committee, especially my distinguished Senator, Derek Slapp, and my distinguished Representative Michael D'Amico. Sorry, Mike. Thank you for this opportunity to testify in favor of Bill 6837, an act extending the authorization of shock therapy by a patient's written consent or probate court order. My name is Evelyn Mukjian Daly, and I have had the honor of serving as the judge of the Farmington Regional Probate Court for the last 18 years. Prior to becoming probate judge, I worked here as staff, and I have very fond memories. I admire you for the work you do, your dedication to the communities, and to the great state of Connecticut. I wish you all a successful session. As judge of the Farmington Regional Probate Court, I have jurisdiction over the towns of Farmington, Burlington, and Plainville. John Dempsey Hospital is located in this jurisdiction and is where I conduct electric shock hearings several times a week. When I was a new judge, I had been surprised that ECT decisions were under the auspices of the probate court, but over the years, I have come to appreciate the wisdom of the legislature for putting this safeguard in place. The first time I granted permission to treat a patient with electroconvulsive shock therapy was almost 18 years ago to this day. It was for an elderly woman with a bleak diagnosis of malignant catatonia. Doctors testified that she would not survive. I granted the treatment only after educating myself, which included actually witnessing an electric shock procedure. Many weeks later, much to my amazement, that elderly woman, now walking and talking, sought me out at the hospital and thanked me for saving her life. Over the years, I have learned that some ECT patients need extended periods of treatment. Initially, ECT is given unilaterally 3 times a week for several or more weeks, and then is titrated down to 2 times a week, and then to 1 until the patient no longer needs the treatments or goes on a maintenance schedule. Some patients, however, require constant and consistent ECT treatments. Case in point, a 24-year-old who is before my court every 45 days for ECT approval. He has a diagnosis of Down syndrome compounded with disintegrative syndrome. When treated with ECT every 7 to 9 days, he is a joyful, gregarious, and highly functioning young man. ECT offers him a better quality of life. Without ECT, he suffers from both bladder and fecal incontinence. He is prone to violent, uncontrollable outbursts, and he is unable to participate in activities of daily living. With electric shock every 7 to 9 days, he functions very differently. He toilets properly, has a good rapport with his family, and he participates in a day program where he has many friends. To a family already...
Excuse me, Judge Daly, but your time, you've reached your 3 minutes. Thank you.
Shall I conclude or shall I
Actually,
just stop?
I was going to ask you, could you conclude and share the rest of that story?
Certainly. So my conclusion is that it would be much more compassionate to allow to lift the burden by extending it from 45 to 90. I do know that ECT's had a difficult history. There's still public skepticism and the need to protect patients' constitutional rights. And I believe probate court oversight is imperative. However, I do strongly believe that we should extend the time frame to 90 days. Thank you.
Thank you, Judge Daly.
I'm happy for any questions.
Yes, I do have a couple of things I wanted to clarify.
Certainly.
First, thank you for sharing those stories. And In your years of serving in this capacity, have you seen a situation where you felt that the request from the clinicians was inappropriate?
I believe I have denied ECT on several occasions, but by and large, it seems like the right thing. And I have to tell you, anybody that I've granted it for have what I consider miraculous results. It's quite incredible.
And because we'll probably hear from individuals that historically it was used with not enough guardrails, and that was probably 15, 20 years ago. But in the last 10 years, do you think that those cases have been less or more?
Well, as far as guardrails, are you talking about the comfort of the patient and the experience? So now the patient's totally anesthetized. They have protection in the jaw. They have a muscle relaxer. They're out. The procedure takes maybe a second or two. The only aftermath could be a headache. They can go home that same day. It's really incredible. And so it's improved so much from the 50s or from One Flew Over a Cuckoo's Nest that it's a whole different animal at this point in time and a very important tool.
Thank you. And as the literature has become more clear and the indications, do you think that these questionable indication or requests have decreased in your mind with the ones that you would deny in the last 5, 10 years?
I'm sorry, sir, I don't understand.
So in other words, you said that there have been rare instances that you have said you did not agree to that permission. Is that more so in many years ago? Is that more recent?
Probably more so in the past. I think I deal primarily with John Dempsey Hospital, and I think they know what I will grant and what I won't at this point after 18 years.
Right. And there Judge Daly, I'm sorry for asking this question, but I need your insight. We have been approached by certain hospitals and situations where this is a life-saving treatment for individuals, but there are probate judges who are not allowing that, which is putting the life of these patients in jeopardy and requiring inpatient care. In the right indication, it's a matter of life and death. So what do we need to fix a law to be able to address this? Because right now, from parts of Hartford, there are people who cannot get the treatment that they need. These patients who cannot advocate on their behalf because of the underlying condition. You have clinicians and families reaching out and saying, what can be done? And as a public health committee, we don't know how to help that situation.
Yeah, I do know what you're talking about, and the people from that facility had reached out to me. I don't know what the answer is, perhaps education. I think there's everything you need in place, but people have to understand the benefits. And you have to remember too, electric shock isn't done until all pharmacological trials have been done. This is a last ditch effort to help someone that perhaps won't survive.
And I need a better understanding of this, and perhaps you can help me understand. In this building, we have so much empathy for mental health, and we do so much legislative work for mental health. And some of the most severe cases of depression to the point of catatonia, there is FDA-approved treatment with so much data and support internationally and nationally. It's medically speaking, it would be malpractice not to offer that to a person. Why is there not enough empathy for this particular issue for a life-saving treatment for patients in our state?
You know, I don't really know the answer, but from my own experience, I think there's so much stigma. And believe it or not, most people's point of reference that don't deal in this area is One Flew Over a Cuckoo's Nest. They think it's a horrendous thing to do to an individual. And that's why I asked to witness it before I could order it. And Dempsey was very accommodating. And I was so impressed at how quick and how humane the procedure was and the recovery.
Thank you. This is very helpful. Representative Kristen McCarthy-Vahey.
Thank you, Judge. I thank you for your work in the probate court, and my question will focus more on the legal aspect because I do know we're going to hear from medical providers later today, but you have come here today saying that it would be better if there was more time. So just from the administration, the legal aspect, the communication, what is it behind that extension that you think would be most helpful is my first question. And my second is, could you give us an example of a time that you did deny a request and what the legal aspect of that was?
Right, the first one I can, the second I'm gonna have to think about for just a minute. But the 45 days to 90 days, the family has to go through so much. A lot of times they're conserved individuals because they can't give conformed consent, or it could be a whole family that's rooting for the young man that I had described earlier. Every 45 days to go through this when they're trying to survive through life too with someone that's having great difficulty in life. If it was 90 days, it would save them that exam, that inquiry, half time. Is it ideal? Probably not, but you also have to have some faith in the physicians who order this. This isn't something that they do lightly. It's a last ditch effort to help people. And it's not most people that need it continually, but there are indeed quite a few in my court that do.
So if I may, I'll forego the second question because it sounds like it's been quite some time since that denial, and I don't want to have you go into the recesses of memory and not
Appreciate
talk
that.
about something that isn't as part of your practice. But specifically, when a family and a patient have to go through this process, can you just give us a few of the steps that are involved in going through the process? What does that look like for a family coming in to talk to you in the court and working with their family member?
Well, first of all, they have generally a family member inpatient, and they're very concerned. It could be the first time generally the person's had a series of inpatient stays. So of course, they're very concerned. They want the best for the person, and yet they're petrified when they hear electric shock. But the doctors do explain to the court every pharmaceutical that they've tried, how it hasn't worked, what else they can do, how they can only titrate up to so much to be safe. There's a lot of balance with the meds in your body. So this is always offered. Families generally concerned, even if the hospital tries to educate them. Though I have a lot of repeat people that maybe have had, I hope I'm answering your question, ECT maybe 4, 5, 20, 30 years ago, and they're back. Once they've experienced, doesn't seem like anyone says no at that point. Even the patient who can't give consent will say, I want to do it. They remember the help it gave them, the relief.
Thank you. Thank you, Senator Elmore.
Thank you. Seeing no other comments or questions, thank you so much. Wait, Representative D'Amico, I just went past you. Sorry, I did not see.
That's right. I didn't make my my presence known quite as robustly as I should have. So thank you, Senator. Thank you, Mr. Chair. So thank you, Judge Daly, for coming to testify. And it's always a pleasure to have constituents come before this committee, but particularly distinguished constituents such as yourself. So I really appreciate everything you're being here and everything that you had to say. I am, however, troubled by some of the testimony in opposition to this bill that I've been reviewing for the last several minutes here, and I'm particularly troubled because two pieces of testimony have been submitted. One from the Connecticut Legal Rights Project, and another from the National Alliance on Mental Illness, and both of those organizations merit quite a bit of concern from me. I give a lot of credence, is what I mean to say, to those two organizations. I'll just read you a couple of quick excerpts. Connecticut Legal Rights Project cannot support this bill because it would remove an important safeguard for patients' rights. The existing 45-day duration of probate court orders authorizing electroshock ensures that if a renewal order is sought to continue electroshock, that the legal standard for involuntary electroshock continues to be met. And then it goes on further and to say that if a person's condition is not improving such that they are capable of consenting to further treatment, if ECT is not resulting in improvement in an individual's condition, why is it continuing to be performed? Does it meet the requirements of, quote, beneficial, unquote, treatment? Arguably, it does not. So I'm concerned when I read things like that, and I'm sure that you are too. So I want to give you an opportunity to respond to these and maybe one other as well.
All right, so that's a little snippet. And my thought is oftentimes they don't know the cases, so it's more generic. A lot of times the people are conserved, so that's why they're not giving informed consent. And the conservation might not come out of the issue that they're receiving electric shock from. So that's one piece of it. The other is they're not improving, and I'm not sure what that means. So generally, well, maybe I've just been really lucky in 18 years. I have never seen one patient that I've granted electric shock not improve, which I think is just incredible. Sometimes it takes a while, or like the young man that I was telling you about, he needs constant and consistent. Is it an improvement? Well, his life is improved every day. However, is he on the long picture improved? I don't know. So it might be how they look at it too. Did I answer your question?
Sort of.
Sort of.
I continue to be concerned, though. I'm concerned that that this 90 days is if the situation has not improved within 45 days, by making this change that's being proposed, we go to 90 days without consent from the patient. Are we not taking away that person's rights to a certain extent?
Well, you are anyway, but without thoughtful protection. And so the question really is it all right to do it for 45 days, but not for 90? Is 90 too long? I don't feel it is, because I have so many people that need the consistent electric shock, and they just have to come to the court, go through the expense, go through the medical, go through the legal, go through the hearing. A lot of times with the young man I was telling you about, if it's a weekend or if they forget to petition the court on time, it might go, instead of the 7 days, which is ideal, it might go to that 9 days, and he's already having issues. He's already pounding holes in the wall. He's already having toiletry issues.
So just one other thing, if I may, Mr. Chair.
Certainly.
You know, I appreciate what you had to say and what others have had to say about this with regards to the beneficial effects of ECT. But it's also pointed out in a couple of pieces of testimony here from reputable organizations that there are significant side effects, including memory loss, including permanent brain damage, and several things in between. Is that a concern to you? Because it's certainly a concern to me.
Certainly, and it was much more so 18 years ago, but they've able to tailor the way they put the probe. So usually it's unilateral, but they might do bilateral, depending on the person's need. The unilateral will have the least memory deficiency, and usually that memory is only right afterwards. It comes back. It's not a long-term memory loss. I believe in the olden days it could have been. Oh, you look skeptical.
No, I'm like I said, I appreciate, you know, I appreciate what you're telling me. But when I see testimony from organizations who have, you know, who are you know, intimately involved with this you know type of procedure, it definitely raises concerns for me. So I thank you for your testimony, and I'm sure we're going to discuss this further. But thank you.
Thank you very much.
Thank you, Representative Daphne.
Thank you, Mr. Chair, and thank you so much for being here. And
Thank you.
I'm quite impressed with your thoughtful attention and the time you took to really understand the treatment, how it impacts individuals, and before making decisions. That's pretty impressive. My question is specific to. I was curious to Representative Vahey's question with regard to why you would deny that, but my other question would be. Pharmacological treatments also have severe side effects. So is that something that they must exhaust before they go to this? In particular, probably there's physicians out there that know a set of symptoms that will lead to likely that kind of treatment anyway, where the pharmacologicals won't work. I just wondered, is there that exception and opportunity to make those decisions?
So generally, you have to go through the trial. So they're not going to order electric shock first time out. You're going to try all the different meds. Usually it's about 3 weeks for each med to see if it's working on that patient. It's a long process. Person's in the hospital during this duration. And then last ditch, they decide that electric shock might be the only thing that can help the person. Yeah, and you're right. It's a lot of meds. I'm amazed at the number and amount of each medicine people can withstand.
Well, and I appreciate Representative D'Amico's concern for the treatment and the side effects, but we also know the pharmacologicals have a lot of side effects as well. And I almost hate to ask this, but can you think of any example really quickly that you may have denied someone treatment for it, just off the top of your head, like a reason that you would have said this isn't appropriate?
One of the things that's in my mind, and I'm sure I'm going to leave here and remember a whole bunch, but one of them was a family, mostly a husband, that had been exasperated and just wanted to be able to control the individual more. And I think that's what we all fear. And it looked as if he wanted to rush it along to get to that point, and I couldn't grant that.
Thank you so much. Appreciate it. Thank you, Mr. Chair.
Thank you. Representative Reddington Hughes.
Thank you, Judge Daly, for enlightening us on many things today. My question has to do with what Representative D'Amico brought up, and that is what would be a negative, okay, in putting in place something that would say that the 90 days would only apply in the event that they were seeing success with 45 days.
I hadn't considered that. It hadn't been proposed before, but I think it has some merit. Absolutely.
Yeah, because I think that what that would do is it would satisfy both some of the concerns of people that see this as something that, you know, could possibly be abused, and also help the people that really were in need of, you know, more therapy.
No, I think it's probably a very good idea, like a little more time to think it out, but on the surface, it sounds great.
Oh, thank you.
Seeing no other questions or comments, thank you so much, Judge
Thank
Daly,
you
for the
very much.
testimony. And we are far past the 1 hour, so we are now going to be going between elected officials and representatives to community members. And I would like to ask Kathy Flaherty if she would come in. Welcome, Kathy. Good to see you. Welcome.
Thank you. Good afternoon, Senator Anwar, Representative McCarthy Vahey, Representative Claritas Ditria, and I assume Senator Summers is online. All the members of the Public Health Committee. My name is Kathy Flaherty. I'm the Executive Director of Connecticut Legal Rights Project, and as Representative D'Amico kind of gave a preview, we do stand in opposition to this bill. The 45-day, what you have to remember is this section of the statute is within the patient's Bill of Rights. These are the rights that protect people from having treatment imposed on them involuntarily. And the 45 days has been in existence since about 2003. Prior to 2003, the voluntary consent was always 30 days. And I think there was a reason that the point of putting in voluntary consent, because that was about the course of a treatment of ECT. So the person would go through the informed consent process basically each round of ECT treatments. And that's why the consent has to be renewed every 30 days. I think when it comes to involuntary, there used to be no time limit on involuntary shock orders. And it was discovered that there were people at, especially Connecticut Valley Hospital, who had been having hundreds of shock treatments. And part of what I was saying in my testimony is it's one thing if this treatment, and it does work for some people. I want to be on record as saying, you know, we're not saying it doesn't work for anybody, and it clearly does work for some people. But if people are not improving at all to the point where they can't even get out of the hospital, can we truly say that there's no other less intrusive beneficial treatment when we're doing this treatment over and over again? And don't we think it's important that the judges see these people and are able to review their case on a more periodic basis? Stretching that process out to double the time that in between times that the court would see people really would enable, would have a lot more treatments imposed on people against their will. There's a lot of testimony that has been submitted. Some of the people will be able to participate in this hearing, other people will not. But I want to tell the story of a couple people who got, the court granted the order, but then we appealed that order because that's something that Connecticut Legal Rights Project does. And, you know, the doctors had come to testify, said there's nothing else that will help this person except for ECT. We need to do it because, like they've said, medicines have failed the person. And that's why we want to do it. The judge granted that order. Well, any probate court order can be appealed to Superior Court, and we've brought those appeals. One of those appeals, and Gina Texera, who's up next, may be telling the story directly, sharing this story too. But we prevailed in Superior Court, but the shock had already been done because of the timing of the court process. So imagine you're a person where the court has made an order, you've appealed it, but it still gets done to you anyway, and you succeed on appeal, but by that time, it's already taken place. We've also had cases where they said, this is really necessary, we have to do this. We've appealed and asked for a stay of the order, and the order has been stayed, and the person hasn't decompensated. In fact, the person started doing better. So I think for every story that you may hear on one side, remember there's an equal and opposite story on the other side. And that's why it's so important that we have these court hearings and why we do want to maintain the status quo of having those hearings every 45 days.
Thank you so much for your testimony. So I just wanted to clarify a few things. Were there, outside of Connecticut Valley Hospital, have you heard in Connecticut other hospitals being, in your opinion, wrongful treatment or using it for anyone who may not?
I think the procedures that are put in place where the probate court has to review it and make sure the person's incapable of giving informed consent, and that there's no other less intrusive beneficial treatment, that's where you have the probate court judges who are making those decisions based on the evidence that's put in front of them. When you talk about, I don't really want to say that I think anybody's abusing the treatment. I do think that doctors who recommend the treatment come to it, I have to believe, with the best of intentions for the patients they're serving. And they think it's the right thing to do. But I also remember you to ask that, remember that patient experience too, and know that not everybody actually wants that treatment or agrees to that treatment. I'm somebody who actually has had electroshock. They recommended it for me at one point in time, and I actually agreed to it because life was so not good that it seemed like we might as well try it. And I can't really say that it was the remarkable thing that I've seen it take place for other people. It didn't make some of the issues that I'm challenged with go away. And it did have some side effects. I mean, I have issues of memory loss from that period of time that really have never changed. So.
Thank you for sharing your personal experience. Seeing no other comments or questions, thank you. Representative D'Amico, I'm always an afterthought, right?
I didn't want to belabor this, Senator, but I just want, since Kathy is in front of us here, I do want to ask. So do you, Kathy, and I know maybe you answered this already, but it's not clear to me.
Okay.
So if we change the law as this proposed bill aims to do, what do you see as the practical downside for some?
Well, I think
some patients.
I think especially for those initial orders of ECT, where the person, it's really being recommended for the first time, as opposed to somebody who's coming back there every 45 days for the renewal of the orders. It's doubling the amount of time somebody's potentially subjected to a treatment that they haven't consented to. There are people where it is being sought for the first time. And I think denying people of that right to, especially for people who, because I just want to put it out there on the record, when you're agreeing with what the doctors recommend, especially in psychiatry, this has been my personal experience, they don't raise questions about your capacity to give consent. But as soon as you challenge their recommendations or you don't agree with what they do, it is not that hard to say that somebody's incapable of giving informed consent, or at least raise that as an issue and question people's capacity. And even if somebody, the other thing that I'd like to point out is that when the court gives authority for the permission for shock therapy, nobody's actually providing informed consent for that shock therapy. What they're going to court for is for permission to be able to do it. When you're talking about involuntary medications, at least that adds another level of protection, because the court appoints a conservator for the purpose of consenting to psychiatric medications. So somebody is going through that informed consent process. Nobody goes through that informed consent process when you're talking about involuntary shock.
Thank you. Seeing no other comments or questions, thank you for your testimony and your advocacy.
Thank you.
Representative Tony Scott, thank you for your patience. Welcome.
Thank you. Appreciate it. Thank you to Chairs Anwar and McCarthy-Vahey, Vice Chairs Marks, McCrory, Belton, Ranking Members Summers and Claris Ditria, and the rest of the Public Health Committee for allowing me to speak and provide my testimony on SB 1190, an act requiring nursing homes and assisted living facilities to be equipped with an automated external defibrillator known as an AED. I proposed this bill after a constituent of mine, actually from Monroe, used their voice and expressed concern when he found out that the assisted living facility that his grandmother was staying at in Connecticut did not require nor have an AED. The state currently mandates AEDs be located at golf courses, collegiate athletic areas, schools, and even fitness clubs and gyms. This bill would require nursing homes and assisted living facilities to have an AED on site, while someone on duty be trained to use it at all times. Neighboring states, New Jersey, Massachusetts, Pennsylvania, among a few others, already have this requirement. And New York currently has a bill going through their legislature with the exact same purpose. Many individuals that are assisted living in nursing homes are at high risk of suffering sudden cardiac arrest due to the fact that risk increases with age. They are some of the most vulnerable individuals, and having an AED close by could be the difference between life and death. There are 356,000 deaths per year in the United States from sudden cardiac arrest outside the hospital. 90% of the incidents end up in death due to the lack of an AED close by. But survival can be as high as 90% if treatment starts within the first minutes after the sudden cardiac arrest. That rate drops by about 10% for every minute there is no treatment. 10% each minute. Honestly, I'm not a fan of mandates. And I understand this one will cost those non-compliant facilities Around $1,000 to purchase an AED. I understand that. But the cost is peanuts when talking about the possibility of saving a life. Thank you for your consideration of this bill, and I hope you see the importance and need for it. And I'll take any questions if there are any.
Thank you so much, Representative Scott. Thank you. We heard you loud and clear, and please share with your constituent that the Public Health Committee took your recommendation, the recommendation of many of our colleagues, very seriously. So we appreciate your testimony and your patience with us today. Seeing no other, Representative Claire Teacher has a comment.
Thank you, Representative, for your advocacy on this, I find, a very important issue. And to your point, I know we require and we do mandate AEDs in certain other situations and buildings. I think this, as we like to say, is a no-brainer, and it's a good bill. It ought to pass. So I will continue to push for this on my end because I do think it's very important. It's a public safety issue that we need to move this issue forward. Thank you again. Thank you, Mr. Chair.
Thank you.
Thank you. And the next person on our list is Ms. Gina Teixeira. Welcome. I hope I pronounced your last name closer to.
Teixeira, unless you like baseball, then it's Teixeira.
Can you hear me?
Yes.
Okay, thank you. Good afternoon. I see my representative, Advocacy is here. Good afternoon. Good afternoon, everyone. I'm testifying today on House Bill 6837, an act extending the authorization of shock. My name is Gina Teixeira. I'm a staff attorney at Disability Rights Connecticut. We're the federally mandated protection and advocacy system for Connecticut. And my experience, and the reason I'm testifying today is that my experience is informed through many conversations I've had with clients who had questions about shock, call to ask whether we could consider legal representation or an appeal, and at times taking on those appeals. So what I want to do today with my time is to tell you a little bit about, to give you information about what the current law actually provides. It's not very long. Subsection C is just a few lines, because as you decide whether or not to expand the time, you're also expanding everything else that the law currently provides. So I want to focus my time on that. And I want to talk just briefly on three things. One is the informed consent issue and the substituted decision-making issue with the statute, the legal standard of proof that's required in shock cases, and the barriers, what barriers we have to appealing these decisions. And the best way to talk about this is to compare the shock provisions to the involuntary medication provisions. So subsection C, which is the shock statute, is a subsection to the statute 17A 543, which also covers medication. And I want to highlight that the current law provides for much lower due process protections for people facing shock hearings than exist for medication. So for shock, informed consent and substituted decision-making, as Kathy pointed out, basically does not exist. In a probate court can order the hospital to pursue shock over a patient's objection if the court finds that the person is not capable of providing informed consent and there is no other less intrusive beneficial treatment. So a person is found not to be capable of balancing the risks, the benefits, the alternatives to the proposed treatment. And if the hospital's petition is granted, nobody does that analysis for the patient. In contrast, for involuntary medication hearings, the statute subsection E explicitly provides that if the person doesn't have consent, a conservator will be appointed to be responsible to do that analysis. The legal standard of proof in involuntary medication hearings is clear and convincing evidence. For shock, it's not. It's preponderance of the evidence standard. And that's why it is, easier in shock cases to for a judge to decide that the person's not capable of informed consent because of that lower standard applies to all of the provisions of the statute and what's required for a hospital's petition to be granted. In terms of the barriers to appeal, 30 days is not a lot of time. Most of the people that contact us, the time has already expired. People in facing shock treatment do not have the right to counsel on appeal. And they also, without an automatic stay, the hospital's petition could be granted today. Shock could start later today or tomorrow. And so in the shock cases where I've represented people, there's this very big scramble to get a lot of documents into court as quickly as possible. Because that shock treatment could start immediately. So you have to prepare a summons and complaint. You have to prepare, in many cases, a permission to use a pseudonym, a memo to support that permission to use a pseudonym, an affidavit by the patient, an emergency motion to stay the probate court order so that the person has an actual right to appeal that decision.
Excuse me, Ms. Terrigat, but your 3 minutes has been reached. Thank
Okay,
you.
Thank you. If anyone has any questions, I'm happy to answer.
Sure, Representative Zupkus.
Thank you. Thank you for coming today. Did you make all 3 of your points? Because you said you had 3 pieces and I wanted to make sure.
I think I did. The lower standard on informed consent, there's no substitute decision maker, the lower standard of proof and the barriers to appeal. Yes.
So you think by balancing this out that it will be, I don't know if, I don't think this is the right terminology, but more fair for the patient, or it will be more of a balanced approach for the patient?
I'm not sure what you mean.
Well, because you were saying that this shock, maybe I misunderstood you, that the shock therapy is less, I think, than something else you were talking about. I was trying to understand and make sure you got all your points. But it seemed like that the someone who is being referred to that involuntarily, they didn't get the same representation as something else. No, am I totally understanding what you're saying?
So if you think about parallel hearings, one for shock and one for medication, the person facing forced medication does have a conservator, or if the court is going to grant it, they would appoint someone to think about the risks and the benefits. And then they can say to the hospital, well, my decision is no. Whereas in the shock hearing, the person, the hospital gets if the petition is granted, they can go ahead with the procedure.
That was my point, what I wanted to ask. So that needs to be fixed, is what you're saying. It needs to be
I mean, I'm here today really not in support or against the bill. I really want to just highlight what the current law is and say that if the time frame is expanded, it really does provide treatment over objection without court review.
Thank you. You said it much better than I did, but at least you knew what I was asking. Thank you.
Representative Kristen McCarthy-Vahey.
Thank you. And thank you, Attorney Texera, for laying out some of the legal standards. But what you just said, I want to follow up on that. This law and the change to the bill, the proposal before us would not change what you just talked about. We don't contemplate that in what we have here. That in other words, whether it's 45 days, 90 days, a year, the current standard for shock is not to require a conservator. Is that correct?
That's correct. Yes. I wanted to just highlight what the current law is, just as a reminder that all of this would also be expanding, right? The person's being subjected to shock without anyone conducting the informed consent analysis and all of the other things I said. It's not really as simple as saying we're going to expand 45 to 90 days. It's really all of this would have the doubling of the time and the impact it has given what the current law is.
So I think then we'll talk about this a little bit more too with Dr. Sakara, but it's interesting because we have the legal side and we have the medical side. And in the midst, we have the patient who all of us agree that's what this is about, is providing the maximum benefit to the patient. And I would suggest that those who are proponents of this bill are certainly not interested in just making life easier. Though we recognize that when we have situations, which sounds like from the attorney or the probate judge who testified, that many of the people who are coming before her, at least in that probate court, are coming with conservators. So they already have conservators. So my question to you is, in your practice, and I perhaps should have asked this of Attorney Flaherty as well, but in your practice, how many cases do you see where there is actually not a conservator, even though it's not required? It sounds like in practice that is often the case. So can you tell us your experience with that?
In my experience, most have conservators, but legally the informed consent is not required. So I have seen situations where that discussion doesn't happen. And you could see in, for medication, there's a long list of things that a conservator is ordered to do. For example, review the medical record, have a conversation with the doctor. That is not required under the shock law as it's currently written. But to answer your question, yes, I would say most of the clients I've talked with have conservators.
And just to clarify on that third point, in terms of barriers to appeal, is essentially the main barrier that you discussed, the fact that it is not required that there is an attorney. Is that right?
Right. People do not have the right to counsel on appeal.
They don't, that's a much more accurate way to say that. They do not have the right to counsel on appeal.
Right.
So is that's the main barrier that you were talking about?
That's I think a barrier, and the corresponding significant barrier is that if the hospital gets a petition today and they can start shock today or tomorrow, do you really have a meaningful right to appeal if you're subjected to the treatment you're seeking to avoid? So I think an automatic stay would change that. So if someone might be able to say that the decision should be stayed or on hold until the appeal process could be completed.
Thank you. Again, not something that we're necessarily contemplating in the bill, but what you're doing is just highlighting the changes, or excuse me, the differences between the medication process and the shock process.
Yeah, and I did, Kathy Flaherty talked about a case where my client, was successful on appeal, and it was a case where there was shock and a medication petition, and it was sort of a hollow victory,
Understood. Thank you very much.
Thank you.
Thank you, Mr. Chair.
Thank you, Representative Miko. No more. Thank you. When I get to you, it's like, all right. Thank you. Thank you. The next person on our list is Dr. Javed Sukhera. Welcome, Dr. Sukhera.
Good afternoon. Thanks so much for having me. So my name is Javed Sukhera. I want to address Senator Anwar, Representative McCarthy-Vahey, and all the distinguished members of the committee. I want to thank you for the opportunity to testify in support of this bill. I'm the Chair and Chief of Psychiatry, the Institute of Living at Hartford Hospital. I've been practicing in both the US and Canada for over a decade. And I want to just start off and tell people a little bit about ECT. We know that it's been stigmatized, but the reality is simple. ECT saves lives. It is not a first-line treatment. It is not used lightly. It is only reserved for rare and severe cases, things like intractable depression, catatonia. And what we're talking about here are cases where we need ECT because patients cannot eat, drink, or function. Without these interventions, they rapidly deteriorate, facing dehydration, malnutrition, and life-threatening complications. We also know that there is a difference of opinion. There's some misinformation out there, but ECT is supported by decades of rigorous scientific research. It's endorsed by several organizations, and it's undergone extensive review by the FDA and has been proven safe and effective in multiple trials. We are not here talking about taking anybody's rights away. We completely support and need to have safeguards in place. No one should be coerced into treatment, and every patient deserves a voice in their care. But we have to recognize what we're talking about in these circumstances are rare and extreme cases where individuals become so gravely ill that they cannot advocate for themselves, or they have already been appointed a conservator, which creates a different situation. And these are cases where we as a system work with families and conservators to try to get access to treatment that we think can be helpful, because the consequence of not giving the treatment is grave disability, grave harm, and we've seen this many times. The issue we're talking about is simple in scope. It's extending this from 45 to 50 days. I just want to give you a glimpse into sort of raw numbers and data. So out of all the patients that we do ECT for in 2024, only less than 6% actually needed a renewal of their initial order. So of the total number, about 25% required orders, only less than 6% required a renewal of that order. Less than 2% required ongoing renewals. So these are rare circumstances, but I want to walk you through why this is important to us. Because if there's someone who's not eating or drinking, and we're faced with arbitrary challenges, and in Hartford, I must tell you, we are faced with incredibly profound, difficult challenges in terms of the probate process that we struggle with. If that lapses, if that order lapses, that patient will go longer without getting access to the treatment. And we've seen circumstances where these patients have to be hospitalized medically because of their malnutrition or because of that deterioration. Oftentimes, this small subset of patients that this is harming, when we get arbitrary delays, are patients with cognitive problems, cognitive challenges, or they're catatonic, where they simply aren't able to consent. So really and truly, these are people who are so severely ill. Their families, we recognize ECT as their best chance for recovery, but we risk administrative delays. We're talking here about 2025. This is a reality of what we do. We take our job very seriously. If someone starts treatment and gets better, this doesn't apply to them. If someone starts treatment and they no longer cannot consent, this doesn't apply to them because they're better and they're able to consent. This applies simply to the sickest, most gravely ill members of our community for whom their families, many of them your constituents, are asking to not have one other hurdle or barrier that might hang up or impair their access to care. So I urge you to support this matter and ensure that those in desperate need of ECT receive it without unnecessary barriers or delays. We still want to support the probate process, the safeguards, the multiple checks and balances that I think must be in place, but for us, it's quite simple. Thank you very much.
Thank you so much for your testimony, Dr. Sukera. I wanted to clarify, I'm sure you heard some of the concerns that have been raised earlier. And I'm sure we are going to hear some of the people saying that they were awake when they had ECT. Tell me, what are the treatments? And then I think the perception people have from movies about what ECT is and what is the current electroconvulsive therapy, what does it entail? Tell me about anesthesia and the whole process. If you can help clarify that, please.
Absolutely. I'm just going to start and say that in addition to being the chief of psychiatry and a practicing psychiatrist, I also have experienced mental illness. There are loved ones that have experienced severe mental illness in my family. So I take my job and my responsibility very seriously. All of us take an oath that we will not and cannot cause unnecessary harm. And ECT as practiced today is incredibly humane. It is not anything like what people think it is. And really and truly, unless you see it or you talk to people who have experienced it, you have a sense of what it is. That doesn't mean that unlike other treatments, there aren't side effects. That doesn't mean that we're always trying to walk a tightrope of risks versus balances, which all of us do in healthcare every day. But the actual experience of what people are getting, and this is about 150 individuals in our facility last year, it is nothing like the misperceptions of the past. And every single due diligence step is taken to ensure that there's humanity and dignity elevated, because that is part of who we are and what we do.
Thank you for that. And I understand that there was this whole concept raised that if somebody gets it once, why should they need it again? And it's almost, and then maybe I'm not a psychiatrist, so it's almost saying that you took the pill for your medicine condition today, why do you have to take it the next day? Is that a fair comparison to be able to say that some people need it on an ongoing basis because there is cyclical pattern of certain diseases and you need intervention. So just because you got it once does not automatically mean that you are all set and cured forever. And it's the same thing that you take medicines every day or depending on what kind of medicine it is on a weekly basis.
Mhm. Yes, absolutely. So ECT is only used for the cases of people who have what we would describe as treatment refractory illnesses. All other treatments aren't effective. So we're already talking about a subset of individuals who have complex, severe, and persistent mental illness. Within that large group, like I said, most people, 75% of which are voluntarily consenting and getting better. The individuals who may not get better or who require maintenance or who require ongoing are often even further more complex within that group. And what we often see is comorbidities like developmental disorders, being elderly, or having a lower buffering capacity of the brain that affects how these treatments work. So in that small group of people that are the most complex of the complex, it's not something that just leads to immediate resolution of symptoms. It becomes something where maintenance treatments work. I will add that a lot of the patients and cases that I have that this matters to are people for whom it's already worked. They've experienced illness at other points in their lives, and there's documented evidence that they have had resolution of symptoms from ECT, which is why the case is even more clear cut when we go to the court for those orders, because we've already had evidence that it's worked for them.
Now, ECT is life-saving treatment. I'm just trying to look at it from another angle. And I'm not aware of a whole lot of other things that are FDA approved and life-saving treatments, which have such level of restriction in our laws in the state of Connecticut. And I can respect where the laws are coming from because there was abuse and people were not using in the right manner. Does that expose the healthcare systems to moral injury when they see that they are not able to provide the care that is proven and known scientifically to be effective, but the legal system and the delays thereof or the understanding of a probate judge perhaps is resulting in patient suffering?
It does. The moral injury is profound when you see someone and you know that they're not eating and they're not drinking, and you know that every day that goes by with that condition continuing is a day that you can offer that patient something that can help them, and you can't do it because of arbitrary or unnecessary delays. So that's certainly what we face. But to step back, we know that the language itself of shock therapy is stigmatizing. It's antiquated. It's called electroconvulsive therapy. There are many ways in which I think we can partner with disability rights advocates to make updates to statute. But today, we're really talking about extending that order for this small subset of patients. So at the end of the day, for us, we don't want to be in a situation just like the patients and families where someone's deteriorating. We know they're deteriorating. We know that's going to get worse. And this hang up with the probate court contributes to that kind of preventable harm.
I have just one more question, and I think the current law is making at least certain judges to think that the person has to be inpatient or be in certain circumstances, which is just creating a significant challenge for the well-being of the people in the greater Hartford area. Could you explain that to me? I could not understand that before.
Yes. So the current law is very clear that if someone needs a renewal of the order, let's say they were admitted as an inpatient, they no longer need to be admitted as an inpatient. They continue to receive the treatment as an outpatient. That you can get a renewal. That is consistent with the practice and precedent of colleagues and judges. However, in Hartford, our judge has a difference of opinion about the statute and will not currently grant outpatient orders, which means that we have to send patients elsewhere. Patients from Hartford are being arbitrarily experiencing arbitrary barriers to accessing outpatient ECT, which is a matter of grave concern for us and something we also need to address.
Thank you. I have my co-chair who has a question or comment. Madam Co-Chair.
Thank you very much. And Dr. Sakara, thank you for being here. And thank you also, as Senator Anwar said, to one of the previous folks testifying. Thank you for sharing your personal experience as well. And as I said earlier, I think we're all coming at this from trying to make sure that patients have the best access to care as possible, and have the opportunity to have their rights be heard. So just to clarify what you said earlier, of the patients that you see, only 25% of patients end up needing ECT. Is that, did I understand that correctly?
No, of
or-
the patients that we do ECT on, only 25% are patients that are court ordered.
Okay, thank you for clarifying that. I don't know if others heard that the same way I did, but only 25% of those. And of that 25%, less than 6% of that 25% require. I know I'm being kind of a stickler, but
No,
this
it's
is
important.
to the point of the numbers. It's 6% of those patients require renewal,
Correct.
Okay.
Renewal of the initial order.
and less than 2% require multiple renewals of
Correct.
that original 25%.
Those are all approximate numbers, yes.
Okay, yes, I know, yeah, okay. I think that the other issue, Senator Amor touched on it, I won't get into it, but I think, I said to Senator Amor, my father was an attorney, and I used to say, "You're not a doctor, Dad," and sometimes I will say to my physician friends, "You're not a lawyer." This issue obviously is one between doctors and lawyers, and you are referencing a specific situation where there is some difficulty. When you're going through that process on your side medically, what is the standard at the court? What kind of medical information is being asked of you as you make that petition?
So currently, we are mandated, not just from statute, but ethically and morally, to ensure that before we would recommend something involuntarily, that we make a case as to why the benefits of that treatment outweigh the risks. We also need to demonstrate that they have been, that this is sort of a treatment of last resort, that there are other things that have been tried, particularly other psychopharmacological treatments that have been unsuccessful. The other thing we often are demonstrating is that they have received the treatment in the past and have found it to be beneficial. And we do this, but also independent physicians, psychiatrists also have to assess the same questions.
And that is something that you do from your end. That's not the legal standard required on the court end. That's just the standard of practice, or that's, I think, what I'm.
We do our due diligence. Sometimes there are specific things that different probate processes require, which I can't speak to, unfortunately, but we do try to follow all this sort of recommendations and standards as per the interpretations of statute.
Thank you. And the last question is just very specific about the medical process itself. And Senator Amor and you had some conversation about this, but most of us are not physicians. Most of us have not experienced this or have not seen. And that same attorney father is someone who suffered from Parkinson's. So one of the things that I'm familiar with, not in a medical way, but just the DBS treatment for Parkinson's. So it's the deep brain stimulation.
Correct.
And I'm wondering, are there similarities here with that in terms of how that looks on a physical level and what that is like for a patient?
There are. In fact, DBS is actually far more invasive because it's a surgical procedure that requires, further degrees of anesthesia and actually making an incision. So in many cases, other types of surgical treatments are even more invasive and carry different kinds of risks than ECT, where no incisions are being made.
Thank you for that. Thank you, Mr. Chair. And
Yeah, Representative Claire DeStitro, followed by Senator Marks, and then Representative Zupkus.
Thank you, Mr. Chair. Thank you for your testimony today. And I say often that we need to bring this down to a fourth grade level for explanation to the non-medical personnel in here. So I apologize if I'm asking you to repeat something. But I think part of the issue, this is more of a probate issue, but also we're trying to get background on the effects of ECT and what it does. And we know that it's been a huge shift from what the practices were 20, 30, 40 years ago. So to that point, can you try and explain to us briefly what the process is to someone that's getting ECT, and have there been any people that have expressed they've had any pain or sensation from these therapies at this point? Because I think that's a big concern with a lot of people, that they're having this shock therapy and they're just awake during it, and it's the way it was, 30, 40 years ago, and people are just traumatized from the experience and not, even though it may be helping, they're still traumatized from what they went through.
Yeah, so essentially ECT is only recommended for someone where everything else has been tried and it hasn't worked. Someone's experiencing a high degree of suffering that's impairing their ability to function, getting in the way of their access to happiness and health. It's either recommended if they can consent to it voluntarily and they have the right to decline, and that's it. Out of all of the times that we're doing ECT, like I said, about a quarter of those cases, we do go to court. Amongst the cases that we're going to court are a mix. They're a mix of people who cannot simply consent because they might be catatonic or unable to consent, and people who have already been conserved. In those cases, legally, because they're conserved, we cannot even allow the conservator's signature to be consenting for ECT because of the way the statute is written. Once someone actually gets access to the treatment, it takes place in the basement of our inpatient building. We also do ECT for other hospitals and facilities in the state. It is a suite where there's prep rooms with curtains like one would see in an emergency department. During the actual procedure, all steps are taken to ensure that those things that you described would never happen. If there's any risk of the patient experiencing the seizure, the physical consequences of the seizure, we would not proceed with the treatment. Present is a trained, certified psychiatrist who has additional training to be able to provide the treatment, as well as nurse and paraprofessional staff, and a trained anesthesiologist to ensure that the patient's anesthesia is appropriately titrated. Once the treatment is completed, it's very brief. The patient is taken to a recovery area where they have a chance to relax and recover, and then they're moved on from their day. We usually do it 3 times a week, and patient and treatment schedules vary.
And thank you for that explanation. And are they fully sedated during their treatment?
Fully sedated to the degree that they are not aware and conscious of what's happening. Yes. But there's degrees of sedation that I don't want to confuse people about. But
Right.
yes.
Okay. Thank you so much for the explanation. Thank you, Mr. Chair.
Senator Marks and then Representative Zupkus.
Doctor, for being here today. So I think anybody's in the healthcare field that works with people with mental health diagnoses will say that they've met patients before that have said that ECT changed their lives, that nothing else worked, and it is what got them out of a terrible, terrible depression. And some are now living, normal, very happy lives. Would you agree with that?
Yes.
Yeah, me too. So in your practice, have you ever had to go get a court order with somebody and then afterwards they thanked you for doing it? And, as opposed to anybody that after you got a court order was still furious that they had to have ECT?
That is correct. 100% of people who've provided feedback about the treatment since I've been in my role have thanked us for helping them.
Yeah, that's what I thought. That's awesome. Thank you so much. I'm sure it's very hard to have to go to court to do this, and that, you took an oath and you certainly wouldn't do it unless you absolutely had to.
Thank you.
Thank you. Representative Zupkus.
Thank you, Mr. Chair. Both of my questions have been asked. One was about the numbers. And so when you get down to the 25%, and then it's 6%, I think you said. This bill is for a certain percentage of the 25%, or is it in general, you need more time to get through the court system? That's what I'm.
Yeah, so part of why I didn't become an accountant is perhaps I don't explain numbers as well as others should. So let me actually try to give people a different angle. Out of 150 patients, who we do ECT on, only about 40 of those patients require court-ordered ECT. And a total of less than 10 out of the original 150 require renewals of those orders. Less than approximately 2 to 3 of the 10 require multiple renewals.
So the moving of the time is for renewals. I guess that's my question.
Correct.
It's not for
correct.
just somebody who needs it and you have to go through the court system. It's for renewals or somebody who needs it multiple times.
Correct, because it's initially a 45-day order, and that means that the vast majority of people do get better enough within those 45 days that we don't need to go back. Or in some cases, those patients are able to consent,
Right.
and then they elect to choose to continue, therefore not
And
requiring.
you don't have to go through court for that.
Correct.
My second question, Representative Claritas Ditria asked, but I need it broken down a little more because I am certainly not a doctor and I am on a 4th grade level. So, you explained about going in the curtains and all of that, but what exactly happens?
The best way to understand what happens is ECT involves inducing a seizure. And a seizure is a large volume of electrical charge. Seizures can occur naturally for people who have epilepsy, and ECT is simply the induction of a seizure. So we give a stimulus to give a seizure, and then the seizure itself is part of what leads to the treatment to happen.
Your mic is not on.
I thought it was and off and on. I've been hitting. So you're inducing a seizure to help their mental state to get better.
Correct.
Okay.
Yes, the induction of the seizure is the treatment for the condition.
Okay. And this is a silly question, but you've mentioned it a couple of times that people not eating or drinking. So is that when you decide to use this? Like, what is the mark to say, okay, we've done all this, it's not working still, but now they're not eating and we have to do this?
Yeah, so there's a list of specific indications that are disorders or conditions that we know ECT can be beneficial for. That list includes things like severe depression, severe psychotic depression. It also includes most commonly a condition called catatonia, which is largely related to severe depression, but can have other kind of causes. It's that condition of catatonia when someone's completely immobile, unable to move, eat, or drink that I'm referring to. And those are the specific clinical circumstances where we find these 45 versus 90-day distinctions actually make a medical difference for the patients.
Understood. Thank you so much.
You're welcome.
Representative D'Amico.
Thank you, Mr. Chair. I appreciate the indulgence. So thank you, Doctor, for coming to testify. So I just wanted to clarify one or two things. Do I understand correctly from your testimony, and I believe the testimony of others previously, that there's a distinction or there's a difference when it comes to involuntary medication versus involuntary ECT treatment? That in the case of involuntary medication, that the patient is allowed to have a conservator to speak on their behalf, whereas when it comes to ECT, they are not allowed to have a conservator to speak on their behalf?
So I can certainly agree that there is a difference. What you described is consistent with my understanding, but I lack the legal expertise to get into the nuances. What you described is consistent with my understanding.
So just as a suggestion to try to solve what seems to be a little bit of a thorny problem here, and that's why we have this bill in front of us, would it not make more sense to change the statute to allow for a conservator to speak on behalf of someone who is subject to ECT?
So I think in some senses that makes sense, but we're also trying to balance the safeguards for the patient themselves. So I think in an oversimplified way, yes, if the conservator could consent for the ECT, that wouldn't require a probate process because the conservator would actually sign and that would be sufficient for us. We also want to make sure that this is all done right and goes through due diligence. And I would say, to step back from everything, right now, ECT itself And psychiatric treatment is subject to a double standard compared to other treatments in medicine. So I think there's broader need for statute reform because the way that the statute is currently written, we're making a lot of psychiatric treatments much harder to get than other types of medical treatments.
So if I may, one more question, Mr. Chair. So I'm looking at, thank you, Doctor. I'm looking at the testimony from the National Alliance on Mental Illness. And towards the end of their testimony, they're talking about these time limits, which is what we're contemplating in the bill that's in front of us today. And it says, quote, "These time limits have been in place for decades and work. There are ways to ensure that in the case of maintenance shock therapy, that hearings are timely requested and scheduled so that treatment does not get meaningfully disrupted," unquote. Would you agree with that there are ways to get around this?
Unfortunately, those ways are not working in 2025 in Hartford, Connecticut. And so we have found circumstances where we cannot get access to timely care because of challenges with the probate court process itself.
Thank you. Thank you, Mr. Chair.
Representative Zupka, second time.
Thank you for the second and last time. Not today, but just right now. Thank you. You mentioned Hartford and the trouble with the probate court because you actually, I think you said, I don't want to put words in your mouth, but specifically there was a judge that hinders, I guess, this, or you mentioned a judge, a probate court judge. Is this just a Hartford issue?
We in Hartford have experienced some challenges with interpretations of statute that we continue to work through legally with our probate court judge. That is our experience in Hartford. From our knowledge with our peers, there's no other jurisdiction in the state where such challenges are being experienced.
So it is a Hartford issue. Thank you.
Senator Summers.
Yes, good afternoon, and thank you for your testimony, Doctor. I just would like to share that I have experienced the process, not myself personally, but with a loved member who was in Hartford and a hospital. And I can't tell you how life-saving ECT is. This is a person who was not eating, not drinking, catatonic, and after having ECT, it to me literally was like resetting a computer, and the person was able to, move forward and then live a, long and happy life. My question is, I'm hearing about the probate court and the need. How does somebody who's in that state even consent to ECT if they don't have a loved member, family member to be able to, be a healthcare advocate for them? I'm assuming they would go to the probate judge to make that happen. And I can see when somebody is not eating and they're not drinking, timeliness is critical. And I was wondering if you could speak to that process. Some folks that are in that condition have a family member, have a medical advocate or a healthcare advocate. Could you speak to that? Because I can see how that would be very difficult to go to a probate judge who may not know the nuances of what's happening and how timeliness is of the essence. I would love for you to speak to that, please.
Yeah, so really and truly, if there is the capacity for someone to consent, then they are consenting. But we don't have to go to the court unless there's severe impairment that the individual can't consent. So for example, if someone is catatonic, let's say, we have to file paperwork, we have to have a hearing, the judge has to agree to schedule the hearing. The judge can't just cancel the hearing and move it arbitrarily to a week or 2 weeks away, because unfortunately the timelines of the probate court process don't align with the medical needs and the necessity of the patient. So that's where some of the challenges come into play in terms of filing the paperwork and getting the hearing itself.
And have you, if I may, with a follow-up question really quickly, have you experienced a delay that has negatively impacted the patient's health and outcome because you could not schedule this hearing in a timely manner?
Yes. There have been circumstances of that nature.
And what happens to a patient who's in that condition, who's catatonic, who, is not responding, not communicating, not eating, not drinking, and you can't get a probate judge to release the authority to have some ECT. And it's my understanding that ECT is done, in waves. So you might have, do it Monday, Wednesday, Friday. You're always checking to see if there's an improvement, et cetera. But what happens to the patient who's in that state, other than continuing to decline? What happens to that patient? And how long has you had experience with having to go back to a probate judge or go back to try to schedule a hearing? Meanwhile, the patient is suffering. I think that's important for us to hear.
Yeah, so if we can't get access to the treatment or there's a lapse in the treatment because of a delay, then that's where the deterioration happens, where at times patients then require either coming back as inpatients if they've already been outpatients, or if they might be psychiatrically hospitalized, that they require medical hospitalizations because of the physical effects of not getting access to the treatment.
Thank you very much.
Thank you, Senator Summers, for your questions. Representative Reddington Hughes.
Thank you, Doctor, for coming here and informing us of these things. And my question has to do, because it seems that we're talking about the time frame here, the 45 days, the 90 days. In your opinion, when a patient is receiving the ECT, if this procedure is going to be beneficial to them, will you see a positive direction that they're going into within those first 45 days?
In the vast majority of cases, yes.
Would you see any value then to require that this would only apply to patients who were seeing a positive value as far as the extension of the 90 days?
So essentially in the current practice, it already does,
Mhm.
because we wouldn't necessitate going back to court or going through the probate process if the patient continues to do better.
So in the event that they were not doing well, this would not pertain to them.
If they were not doing well, it would pertain to them, because that's where the functional sort of the reality of this unfolds is if someone in most cases gets ECT, does better, they either continue ECT voluntarily or they no longer need ECT. The subset of that group are people who aren't doing better, where there might be some response but not enough of a response, and they require clinically to continue the treatment.
So even in that subset of people who were seeing a small response, the response would be a positive response.
It's difficult to say because it's not universally that it would be a positive response. In some cases, there may not be any response, but because the patient has responded in the past, there's reason to believe that ongoing treatments will continue to benefit them.
So correct me if I'm wrong, this really would be to cover the people that perhaps would not be automatically approved for an extension. And in this case, now they would be.
I'm sorry, there may be just a misunderstanding I have of being able to answer your question properly. So could you repeat what you're asking?
So in the past, if a patient was not responding positively to ECT and they went to the court and they did their 45 days and now they are going back to the court to extend this for another 45 days, if that person was to go, through the court system, it would not be an automatic that they would extend this ECT therapy, correct?
Correct, it wouldn't be automatic.
But now with the 90 days, it would be.
If they still needed it by that time. Because it's very possible and often likely that by 90 days, they don't need it anymore. That's also the circumstance that could take place.
Okay, thank you.
Actually, can we have, yes, Representative Gilchrist first and then Representative D'Amico.
Thank you. And and thank you. This is helpful to follow up on what was just being asked in saying when they go to the court. In looking at the statute, this in no way changes the fact that a head of a hospital and 2 qualified physicians would have to sign off on this should the patient not be able to do that themselves. Is that correct?
Correct. That would stay the same.
And so after having the head of the hospital and 2 qualified physicians sign off, again, for the person who cannot do it themselves, this proposal before us is saying that that authorization would be in effect for 90 days.
Correct.
Okay, thank you.
Representative Miko.
Thank you, Mr. Chair. And I have to thank my good colleague, Representative Gilchrist, for asking that question because it's a good segue to my question, Doctor. I believe we heard earlier from someone who testified before you that when it comes to this determination of being able to give informed consent, it was suggested, and correct me if I'm wrong, but what I heard was that that there's a possibility that if a patient agrees with the medical personnel, then he or she is deemed qualified to give informed consent. But if the patient doesn't agree with the medical personnel, they are sometimes considered to be incapable of giving qualified consent. Would that comport with your experience?
It would not comport with my own personal experience as a psychiatrist, because that's not how I practice psychiatry. However, I will recognize that historically, there has been harm perpetrated by psychiatry, and historically there have been cases where coercive harm of what was shared has been real. And I think that's something for us to recognize and honor, but it has not been my own experience as a practicing psychiatrist.
Okay. Thank you very much. Thank you, Mr. Chair.
Thank you. I just wanted to also clarify, in the various conferences, national conferences that you're part of or groups, are you seeing similar pattern in other states, similar laws in other states? Is it as complicated in other states as it is in Connecticut?
There are many states where it's less complicated.
Okay, this is very helpful. Thank you. Oh, Representative Daphne, followed by Michael Chair.
Thank you, Mr. Chair, and thank you for being here today. I'm trying to visualize someone who doesn't want treatment, but it's ordered anyway. Are they tied down to a bed and forced to have it? How does that look? I'm just trying to visualize how that plays out.
So I can't really speak to what that looks like because typically someone isn't going to be forced down in the way that you described. The cases that I'm speaking about are cases where individuals are unable to consent to treatment, or that they wish to consent, however, because they need a conservator, they require a court order.
So what you're saying is they're unable to consent and they need someone to consent, yes. But if they're unable to consent, and someone says yes, I'm just still trying to visualize how it's forced for someone who might not want it. They're unable to consent, so someone has to make that decision. So someone's making the decision for them.
Yes, when someone is that gravely ill, then we are, in those circumstances, as a society, their family, the doctors, and the state are acting and presenting to the probate court a recommendation that they believe is in that patient's best interest.
A conservator. Okay, thank you. Appreciate it.
I think Representative Daphne was probably maybe, I'm trying to picture that people are 5-6 people are holding somebody just like in the movie, and you're holding them down and putting something and just like, and the person is screaming and yelling. That's not the reality. That's a good movie, but it's not a good reality. So that's the important thing, because that mindset in the larger society is that what you're asking for is to hold people down and then give them electric shocks so that they would get better, and they're yelling and screaming, "Don't do this to me." That's not what's happening.
Correct.
If
That
you
is
can just
far, 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 far from the reality of how this is happening.
Thank you. It's almost like when somebody goes for endoscopy or colonoscopy, right? They get anesthesia and they wake up and they actually already had the endoscopy and colonoscopy. That's the anesthesia and the general anesthesia that happens. What happens in between, you don't remember, thankfully. But that's in the same way in the ECTs as well.
Correct. They're sedated.
Thank you for your time. This was very helpful. Thank you.
Thank you, everyone.
I wanted to see if Sonia Hernandez was here because you're listed as being remote, but you're not remote. And not seeing you there is Eric Loff over here in person. Not seeing you. Well, next is Mr. Burr, Thomas Burr. You're on. Welcome.
Yes, thank you, Senator Anwar, and good afternoon, Representative McCarthy-Vahey and members of the Public Health Committee. My name is Thomas Burr. I'm the Public Policy Manager of the Connecticut chapter of the National Alliance on Mental Illness, otherwise known as NAMI Connecticut, and I am testifying today in opposition of HB 6837, an act extending the authorization of shock therapy by a patient's written consent or probate court order. For any of the new legislators on this committee, NAMI is the nation's largest grassroots mental health organization dedicated to building better lives for the millions of Americans affected by mental illness. NAMI Connecticut and its 9 local affiliates provide support groups and education programs for people with mental health conditions and their loved ones, provide public awareness events and activities to communities throughout Connecticut, and advocate for policies to improve the lives of people affected by mental health conditions. So if you're interested in more information about NAMI, I did include that in my written testimony. So regarding HB 6837, the bill's stated purpose, as we've all been discussing here, is to extend the authorization of shock therapy by a patient's written consent or probate court order to 90 days from the current 45. You've already heard from Kathy Flaherty from the Connecticut Legal Rights Project and Gina Texiera from Disability Rights Connecticut, who have both most eloquently laid out the argument against this change. I echo their thoughts and concerns about this issue, and frankly, as a parent of a special needs adult child who has a seizure disorder, I naturally recoil at any practice that would deliberately induce a seizure. There was just an article in the Hartford Courant 2 days ago on the sudden unexpected death in epilepsy, which for me was very concerning, and I will email that link to that article to the committee clerk. Hadn't anticipated putting it in my testimony. But in any event, kind of the bottom line for all of this is, while, you know, I certainly and sincerely appreciate and respect the medical perspectives on these treatments, we should not diminish this 45-day safeguard for the sake of convenience. These time limits have been in place for decades and work, and I appreciate Rep. D'Amico referencing my testimony before I even gave it. I'm very sorry to hear that here in Hartford, anyway, that this might not be the case. But I don't think the solution to that problem should be set in state statute. Therefore, I strongly believe that for the majority of people subject to shock therapy treatment, the existing time limits are an important protection and should be continued. So therefore, NAMI Connecticut, we oppose the passage of HB 6837, and I thank everyone for their time and attention to this very important topic. Thank you.
Thank you so much, Mr. Burr. Can I clarify some of the things in your testimony?
Sure.
Are you equating electroconvulsive therapy for people who have epilepsy? Because that's not accurate.
Well, no, I'm saying that the treatment, as I understand it, induces a seizure. And seizures are very concerning.
I think we have a bill on SUDEP, which we will probably hopefully have an opportunity to talk more about that, which is the death associated with the seizure disorder, but that's epilepsy, but that's a different condition and different thing completely, and it's could not be equated. But that's I just wanted
and you're
to.
a doctor, and I'm not, Senator Anwar, so I will defer to you on that. I just, again, I've had personal experience with watching my daughter have seizures, and it's horrifying.
And so can I help understand? So NAMI's position is that you're advocating on behalf of the patients
Yes.
with mental illness. And now we are looking at some of the most difficult patients with respect to their health issue, the mental health issue, that they're catatonic to the point that they do not move. And if they're unable to move and they're unable to eat, they're unable to drink. And what would NAMI say for that? What would NAMI's position be? To do nothing, or?
No, I wouldn't paint this as a binary thing at all. I just think that having the protections provides a balance, to the civil rights. And again, that's why I refer to Kathy and Gina's testimony, because I am not an attorney. And when we get too deep in the weeds on civil rights stuff, I'm out of my element. I'm a parent and a caregiver and someone who's done a lot of reading on mental health, but I'm not a doctor and I'm not an attorney. So when I have people who I respect, like the people from Disability Rights Connecticut and the Connecticut Legal Rights Project, saying that this extension of a time limit is potentially not great for protecting someone's civil rights, you know, we're certainly as an organization concerned with that. I'm not saying that, you know, ECT doesn't have a value for anyone, but I think it should be treated very seriously.
No, I did not. I don't know how to ask this, but it probably should not. Okay. I wanted to perhaps, how many catatonic patients have you seen in the circumstances that you're aware of?
I'm not a doctor. I don't see patients.
But in your advocacy work, have you been able to interact with the situation where somebody's catatonic?
No, I would not be in an environment like that.
And if they were unable to give consent and the conservator was unable to give consent and they have to have the ECT treatment for their life saving or saving their life, you are suggesting that 45 days is very lenient and it's okay to help that family continue to live in that situation and survive with all the difficulties of a complex person who's barely living without that treatment, to just keep waiting for the probate court to make the decisions on a very frequent basis. You think that's a fair thing from NAMI's perspective?
Again, as I understand it, that this process seems to work okay, except in Hartford. So that's why I added to my spoken testimony what wasn't in my written testimony, because I've been learning a lot in the course of this hearing. It sounds like this is just a problem in Hartford, and maybe, you know, changing the law for the entire state is not the route we want to go here.
Thank you so much for your testimony. Thank you.
You're welcome.
Next person, I think, is number 11, number 10, Sonia Hernandez. You're here.
Yes, I'm here. And
Oh,
soon,
you're here. Okay, thank you.
and soon. Hi. Thank you. Dear Senator Anwar and Representative McCarthy, Valley, and esteemed members of the public hearing, thank you for the opportunity to be here. My name is Sonia Hernandez, and I am a resident of Bridgeport, Connecticut, and I a community organizer at Make the Road, Connecticut, and also part of the Health Equally for the People by the People Coalition. And I'm here on support of the SB 1192 and act concerning a hospital financial assistance. I work directly with community members and I hear daily their stories about, you know, medical debt that cause in their life and how this impact our community and their families. This is impact our community, not just, you know, emotional, but also economically. And I have been, you know, how this program can benefit our community and, you know, to have a better financial policies that can help our community and prevent, you know, the care that they need, also known as charity care. This will be reduced. Frequently, the medical debt will help people to benefit and receive the need that they deserve and also be more eligible for different programs that there is, like the financial assistance program. This will prevent our community members, you know, to ending on collections and have, you know, that they don't have insurance, because also we have members that they have insurance, but they has to be, you know, co-payments, or they can afford to go to the doctor, but they cannot afford to continue the treatment because they don't qualify for the requirements that they need for financial programs, or also they have to be in the waiting list until they qualify or they receive the letters that they disqualify for POSCI, for they can show that they don't qualify for the state insurance. So many of our residents, they are suffering some mental health and also emotional because they are ending on collections or they are receiving so many letters or terminate letters from the mail or from the hospital that they have the amount that they need to pay the bill, or they don't qualify because they don't have enough requirements. This is a lot of daily stories that we hear with members of the community that they apply for financial programs, but they don't have insurance, so they don't have enough documentation to show up that they can receive the financial program. Also, some family, they have to choose between continue paying the bills or pay the utilities or provide for their family. This is really heartbroken hearing the stories daily of families that they cannot afford going to the emergency room because they don't want to receive a bill. It's unfortunately that we don't have a program that it is equally and equitative for all our communities or residents in Connecticut. Thank you for the opportunity to testify in the SB 1192. And also I urge the committee to pass this bill and recommend additional language of the SB 92 to help all residents in Connecticut and the families in the hospitals so we can have a universal application or training for people that they can have different resources or programs that they can, inquire and apply for financial assistance. Thank you so much. Sonia.
Thank you, Ms. Hernandez. Thank you for your testimony, and we hear you loud and clear. So I think what you're saying is that individuals' medical debt will be reduced if this bill passes. The likelihood of individuals having to declare bankruptcy will decrease if this bill passes. Is that a fair understanding?
Yes, and also because this is really hard that we don't have a program that will help us and support us to prevent, debt, and also the economic and emotional programs that they have, because so many people that they not able to go to the clinics or have a primary doctor, they ending going to the emergency room.
Thank you so much. I see no other question. Actually, we have a question from my co-chair, Representative.
Ms. Hernandez, I just want to say thank you to you for your work and certainly the work of Health Equity Solution. And I just wanted to confirm you reference additional language. Did you say Senate Bill 292? Is that correct?
Yes, 1192.
No, okay, gotcha. You were referencing our bill. Got you. Okay. I just want to say that this has been a long conversation and one that we're probably going to need to continue to have for the years to come because the issue is so enormous and has impacted so many people. And you did a great job really outlining that for us and what it means for members of the community. And I want to thank you and everyone else who has been part of this conversation and commit to all of you that I, for one, and I know this committee will continue to engage in this conversation for as long as we need to be able to make sure people have the healthcare access that they need. Thank you, Mr. Chair.
Thank you. Seeing no other questions, thank you so much, Ms. Hernandez. Muchas gracias. Next is Faiza, Dr. Faiza Hussein. Are you here or online? Not seeing you there. The next person I have is Jason Privilege. Jason, you're on. Welcome.
Thank you. Thank you for having me. Good afternoon, Senator Anwar, Representative McCarthy-Vahey, and all the esteemed members of the Public Health Committee. I am Jason Privilege, and I thank you for the opportunity to speak before you today. I live in Fairfield and work at St. Mary's Hospital in Waterbury. Today, I represent the Connecticut Academy of Physician Associates as a past president and current chair of the Legislative Committee. However, I also currently am serving as president and chair of the board of the American Academy of Physician Associates, which is one of the sponsoring organizations of my primary area of testimony today, HB 6835, an act adopting the Physician Assistant Licensure Compact, of which I am supportive of. Recognizing the need for increased access to care and the much more traveled world we live in, this compact was released in early 2023 for legislative passage across the country. Since then, we've seen 13 states already adopt the compact, with at least 15 expected to introduce the compact to their respective legislators this year. It has been widely supported in the states where it has been introduced thus far, and we appreciate this committee's willingness to hear more on the topic. Licensure can vary widely among states in what is required and the length of time for final licensure approval. This compact utilizes a mutual recognition model, so that a license in one compact state will then be recognized in all other states after a request for a compact privilege has been placed by the PA. This process can be then completed in just days or even hours, instead of the months it may take under the normal licensure process. It is important to note this compact protects the sovereignty of the states. Regardless of where licensure is held, a PA with compact privilege granted in Connecticut is bound by Connecticut practice requirements. As well, other areas such as compact fees are determined by Connecticut, and there are provisions to ensure that disciplinary issues are not hidden when occurring elsewhere. As a PA practicing emergency medicine here in Connecticut, I can attest to the importance of such a compact. My own system crosses state borders, as do other Connecticut health systems, and it would improve access to care by having a simplified way of obtaining the ability to practice across borders. As well, for years, we're able to more efficiently and effectively provide mental health services in my own location by utilizing virtual health services. Quickly integrating providers for such services is immensely improved through the use of such a compact. I would also like to draw attention to HB 6834, which revises areas of DMHAS statutes, and HB 6838, which is a bill on substance use treatment access. I'd like to respectfully request fully integrating PAs and APRNs into these two bills. HB 6834 speaks to the composition of the Connecticut Alcohol and Drug Policy Council. My ask is to amend lines 188 and 190 to also include PAs and APRNs as considerations for the council, as we care for patients daily struggling with substance use disorders and are passionate about the care we provide and have significant expertise to offer. By broadening the pool of candidates for the council, it ensures that there will always be qualified healthcare professionals available to serve. Related, as I pointed out, PAs and APRNs work with patients daily that use various substances who seek treatment. HB 6838 excludes PAs and APRNs from the ability to certify that patients as eligible for treatment for their disorders, despite caring for them on a daily basis. I've indicated in my written testimony where exactly we ask to be included, but they are lines 17, 22, 24, 30, and 31. Inclusion of PAs and APRNs into these lines will absolutely help increase access to care for our patients that are in need of such services. In general, I just ask that PAs and APRNs be included in areas that speak to physicians authorizing services and care for patients, as doing so only ensures that our patients have less cumbersome journeys to fulfilling their needs. I've submitted written testimony on all three bills with more detailed responses, and I thank you all for your time and for your work in improving the health of those around us. I'm happy to answer any questions.
Thank you so much for your testimony. I think Representative Kristen McCarthy has a question or a comment.
Thank you, Mr. Privilege, for being here, for your constant work in advocacy, and for your help with the Physician Assistant Compact. And more just a comment, we in this committee have consistently engaged in passing compact language each year, and this is a priority for us this year in the committee, and we're grateful to work in partnership with you to hopefully we can help make that happen. Thank you, Mr. Chair.
Thank you, Madam Chair. Seeing no other comments or questions, thank you so much for your testimony. And
Thank you.
to the next person on our line, which is Dino Varelli. Mr. Varelli, thank you so much for your patience with us. Welcome. I know what you're going to talk about.
What gives it away? Thank you. Thank you, Senator Anwar, Representative McCarthy-Vahey, Senator Summers, Representative Clarice Dietra, and members of the committee. My name is Dino Varelli. I'm the founder and CEO of Project Purple. I reside in Beacon Falls with our office in Seymour, Connecticut. Since starting Project Purple 15 years ago, always based in Connecticut, we have grown to become one of the top charities in the world for pancreatic cancer. We have worked hard towards our mission of a world without pancreatic cancer by supporting patients and families with financial aid assistance. Since inception, we've helped over 1,500 families nationwide and paid lenders and debtors of families over $1.5 million in financial aid grants through our programs. Additionally, we've invested over $4 million of clinical research to some of the world's top organizations fighting for early detection and curative treatments of pancreatic cancer. Most recently, we made the largest grant in pancreatic cancer research in the state of Connecticut in the fall of 2024 to Hartford Healthcare for $750,000, which will be used for what will become the state's largest high-risk screening and surveillance program for high-risk individuals in Connecticut. I'm here today in support of Senate Bill 1191, an act establishing a pancreatic cancer screening and treatment referral program. How I got involved in Project Purple is I lost my hero and my role model, my dad, to pancreatic cancer in 2011. My dad was actually originally diagnosed in December 2008, but early detection would have most likely made a big difference. He was misdiagnosed for up to a year with various ailments and symptoms related to pancreatic cancer, lower back pain, weight loss, loss of appetite, depression, gallbladder removal, and eventually jaundice. And even though my dad was a surgical candidate, only 1 in 5 are because of most are late stage diagnosis. The reoccurrence rate for pancreatic cancer is also 44% post-surgery. I started Project Purple to help families going through the pancreatic cancer journey and to keep a promise I made to my dad that no other family will experience the hell we experience with this disease. Pancreatic cancer is the least funded cancer of all the major cancers in the United States. It receives less than 2% of the NIH budget for clinical research. In terms of survivability, nationally, pancreatic cancer has the lowest survival rate of all the major cancers at just 13% for the 5-year survival rate. Here in Connecticut, it's actually number 2 for cancer deaths. According to the American Cancer Society Cancer Facts for 2025, pancreatic cancer will kill 610 men and women in Connecticut. This is second compared to lung cancer. Those numbers are grim and unacceptable. More can be done here at the state level with proper support. In the past 5 years, the advances made, in particular in genetics, are promising and hopefully hope for the future. We now know that up to 10% of the cases nationally are attributed to some sort of genetic mutation. There are also treatment protocols recently used that not only provide high quality of life, but also in some cases, complete elimination of the disease. Screening saves lives. We've seen this in multiple cancers from breast to colon, where the screening modalities have allowed survival rates to go up because of screening high-risk groups. In 2017, we helped establish what at the time was the first high-risk screening and surveillance program for pancreatic cancer in Nebraska. To date, over 800 high-risk patients have been enrolled in Nebraska. Over the 6 years, 10 stage 1 cancers have been found. Not all pancreatic cancer, 2 of which were pancreatic cancer, but breast, melanoma, colon. But these patients had a much different outcome because these cancers were diagnosed at stage 1 versus later stage cancers. Similarly, in 2009, we helped establish the PRECEDE study with initial investment of $1.25 million, which has grown to become one of the largest high-risk screening and surveillance programs for pancreatic cancer with over 7,000 patients from over 20 centers worldwide.
Excuse me, Mr. Vernelli, but your time is up. Thank you.
Nice. 2 cents a statute for this office.
Would you be able to just finish your testimony?
Yeah.
Just going to ask you that question.
All these high-risk screening and surveillance programs have adopted what the NIH now has directed as common procedure, rotating from EUS and MRI imaging every other year, along with routine blood draw. As a BRCA2 patient, I know there might come a day when I might be fighting one of these associated cancers. Screening saves lives. We all know this. I'm not going to wait for when I have this cancer that took my dad and so many too early. We have the ability to make a difference. I might have the knowledge and the ability to do so because of my experience, but what about those who don't? We have the ability to help those in Connecticut that are at high risk and eventually everyone fighting this evil cancer. Thank you for listening to my testimony today. Senate Bill 1191 is a life-saving proposal, and I'd be happy to answer any questions you might have.
Thank you so much for your testimony, Mr. Varelli, and I'm so sorry about your loss. And that's one of the finest way to honor your father, by trying to save more lives. So I appreciate you being here and appreciate the work you're doing. Thank you so much. And I think my Representative Claire DeZitra had a question or comment.
Thank you, Mr. Chair. Thank you, Dino, for being here today. Dino is a new neighbor of mine in the lovely town of Beacon Falls and has an office in my old hometown of Seymour. So thank you for being here today. Thank you for your strong advocacy in this obviously very important screening tool with pancreatic cancer. What have you done, or what do you plan on doing as far as partnering with non-government organizations?
So we're trying to work with everybody here in state. And I think Connecticut is very unique We have a couple of healthcare systems and some that are in all communities. So I think from a nonprofit standpoint for us, it's really important to partner with everybody. And those are the folks in Hartford, in New Haven, in Norwalk, who are at this day in, day out, as I say, on the front lines. And I think there's something really unique here in state where we do have the ability to get into all the communities, and really support those patients that eventually will go through this disease. So a lot of our work is with working with the teams, the GI teams, even the folks, because our goal is to get this cancer early. So work with the inherited risk teams, the folks that are dealing with other cancers that align with pancreatic cancer. For example, BRCA. We know that the BRCA gene is responsible for pancreatic cancer. We know that BRCA is very prevalent in the breast cancer family. Connecticut has a long history. My mom's a 2-time breast cancer survivor. My office manager is a breast cancer survivor. So we know that Connecticut has a long, long history with breast cancer and a very high prevalence of breast cancer. So working with groups that are invested in that germline, in the BRCA space to bring awareness for pancreatic cancer within those groups all over the state.
Thank you for that explanation. And to those of you in virtual land, if you don't know a lot about Dino's organization, Project Purple, he's constantly everywhere in Connecticut and across the country doing fundraisers. I was fortunate enough to be able to participate in a pickleball fundraiser. But there's so many ways that people can get involved in this amazing organization. And I encourage everybody to take a look and have a conversation with Dino, and hopefully we can get this across the finish line. Thank you.
My co-chair has a question or comment, followed by Representative Reddington Hughes.
Thank you, Mr. Chair, and thank you for being here with us today. So one serious is that pancreatic cancer is touching more and more people's lives. This week, I have a neighbor and friend who is struggling tremendously in their journey. But also one maybe more frivolous comment, and it has to be said, your suit is just absolutely fabulous. So
Thank you.
it's a great representation and reminder of the purple for pancreatic cancer. Thanks.
Thank you.
Thank you, Representative Reddington Hughes.
Oh, first, I'm going to say thank you for all the work that you're doing. I had a mother that succumbed to breast cancer at 49, so I absolutely value the work that you are engaging in. My, shock is that this is the number 2 cause of death in the state of Connecticut, which I'm sure is like a whole conversation for another day. But obviously, what you're trying to do with the tracking and following, is that going to be reported statewide, or will that be a national reporting?
That's a great question. I hope this bill that we do have statewide and I know Dr. Shipper spoke earlier, there's things in place. And I think this is what is so exciting. I've traveled all over the country giving out research grants to many amazing cancer centers, and to be able to do this here in state, I think there's really some things that are really happening, but we need help. With our relationship with Hartford, Yale has a program, Norwalk has a program, which is now Nuvance, but covers Fairfield County. There's really some things in place, and maybe part of what this bill could be is to establish a state registry, whether that's with the Department of Health or through another NGO possibly, or with a group of NGOs that potentially, could be the repository for the data. But I think that's a great idea. And I think another piece to this is just the awareness piece of letting people know. I think a lot of people don't know. Again, my mom's a 2-time breast cancer survivor, and I look at breast cancer, even though we don't want to compare ourselves to breast, but they made amazing strides. And I believe that's a reason why my mom is here today still. So I think there could be a lot that could be done on the awareness piece.
And a quick follow-up on the number 2 cause of death in Connecticut. How do we compare to other states?
If you look at all of New England, pretty much most of the states in New England, and also I believe in New Jersey, it's number 2 already, but most of the states in New England, it's number 2 already. I mean, nationally, I think the original number was by 2025, it would become number 2 nationally, but I think that guidance has moved up to 2030. nationally. So I think we'll continue to see it increase here in the state naturally, and we'll see it to increase across the country and in particular in New England. The last data that I crunched, I think it was already the number 2 killer in like 23 states.
Thank you.
Thank you.
Would you be able to speak about the support from the NIH and what's recently happened about the reduction or stopping of all the research around this?
I can't speak to that because I'm not familiar with that. But I know from NIH, there's been over the last 4 years, there's been this push with high risk screening and surveillance. There's been more basic research, and the guidance across the board from the GI community has been the MRI EUS modality and blood. And I think the blood piece is interesting because, we've been hearing a lot about, a specific test, but, as you probably are aware, if you put people, the other piece of this, getting people in screening surveillance, they're going to be more aware of their bodies. They're going to be in front of doctors and physicians and be able to diagnose very early versus a later stage. But by gathering all that information and blood and also imaging, we could build a roadmap. And that's something that this disease really lacks right now, is the lack of roadmap. I know that probably doesn't answer your question directly. I'm not familiar with what's happening at the NIH level. I think there's a lot of unknowns. But I know from the NIH level, there's been a big push in this space, and particularly the genetics piece, because there is a lot happening in genetics. Testing has come down. I mean, we could find genetic testing for free. So from that standpoint, that cost has been eliminated, where 5 years ago it was thousands of dollars.
I think the fear is that the NIH has stopped all their research at this time, and so your foundation becomes even more critical at a time like this. So.
Well, I guess I can answer that question. And I did get a call at the end of last year from a researcher out of state that had an R1 grant. And he was at the end of his tenure. It was a 5-year grant. And last year, the NIH came to him in September and said, the $120,000 that you're owed, we're not going to be able to fund. And from my understanding, that happens quite often, not just with what's happening now, but in years past. So where philanthropy can step in is, giving kind of this bridge grant where researchers can get to the finish line. I mean, he was in his last year, that's going into the last year of a 5-year project, and you would hate to see a researcher have to just stop the project because of lack of funding.
And then the final question is, what's your website? Sorry.
It's www.projectpurple.org.
Thank you so much. Seeing no other questions, thank you for being here and thank you for your testimony.
Thank you.
Next person is Chris Doobie. You're remote. Welcome. Thank you for your patience with us.
Good afternoon, Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee. I am testifying on HB 6837, an act extending the authorization of shock therapy. I'll start by saying I'm shy and I have trouble concentrating. I'm much better at communicating in writing, and I did submit lengthy written testimony with several pages of references. I am a resident of Newington. I'm 41 years old. I'm disabled and I'm unemployed, but I have 2 college degrees in biotechnology, English, and philosophy. And I'm involved in several online activist and support groups. I am someone who was forced by probate court order to have ECT against my will. It was about 20 years ago in 2005. I was 22 years old and I had recently graduated from college. I had some issues. I was quite shy. I was isolated, but I had become a very good student and I had won several awards while in college. And shortly after I graduated, or actually around the time I graduated, I had also stopped taking an antidepressant medication called Paxil because I didn't like how it was affecting me, and it seemed like I wasn't getting much benefit from it, and I didn't like the side effects. And I stopped taking it around the time that I graduated, and then a whole bunch of events happened that really totally turned my life around. Um, I had some suicide attempts. But before the suicide attempts, I was having some employment issues, and my family was being insensitive and abusive at times. And so I was under a lot of stress, and I made some suicide attempts, and then I ended up injuring myself, and I was hospitalized a few times. The first was in California, and then I came back to Connecticut, and I was hospitalized at Hartford Hospital, and then I voluntarily entered the Institute of Living. And um, I'll just say I have listened to and watched most of the previous testimony on this bill, so it seems to me that there's a lot of support for it, and I'm not going to try to argue against it, but I'm just going to talk about my experience and things that I have learned. After I got into the Institute of Living, the doctors told me, this was, of course, back in 2005, the doctors told me that because I had been on 2 antidepressants and still wanted to be dead, that I had treatment-resistant depression. And then they were saying that ECT was the next best option for me and that there really wasn't anything else. And I actually was told some of the same points about ECT that have been made today, even though this was back 20 years ago. I was told that it's nothing like One Flew Over the Cuckoo's Nest, that it had changed so much and it's modernized, and there's nothing to be afraid of. And I actually still have never watched One Flew Over the Cuckoo's Nest, just to be on record about that. But my experience was still quite traumatic, and I was not forcibly tied down. I was under sedation. I was totally asleep when they did the ECT on me, but it was still very traumatic. And um, the I had a psychiatrist at the Institute of Living who interacted with me in manners that I found threatening. And he was saying that they could get a court order to force me to have ECT. I was not catatonic. I was eating and drinking. I was completely verbal. I was fully able to express myself. But I did say that I still wanted to be dead because I had had some very horrible things happen to me and I didn't really have any hope. So then I was told that I had treatment-resistant depression, and they recommended ECT, and um, I, I listened to what they told me about it, and I was skeptical, and it didn't seem like a good idea to me. I didn't want to do it, and I wanted to try some other things, and I didn't have much idea at the time of what other options there were, um, because I was just basically going with what my psychiatrist had told me. So I just basically, I didn't really have many other suggestions.
Excuse me,
Um,
Mr. Doobie, but you have reached your 3 minutes. Thank you.
Do you want to finish your thought, Mr. Doobie?
I had a very traumatic experience at the Institute of Living, and I have gotten in touch through the internet with hundreds of people with similar experiences. I will admit that it seems to me that the majority of them did have ECT a long time ago, like me, but I think that also there are some people who've had it in the last few years who have had very bad experiences, um, terrible side effects, long-term reduced functioning in their cognition, memory loss. A lot of people have lost the ability to work, or they can't work very much. It's really affected people's lives in so many ways. And I hope that people will read my written testimony because I made a lot of points in it with a lot of references. And I just wanted to go on record about that. And I also want to mention in 2005, when I became suicidal, my understanding now is that the reason that that happened is because I was going through antidepressant withdrawal from having quickly gotten off of the Paxil, and that's something that there wasn't much information about at the time. I've learned that antidepressant withdrawal can be very severe. It can cause suicidality, that it's often mistaken for a relapse of prior or underlying depression or mental illness. And there's a lot more research now about that, and I cited some of it. So I really think that that was what caused my suicide attempts, because previously I did not have that. I did not have overwhelming suicidal thoughts or urges like that. And I have also experienced similar symptoms at times over the past several years, at times when trying to get off of antidepressants, and it's taken me several years to learn about proper ways to reduce them more carefully that can minimize that. So I just recommend everybody to read my written testimony, and thank you for listening.
Thank you so much. Thank you for your courage to share your experience, and I'm so sorry that you have had the experience, but I appreciate your sharing your story and your experience. I see Representative Dauphiny has a question or comment. Thank you.
Thank you, Mr. Chair, and thank you for your testimony today. Could you elaborate a little bit on what it was like? You said you weren't tied down, but you were heavily sedated. I'm assuming that you were sedated against your will and unable to resist the ECT that you said you didn't want. Is that correct?
It's partly correct because I was sedated like shortly before they actually applied the electricity when I was in the ECT room, which is, standard. They put you under anesthesia. They were still, it was 20 years ago, but they were doing it with anesthesia still back then. But I was awake when I was in a wheelchair being wheeled to the ECT room. I was awake, and then they told me to get on the table so that they could, prepare the anesthesia and the equipment. But I was fully asleep when the electricity was applied and the procedure was done.
Okay, so I'm trying to understand, at what point did you say you didn't want it? And then what happened between when you said you didn't want it and it being applied? I'm trying to understand what happened between no and you given the ECT therapy.
Well, when they first told me that they recommended ECT, and then I said I didn't agree, then it started getting threatening, and I was told, well, they can get a court order. And then they did, and we had a probate court meeting in the hospital. And the doctors all said that I should have ECT, even though my family sided with me. So then they started the treatments. And I actually, at that point, even though I felt kind of defeated by having lost in the probate court, I still was kind of open-minded about the treatment. And then I had like one or two of the first treatments, and I would wake up from after the ECT and the anesthesia would wear off. But then I was having effects of, I had pains in my jaw, I had headaches, I started having trouble concentrating. At times I was very disoriented. And I did have some memory loss, and that was traumatizing. And my treatment team would regularly ask, like, how are you feeling? What do you think of the treatment? And I started saying, I actually said one day, and I'll admit this is not a PC thing to say, but I said it feels like being raped. And I said that to my psychologist, and I also got very aggressive one day with the director of the ECT department who came to see me, and I made it clear that I did not like it, and they just ignored it. they just treat me like a crazy person. If you're screaming or you say, oh, it feels like being raped, well, that's because you're crazy.
Okay,
And
thank you. I appreciate that information.
Thank you. Seeing no other comments or questions, we appreciate your testimony. Again, thank you for being here today. Next person on our list is Jordan Fairchild. Welcome, Jordan.
Hello, Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee. My name is Jordan Fairchild, and I'm the former Executive Director of Keep the Promise Coalition, or KTP. Keep the Promise Coalition builds community power against psychiatric oppression to uplift human rights, self-determination, and racial and social justice in Connecticut's mental health system. I'm testifying today still on behalf of KTP in opposition to House Bill 6837 regarding forced electroshock therapy over a person's objection. I first want to note that I am personally disheartened by this bill, and I've read through all of the supportive testimony that was posted at least by this morning. And in that, I see several psychiatrists have mentioned the need to recognize patients who benefited from ECT, but I don't see any supportive testimony from these patients themselves. I only see probate judges, psychiatrists, and other clinicians supporting this bill. Instead, if you look online, there are actually several testimonies from psychiatric survivors who have direct lived experience and describe their experience of forced electroshock as being a trauma, not a treatment. So I really hope that the committee listens to the individuals who have been harmed by the use of forced electroshock therapy and the express need for greater protections against the use of forced ECT, not fewer. For people who feel that ECT benefits them, there are already several voluntary mechanisms for them to receive it. The decision to force involuntary treatment upon someone is a subjective one and not based on biological testing. Same with the determination of whether or not someone is capable of consenting to treatment to begin with. Forced treatment over objection is an invasion of a person's bodily autonomy, and I personally recognize this as inherently violent. In the case of electroshock, it causes brain damage, memory loss, and traumatizes and disempowers those who object to treatment. I think there are several other ways besides this bill to look at the needs of folks who are not explicitly objecting to ECT or have a conservator, such as actually giving those conservators a say in the informed consent process. I do want to talk about the time frame specifically. There was an idea floated earlier which went something along the lines of why not put in a provision that states that ECT can only be continued past the 45-day time period if we're seeing success. I'll tell you why not. If you believe that electroshock is effective and if you believe that people can lose and regain the ability to consent to treatment, then you should also understand that it's entirely possible that within or following a full 45-day course of shock treatment, that someone will regain the capacity to withhold their consent and say no more. Disregarding the need to satisfy the legal processes protecting that individual from non-consensual forced treatment would violate their right to an informed consent process prior to continuing or ceasing treatment. So therefore, we do consider that 45-day limit a protection in and of itself. The needs of people who are not explicitly objecting cannot supersede the rights of people who are objecting and stand to be harmed and traumatized by the use of force. Much of the research...
Child, but you've reached your 3 minutes. Thank you.
I will summarize if that's okay.
Sure.
The needs of people who are not, much of the research supporting the use of force in psychiatry to begin with lacks sufficient controls for the degree to which individuals who self-indicate positive results have done so due to fear. Last time this particular bill came up in 2023, one speaker recalled knowing that ECT was not working for them, but telling the doctors that it was since they thought that it would end their treatment sooner. I've also referenced in my written testimony, which I hope people read, that there was a court case in 2018 that was settled between a manufacturer of ECT equipment and people who alleged permanent brain damage. The manufacturer Somatics actually added a statement to their risk disclosures that their ACT devices do cause permanent brain damage. So despite the fact that this has been characterized, as the opposition is just looking at this as if it were one flew over the cuckoo's nest, this is not 50 or 70 years ago. This is 7 years ago that we're still seeing this sort of thing happen. So thank you for the opportunity to testify, and please, please do not advance this bill, which would further violate the bodily autonomy of disabled people.
Thank you for your testimony. Seeing no questions, we'll move to the next person on our list. Monica Nugent. Welcome.
Hi, good afternoon, Senator Anwar, Representative McCarthy-Vahey, Representative Claridis Dietrich, and members of the Public Health Committee. My name is Monica Nugent, and I'm a Public Policy and Advocacy Associate at the Connecticut Community Nonprofit Alliance, or also known as the Alliance. The Alliance is a statewide association of community nonprofits. Community nonprofits provide essential services to over 500,000 individuals and families in Connecticut every year, improving the quality of life in communities across the state. The Alliance urges you to support Section 1 of House Bill 6834, an act concerning the Department of Mental Health and Addiction Services recommendations regarding various revisions to mental health and addiction services statutes. This change would allow providers contracting with the Department of Mental Health and Addiction Services, or better known as DMHAS, to bill public or private insurance prior to using a fund established for diversionary treatment programs for people who are deemed indigent by the court. While the fund would still be used when needed, billing insurance first has the potential to lead to savings for the state and a better rate of reimbursement for the providers of these treatment services. Currently, the providers of these services get a reimbursement rate that is established by DMHAS and paid for by the DMHAS-funded grant account. For most commercial and public insurance programs, the reimbursement for this specific program would be higher than the rate offered by DMHAS. This benefits providers by receiving reimbursement closer to the actual cost of providing the services, which can lead to better budget stability for providers. Better budget stability for providers means being able to fill vacancies, being able to plan, and better access to services. The Alliance supports this bill, and we encourage you to support it as well. Thank you so much.
Thank you so much for your testimony. Seeing no questions or comments, we move to the next person on our list, which is Rosanna Ferraro. Welcome.
Good afternoon, Public Health Committee. It's still afternoon. Great. My name is Rosanna Garcia Ferraro. I'm the Policy Director at Universal Healthcare Foundation of Connecticut. I'm here to support Senate Bill 1192 on hospital financial assistance. Just so folks know, Universal's mission is to accelerate the movement for health justice for everybody, because health is a human right and core to racial and social justice. That's where we see our connection coming in here. Not to mention that affordability has been an issue that we've been very concerned about for a number of years. I just want to mention that on some level, we really see the unaffordability of healthcare as somewhat of a public health crisis. It threatens our collective health. It hits us in our pocketbooks, not just, straightforwardly, not just my pocketbook or the person on the street, but the state as well. And I do think that we have seen amazing things happen right during the COVID pandemic, for example. We were able to create access to critical public health services and vaccines and all of these things because we removed the barrier of cost. So I think along those lines that this bill is, as far as supporting improvement to the financial assistance policies at hospitals. And while we support that, we also support strengthening the bill. I will just say that health
Can you wait for a second?
Sure.
I think our Zoom turned off for a second. We want to make sure that we are back online and then on YouTube. So we want to make sure that everybody gets to hear what you're saying. And oh, we're good. You can go.
Go?
Yes, go
Okay.
forward, I mean.
Go. The one thing that I think is most important about what I'm saying today is that this is not a solution looking for a problem. Historically, we have seen some less than generous policies put in place where patients have been sued, they've been sent to collections. Many years ago, there were even liens put on homes for hospital bills. So I think that despite the fact that perhaps there may be pushback on strengthening this bill, what we're ultimately talking about by strengthening is helping folks that need the help. And if that means screening everybody, let's screen everybody. If that means making sure that the hospitals will take different types of documentation, well, let's do it. There are some really great ideas in the testimony, health equity solutions supplied, and also in the written testimony that I'll be providing at a later date. I think that's probably way over 3 minutes.
I think you had 5 extra seconds. Good. All right, so Representative Kristen McCarthy has a question and comment.
Thank you so much for being here and for joining your voice. You're joining voices with many others who have advocated on this issue. And I appreciate that you pointed out that this is a real problem that this bill is seeking to solve. And also pointing out that there is other language that we know Health Equity Solutions would love to see. Actually, I would love to see as well. I'm just going to name that here pretty openly. And I wondered if, because you're here now and as the day wears on, sometimes we don't have as many people listening in just because people have to do the multiple hearings. So when Kati comes, I may repeat some of these questions, but I wondered if you could kind of walk through a little bit more of the specifics of some of those pieces that are those expansions. And for example, when you say screening everybody, what do you mean by that?
Oh, that is very true. In healthcare, it could mean any number of things, right? What I mean is that anybody that says that I cannot afford to pay should be able to apply for financial assistance. It shouldn't simply be because they are uninsured. The other piece of that is also creating more accessible ways for folks to access hospital financial assistance. Is it provided in multiple languages? Is it provided with the bill that gets sent to people? Do we have it in Braille? Do we have it in large print? Are we thinking about all the ways that folks communicate and so need to be informed? There was another idea that actually I've seen it. I'm personally on a payment plan for a ER visit. I know hospitals can and have done this. I'm insured.
Can we just wait? I just got a text that it's not streaming on YouTube. So can we recess for a second?
Sure.
Sorry about that.
Thanks, Senator.
Yeah.
So since something's going on with our system, I'll just send it.
You need to know that Peter said that it was streaming.
I do that. I'll do it. We will recess the meeting for about 15 minutes. Thank you. We are going to reconvene in 2 minutes. We will reconvene in 2 minutes. Thank you. All right, we'll reconvene our meeting. Ms. Ferraro, do you want to come back again? Welcome. Thank you for your patience with us. And we were in the midst of a conversation earlier and asking you questions. I think the little recess was because our systems were down for some of the live streaming for YouTube, and we had to make sure that everybody in the community has an opportunity to listen to what you had to say and the people following you as well. And that's why we had to recess. Now we are back in the picture. It was the heavy testimony that resulted in this. So, all right, with that, Madam Co-Chair.
I was answering your question.
Yes, I was just going to say, I was asking you if you could just give us some of the more specifics in the testimony. Again, we'll hear, I know that later today we'll hear from Health Equity Solutions, but just want to have a chance to get this out on the table now.
Sure thing. One of the recommendations that they had that I was uplifting before we recessed was the idea that hospitals should offer payment plans for folks that are deemed ineligible for financial assistance. That in fact, I'm on one myself right now for an ER visit, and it was pretty straightforward. I do have technology literacy and access to technology, so it did facilitate the process, but I know that this is possible. So I think it's a totally reasonable recommendation. I think another piece here is taking a look at the race, ethnicity, and language of folks that are applying, seeing where there are potential gaps, right? Like we may think that we have things in all the languages we need, but there may be a small community in a certain area that isn't being represented by the policies or the language or the literature of the hospital. So I think there's any number of reasons to collect REL data, but I think one of them is also to just get a better idea of who is being served.
I appreciate that so much. And I wanted to just take the opportunity to share, as I was mentioning before, we did have a proposal last year. We started last year with the broader language. And over the course of time, with negotiations with the hospital association and a number of leaders in the building, came up with what was a consensus, much more scaled down version, which is the language we see today. And we start with this language not with the intent to go any smaller or to scale it down any more than it is, but in the hopes that we can actually pass this through both chambers and have this signed into law this year, and then build on that. Because part of what we heard from our hospital partners was, just the translation, not language translation, but one of the asks was to have the universal application, as you talked about. And each hospital system has their own application. There is also the issue of, funding. If there is, for example, one hub that was a portal for this to happen, who houses that and how does that work? So I think there have been a lot of really great conversations. What has been made so explicitly clear to us, and the governor has certainly recognized this through the medical debt erasure work that he has led on, is that medical debt bankrupts way too many people, and that we shouldn't have people having to be going through bankruptcy as a result of the necessary life-saving care that they're receiving. So I want to just say thank you for being one of the many advocates on this issue. And again, I know we'll talk later to Health Equity Solutions folks, but it really is going to take a lot of voices coming forward on this to move the needle. Thank you.
Thank you for the opportunity to speak. One thing I go back to whenever I think about our hospitals and financial assistance, or charity care, right, that it's called, is the contract that hospitals have entered into with communities by claiming nonprofit status. And part of that is the community benefit. So I see this as them stepping into fully their mission and charge. I understand that there are discussions going back and forth and that there may be building on this, and I will be here next year to say we should keep building on it.
Well, we'll hopefully pass the bill and you'll talk about something else.
I'm more than happy. I never spend enough time at public health. I feel like I'm in human services and insurance all the time. So I appreciate the opportunity.
Thank you so much for your testimony. Seeing no other questions or comments, we'll move to the next person on our list. That is remotely available, Sarah Hernandez. Welcome. You're on. Thank you for your patience with us today.
Thank you. Before I begin my testimony, I'm deaf and autistic. I will do my best to use my mouth words. I also have AAC available. I would like to request a point of contact person for closed captioning. We're using the automated and it's not accessible or appropriate for effective communication for me. So thank you so much. So I will begin my testimony now. Honorable members of the Public Health Committee, my name is Sarah Salvaggi Hernandez. I am an occupational therapist, a former elected official, the first deaf autistic person elected in the nation, right here in Connecticut, in Enfield, to the Board of Education, and an unrelenting advocate for bodily autonomy and disability rights. I've worked all over the state, from Waterbury Head Start to Bristol Head Start. I've been a paraprofessional at Region 10. I started the sensory program as an occupational therapist at Solnit North in East Windsor. So I'm my husband is a electronics professor at Asnantuck, and we have served the state as therapeutic foster parents for 20 years. We're very committed to the state, and everything we do is rooted in consent. Consent is the foundation for ethical care, and I am here today because HB 6837 threatens that foundation. This bill would double the time a person can be subjected to forced electroconvulsive therapy from 45 days to 90 days. 3 months. That is a season. That is a lifetime if you are waiting for somebody to listen. 3 months where a person, a human being, loses the right to say no. And who gains from that? Follow the money. Who profits from this? This is not about care. It is about control. And when there is control, there is profit. ECT is an expensive procedure. One session can cost $2,500 or more. This bill doubles the ability of hospitals and probate courts to bill insurance, Medicaid, and taxpayers for forced treatment. Psychiatric facilities, hospitals, and probate courts all stand to profit while the patient has no say. And who pays for it? You do. Your tax dollars funding forced procedures on people who may never get the chance to object. We are talking about communication rights, and we are talking about patient rights. Does that sit right with you? This is government overreach, period. Electroshock therapy is not benign. It induces grand mal seizures, alters brain chemistry, and carries a high risk of permanent memory loss. Even the National Institute of Health acknowledges this. And yet, rather than protecting people, this bill makes it easier for the state to override their consent. Connecticut's prorate system is already one of the worst in the country, a system built on overreach, unchecked power, and on the quiet stories of people who were never heard and now would ask for more. So I ask you, do we really want to expand its power and strip the rights of people? Government overreach never stops with just one group of people. It always expands. One forced medical treatment becomes normal. Who is next? How long before this expands to veterans, the elderly, and anyone deemed unfit by bureaucrats? That's me. And when that moment comes, when the line has already been crossed, when the president is set, who is going to stop them? Reject HB 6H37, defend the right to consent. History does not look kindly on governments that expand their power at the expense of individual rights, and we are better than this. You do not have to like me, but I hope you will. You don't have to agree with me, but I have more information I'd love to share with you. But you do have to ask yourself, if the government can do this to them today, what stops them from doing it to you tomorrow? I will be there to defend your right to say no, and I'm asking that you do that for your constituents today. Reject this bill. Defend the right to say no. Thank you.
Thank you so much for your passionate testimony. We hear you very loud and clear. We appreciate you. The next person on the list
There's
is
no questions? Because there are so many, I'm confused because for the activists and advocates, there's very little, but for the medical professionals who stand to profit from this, you have none? Like you asked many?
Representative Kristen McCarthy-Vahey has a comment.
Yes, ma'am.
Thank you, Ms. Salvaggi Hernandez. And there will be a question from another member. And I just want to say, I do very much appreciate your advocacy, your passionate testimony. We've had wonderful testimony from people here on both sides of the issue. I just would caution that the members of this committee, I think we do ask questions of lots of people, and want you to know that we certainly are interested in hearing information. If there's additional information that you would like to share, feel free to email that to us and we will take that in. Thank you.
You're welcome. To respond to you though, it is objective to say that there were more questions asked to people who stand to benefit from this bill than people who are protesting against it. And I will send you that information. We can also go over the transcript. So that highlights to you the inequity that's happening. If there was a question?
No, I just will take a moment to respond. You're right. There were more questions to different witnesses. But I do often in this committee, and I think members of this committee are used to me saying the assumption of intent. And I think you are raising important issues and presenting your position. One thing that I have said here today to everyone on every side of this issue is that my experience of those who have testified before us, whatever their perspective on this issue, is that they are here in the best, what they believe is the best interests of the patients they are serving. And I just want to say that because I do think, again, I think we're very fortunate in the committee to have a lot of thoughtful members who ask lots of questions and in addition have conversations outside of this. We very much value the experience, the lived experience of those who have come before us and appreciate the conversation. But thank you, Mr. Chair.
I look forward to, and to
No
respond
other
to that
questions?
again, I look forward to that being reflected. And it's just it's an opportunity for us to call in each other. That's all. Thank you.
Okay, thank you. We move to the next person on the list, which is Mr. Paul Palmer. Are you in? Welcome.
Oh, you have to touch the button. All right. Yeah, I'm nobody special. I don't have a degree. I'm not a doctor, a nurse, or head of an association. I'm just a concerned person who has a little experience with the behavioral health industry. And
would
I'd
you
like
be
to
able to introduce yourself if you don't mind, please?
Paul Palmer. Yeah, I'd just like to say that the measure of society is how it treats the weakest member. That's a famous quote from a guy, you might know him better. We were endowed by our creator with certain inalienable rights, that guy. At any rate, what we've done with this legislation a long time ago is we inalienated a person's rights. We took their rights away and we handed them to a doctor. This is a fact, and it happens a lot in behavioral health. But we do that believing in the benevolence of doctors, that doctors always want to do what's right for their patients, and they do no harm. They take that oath, and they always know what's best. But that's not always true. Sometimes they make mistakes. Otherwise, we wouldn't have lawyers suing doctors, right? We all know they make mistakes. They're not perfect. And this legislation, what it's doing is extending the time period of a person whose rights have already been alienated without a check. The original legislation was written as a compromise. That's what I was told. Now, you will note that voluntary patients, 30 days. Involuntary patients, 45. I already see a fault with the original legislation. Why does an involuntary patient have less rights than a voluntary patient? Because you wrote it that way. Now, they're going to go to 90 days. And maybe the patient does need 90 days. But I say, go back to the court and get permission, do it again. That's why the original legislation put a time limit on it. If you're going to say, no, they need more time, but the doctors are benevolent, why not just go to 180 days? Why not go 360? Why not put any time limit on it? The original legislation was put there to at least put a little bit of a check and a little bit of a safeguard. Okay. Next, I have some family experience with ECT, electroshock therapy. I had a close relative that had it, and I was there every day afterwards of the treatments. Now, the first treatment, the person came back to me and said, I feel horrible. I feel like somebody beat me with a baseball bat. That was the first treatment. And then, well, maybe they didn't give me enough anesthetic. And then they continued to have treatments every other day, which is the process. Monday, Wednesday, Friday, Monday, Wednesday, Friday, up to between 6 and 8 treatments. When she got better, fortunately, she had a doctor that said, okay, if you want to, she said, I don't want to do any more treatments. Okay, you can go. Well, these patients on the 90-day routine, they don't have that option. Just because you're getting better, the doctor can say, well, maybe you'll get a lot better if I just keep doing it. If you do the math, 90 days would be about 39 or 40 treatments doing every other day for 90 days.
Excuse me, Mr. Palmer, but you've reached your 3 minutes. Thank you.
Why don't you finish your thought?
Well, I can say that I have another friend who also had ECTs. They say there's no downsides to this.
Can I ask you a question?
Yes.
Tell me about your other friend. Go ahead.
Oh, okay, I'll tell you. Well, I'm not at liberty to tell you about the other friend, but what I will say is the results of her ECT was she had the memory of her honeymoon erased, gone. So don't give this, oh, well, it's just a little minor, blah, blah, blah. No, real things happen to people. There is a downside. I'm not saying that the treatment is a bad idea for people to have it, but only voluntarily, and 30 days is great. But forcing people to do it for a period of 90 days seems a little too long. Finally, I'd just like to say, do unto others as you would have them do unto you. You put yourself on that table and you think about it. Thank you.
Thank you so much for your testimony, and being no questions or comments, we appreciate your time today with us. Thank you.
All right.
I just want to see if Tom Burnett is there. I don't see them there. Next one is Jordan Dean. You're on. Welcome, Mr. Dean.
Hello, members. Hello, members of the Public Health Committee. My name is Jordan Dean. I'm a medical student at UConn School of Medicine, and I'm a lifelong resident of Waterbury, Connecticut. I'm here to support House Bill 6837. During my psychiatry rotation, one of the patients assigned to me had schizophrenia and was catatonic. Catatonia is a medical condition that affects a person's behavior, speech, and movement. It can cause muscle rigidity, cardiovascular instability, respiratory failure, and death. Dozens of studies published in top scientific journals from all around the world prove that the most effective treatment is ECT, electroconvulsive therapy, or shock therapy. This patient was unable to speak clearly. He could only mumble and make incomprehensible noises. He spent most of his day in bed, barely moving, rarely acknowledging anyone else in the room. Prior to his illness, he earned a master's degree from an Ivy League school and was on the verge of launching an international business. I watched this patient deteriorate every day while awaiting the probate court approval. Once the probate court approved and the patient received ECT treatment, I heard him speak a full coherent sentence for the first time, and it was really astonishing. He went from treatment and he underwent continued treatment, and he continually improved until the probate court order expired. While he was awaiting a second court hearing and without ECT, he began deteriorating again and eventually fell back into catatonia. I'm testifying today on behalf of this patient and others like him who deserve timely access to the treatment that could save their lives. While the concerns raised by the opposing testimonies are well-intentioned, they don't acknowledge the clinical realities of ECT. Testimonies from individuals who do not see or treat catatonic patients have stated that the current law works. However, you've heard from physicians and will hear from more physicians from multiple Connecticut hospitals that it does not work. Psychiatric illnesses are complex. They require treatment tailored to specific patients by their physicians. Imposing arbitrary time restrictions to an ongoing medically necessary treatment harms patients. The argument that the current limit protects patient rights fails to consider that overly restrictive barriers can itself infringe on patient rights. Individuals suffering from severe psychiatric conditions deserve timely, uninterrupted access to evidence-based treatment when they're unable to advocate for themselves. Lengthening the duration of consent does not strip away rights, it enhances them. For these reasons, I urge you to support the proposed bill extending the duration of consent for ECT. This change aligns with the best medical practices, respects patients' rights, and ensures that individuals with severe mental illnesses receive uninterrupted evidence-based care. Thank you for your time and consideration.
Thank you so much for your testimony. Representative D'Amico has a question.
Thank you, Mr. Chair. Thank you for testifying remotely in front of the committee. Very much appreciated. So I have to ask this question. Is it possible to reach some kind of a compromise here? We have heard, testimony today that the current system protects patients' rights, that the current system is in violation of patients' rights. I think that's fair to say. Do you foresee any way that we could come up with a compromise, perhaps allowing someone other than the court to advocate on behalf of the patient to make sure that this person gets what they truly need?
I think the idea of a conservator having this power has been talked about. I'll defer to my psychiatry attendings, the ones who have completed medical school on that. But I think one of the problems is when you need ECT sometimes, this is an acute issue. This is a time sensitive issue where we can't wait for another court hearing, or we can't, wait for the court to create a conservator and things like that. Some of the psychiatry residents at UConn that I've talked to, they said these delays they've seen it cost a patient their life. So these are life-threatening situations where time is of the essence, and you need a procedure that's already in place where the doctor can do what's best for the patient rather than going through more like bureaucratic loops.
If I may, Mr. Chair, just one more quick question. I'm going to ask you the same question that I asked of a previous testifier. So have you experienced a situation where the patient is deemed to be not capable of giving informed consent by virtue of the fact, or because of the fact that they disagree with the medical personnel, as opposed to being deemed able to give informed consent because they agree with the medical personnel? Have you had that experience?
Of a patient saying they don't want ECT and then and they're of sound mind and judgment? Is that what you're asking?
Oh, I'm asking, have you ever run into a situation where someone is deemed to be unable to give informed consent simply because they disagree with the diagnosis or they disagree with the recommendations of the medical people?
No. So I actually did a presentation on informed consent to our psychiatry department. To say someone cannot provide consent, they either have to not be able to communicate their decisions somehow, or they don't understand the ramifications of that decision. So if somebody disagrees with having ECT and they can explain why, or if we just can't show that they're not of sound mind, then we have to abide by that. And also, just because we're extending it to 90 days, if the patient gains the ability to provide consent or decline consent, they can do that at any time. A patient can revoke consent for any procedure whenever they want.
Okay, thank you very much. Thank you, Mr. Chair.
Thank you so much. I see no other questions. Oh, we do have questions. Look, you're getting attention. So wait, who should we go with? Representative Reddington Hughes or Representative Ann Dauphin? Oh,
Oh, yeah.
all right, Representative Reddington Hughes, you have it.
Oh, thank you. My short question, you were making reference to that as a result of not having this in place, that it has already wound up destroying some lives of people because they were not able to get access to the treatment in a way in which they, would be able to through the court system if this were passed. What percentage of people that are undergoing ECT would you say that represents?
I do not have that statistic, and I don't even know if that's something that's been studied extensively. I've read individual case reports on that, but that's just one circumstance that I've talked to the psychiatrist at UConn about. But I'm also a medical student, and I don't have the experience of the psychiatrists that have spoken and that will be speaking.
Okay, I'm just bringing this up because I would think that would be fairly important in a bill like this, because we're changing the length and period of time specifically because of that. So I would hope that somehow, through some form of research that could be presented, that we would be given that information from some organization in order to make a decision. Thank you.
Representative Rand Dauphin.
Thank you, Mr. Chair. It might not be a question, but a comment. You mentioned that someone who said no to the procedure would have to explain why in order to determine that they were able to make that decision. I don't know that I've ever heard that before with any kind of consent, that somebody had to give an explanation as to why. I don't, maybe you could comment on that. I've never heard that before.
Sure. So the explanation as to why, it's the same as any other procedure. So if you can refuse, but they have to make sure that you're understanding why you're refusing. So if you needed some emergency surgery or you are going to die, and the surgeon tells you we need to bring you to the OR and do the surgery, and you say no, that kind of gives the surgeon pause, and they want to figure out why and make sure you're making this rational decision. If you say, no, I don't want a blood test that's mostly inconsequential, they usually don't need to dive in a little further. But when it's a life-threatening condition that we can prevent, that's when we need to make sure you're of sound mind. And usually the doctor will ask something along the lines of, what do you know about this procedure? And why don't you want it? I had one patient that I was seeing alongside this patient who also had schizophrenia, and he declined ECT. And when we asked him why, he said he's heard about it and he doesn't like the idea of being shocked. So he declined, and we didn't go forward with it because he was of sound mind enough.
Thank you for that answer. It seems to kind of lend to what our other representative, D'Amico, was talking about with regard to not liking the answer. I just wanted to say that, but thank you. Thank you for your testimony.
All right. Seeing no other, we have Representative Claire DeCeed.
Sorry. Thank you for your testimony. And I just want to reiterate, when someone is able to verbalize no, and then you as a healthcare professional are trying to dig deeper as into why, to make sure they're understanding that this could be life or death, and they continue just to say no because I don't want to. Isn't that sufficient enough answer?
Yes, you would have to look at you can't just look at this kind of in an isolated situation though. You have to look at the whole clinical picture. So why is the person there? Do they have a condition that could make them not able to provide consent? If it's somebody that you have, if every adult that comes into the hospital, we assume they can always provide informed consent. So you need a reason why they wouldn't be able to. You can't just say, I don't like their answer, and I'm going to say they aren't able to provide consent. You have to look, is this person schizophrenic and off medications? Is this person catatonic and they're just saying the word no, I don't want to 20 times a day to every single question you ask? So you have to look at it in the clinical picture, which is what doctors do. Doctors aren't going through a decade plus of training to take people's rights away and hurt them. They genuinely want to help them as best they can, and patient rights are something sacred in the medical world.
Okay, thank you for that clarification. Thank you, Mr. Chair.
Thank you. Seeing no other questions or comments, we will move to the next person on our list. Is Liz DuPont Dale here? I don't see her online and neither in person. Sharon Gauthier, welcome. Thank you for your patience with us today.
Is it on? No.
Oh, this one.
Hello?
Can you hear me?
Yes.
Okay.
Okay. So I'm a panelist now? Okay, thank you.
I'm
Excuse
good.
me.
So my name is
Just
Sharon.
hang on just
Wait,
for
wait,
one
we
moment.
are-
Senator Anwar.
Thank you. I think what we'll do is we are going to have Sharon, you go first. And Liz, you were a couple of minutes late, so we went to the next person and we'll have you join us in a second.
Oh, hi, Liz.
Hey, Sharon.
So my name is Sharon Gauthier, and I am a nurse advocate, and I have my own patient advocacy nursing practice that I've had for 17 years and was the first in Connecticut, where hospitals had no idea what to do with me. So Senator Anwar and all the committee members, thank you so much for being here and supporting healthcare in general. I support the requirement of both nursing homes and assisted living facilities to be equipped with an AED to protect the staff, families, and residents. Florida, New Jersey, New York, Texas, Massachusetts, Alabama, and Pennsylvania have requirements for an AED equipment. Massachusetts, on our border, require assisted living communities and long-term care facilities to have AED equipment on site, as well as a requirement for long-term care facilities. And I've also provided copies of those bills for you, which I will leave. The Connecticut Association of assisted living who I contact will be against the bill, as I've already discussed this with the president. The reasons I believe are the costs, training, and how many. This is not about cost. As we all know, assisted living community owners, God bless you, only goal is profit, as well as long-term care facility owners. It's not how many that will be decided by the state. It's not how many that will be decided by the state. It's not about medicine, as I can tell you that presently there are assisted living communities that advise they will take care of your loved one for the rest of their lives. Perhaps outsourcing on the backs of families, which often happen. They also take on residents who have allergies and diabetes, who very well may be chronic and stable, but have no plan that I'm aware of to address an emergency issue with an allergic reaction or a low blood sugar. The only two categories as an old emergency room nurse, and I say that lovingly, that needs to be addressed immediately is a low blood sugar and an allergic reaction. Everything else can wait for EMS to get there. I have had discussions with Senator Anwar and Senator McCrory about specific instances that occurred to one of my clients. Our population of aging citizens is growing, with a projected growth of 57% between 2010 and 2040, which I actually took from the statistics here. And access to assisted living communities expanding, as well as the need for long-term care facilities. As we go forward, we must understand that elderly residents have medical issues, and the term chronic and stable does not reflect the rest of their lives, and we should be prepared for those events. I'm in full support of this device, both long-term and assisted living communities, because it's not just about the residents, it's about the staff and the families and the visitors. And if you have any questions, I'm happy. If not,
Under 3 minutes and very strong.
yes, I timed myself. I've been here before.
Yes, yes. Thank you for your work and thank you for your testimony. And we appreciate your support for the bill and advocacy for this bill as well. And as you can see, most of the people who come are supporting this as well.
Yes, I think it's a good idea.
Seeing no questions or comments, we appreciate you being here in person as
No
well.
problem.
Thank you.
And I'll leave those documents over there.
Okay, thank you.
You're welcome. Okay, Liz.
Liz, you're on.
Good afternoon, Senator Anwar, Representative McCarthy-Vahey, members of the committee. My name is Liz DuPont-Deal. I'm the Associate Director of the Connecticut Citizen Action Group. For more than 50 years, CCAG has worked to make Connecticut a more fair and just place. And I testify today on behalf of our thousands of member families throughout the state. We stand in strong support of SB 1192 regarding hospital financial assistance. Last year, Connecticut took a big step in prohibiting medical debt from being reported to credit collection agencies, but more is needed. Medical debt, as you know, is seriously harming thousands of families. 6 in 10 people who reported difficulty paying medical bills were covered by health insurance and could still not afford to pay. Universal access to financial assistance and information for families and patients to avoid incurring further medical debt is essential. Financial assistance policies can help reduce how often patients incur medical debt. Furthermore, our state's Black and Latina residents are more likely to lack insurance or have a high deductible plan due to systemic racism and other disparities in employment and education. For example, in Connecticut, a disproportionate number of Black and Latina adults said they had not received or had delayed medical care in a survey conducted in 2021 by Connecticut Data Haven. We are very encouraged by proposals to address underlying structural causes of skyrocketing healthcare costs, like private equity ownership in our healthcare systems, rising and inconsistent hospital prices, vertical integration of for-profit health insurance companies, and secretive pharmacy benefit manager schemes, mostly promoted by health insurance companies, and also abusive practices around prior authorization and claims denials. These will begin to address our core problem that we treat healthcare as a commodity. There are too many people extracting too much money at the expense of our care. We are sick and tired of corporate interests getting policymakers to perpetuate the lie that patient protections and utilization are the reasons that healthcare is so expensive. It's time to stop validating this as a reason why the United States healthcare costs so much more than other countries with worse results. Our federal government is now threatening to undermine our fragile healthcare system even further. Recent events have revealed widespread anger at the insurance industry's deplorable claims denial practices that deny people needed care. If there was ever a time to pass state healthcare reform, time is now. I urge you to vote favorably on SB 1192 and also to follow through with measures to address greed in healthcare and eliminate future medical debt for Connecticut residents. Thank you very much for your work and your attention today, and I welcome any questions.
Thank you so much, Liz, for your testimony. Representative Kristen McCarthy-Vahey has a question.
Thank you. Actually, I'll admit it's a comment. Liz, thank you very much for your testimony and also just for naming all of the different aspects that impact cost. And that this bill that you're testifying on is just one aspect, and it's at the tail end. So we do certainly look on the prevention side here as well, but thank you for your support all across the spectrum.
Of course, thank you.
Thank you. Liz, I'm going to ask you a couple of questions on this bill. Now, I know you've been part of this bill as well. Last year, we were able to get very close to passing this bill, but it was negotiated after we got everybody to sit together. So we are starting and ending at the level where we were last time rather than starting from scratch. You're aware of that, right?
Yes, yes.
And the reason is that we Representative Kristen McCarthy-Vahey had spoken earlier to one of the other advocates for the same purpose, was that this had been something that everybody could accept, but not everybody was happy with. But at least we were able to get significant support across all different stakeholders. But we also feel that we cannot dilute this further. It has been not where it could have been, but it is where it is, and this has acceptance across. And we are hoping we should be able to get some success with this, and then we can reassess its utility and see what opportunities it can provide us. So I just wanted to make that comment and see how you wanted to reflect on that.
Yeah, thank you for that overview and perspective. And we have made some progress both in terms of reporting to debt collection agencies. I think as I said, there are many other elements of it. I mean, we of course would welcome strengthening the bill. We would also welcome people being signed up automatically for SNAP or other benefits as part of this process, because these systems all should be working together, right, to keep people safe and healthy and adequately housed and providing with healthcare, and all of those should work together. So I think I agree with what you're saying. We would welcome it being strengthened, and we support it as it is, and we appreciate the process. Even also recognizing the other factors that do contribute to people's health and well-being, and what you all can do about that. As I said, we're aware of a number of other bills that will address other measures, and we're grateful for those.
Thank you so much, and thank you for all that you do and your organization does. Seeing no other questions or comments, we'll move to the next person on our list, which is Dr. Jane. Welcome, Dr. Jane, you're on.
Thank you for this. Thank you, respected Senator Anwar, co-chair, Representative Vahey, and respected members of the Public Health Committee. My name is Lakshya Jain. I'm a resident of Glastonbury, Connecticut. I'm a principal psychiatrist working at Connecticut Valley Hospital. I wanted to share some of my personal opinions on regarding SB 6837, an act extending the authorization of shock therapy. These opinions are my own, not the opinions of my organization or institution. As Dr. Sukhera mentioned in his testimony, shock therapy, also known as ECT, is a treatment reserved for patients whose symptoms of severe psychosis or depression or mania have not responded to 3, 4, even 5 trials of psychiatric medications. ECT is used for patients who are facing life-threatening situations, like elderly patients who have severe depression or catatonia and have restricted their food and water intake, threatening organ failure and imminent death. Just as Judge Daly mentioned, some patients who recover from ECT may experience a recovery of their symptoms if ECT is stopped too abruptly, and we, as providers, we have to slowly taper their frequency from 3 times a week to 2 times a week to once a week. And this can sometimes require continuing ECT for 2 to 3 months. Some patients also need to stay on maintenance ECT at a low frequency, like once a week, once every 2 weeks, or even once a month for several months to stay functional. In regards to the concerns raised by CLRP, I would like to add that, like CVH, most of the psychiatric hospitals don't actually have ECT available on site. So they have to send patients to the few places in Connecticut that actually do offer ECT, like IOL. And these places are often incredibly busy. So once a court order is received, it can take up to 2 to 3 weeks for us to schedule an actual ECT appointment. And generally, it takes about 7 to 12 sessions of ECT in order for a patient to start responding to ECT. I personally have had a patient who responded to ECT after 18 sessions, which was quite unusual. And actually, with a medical student at UConn, we wrote a case report about it. Often I see the 45-day time duration not being long enough for us to see a full response or full impact of ECT on a patient. Another discussion is about maintenance ECT. I have seen patients on maintenance ECT often ending up going to probate court multiple times despite having minimal change in our presentation. I recall a recent case about a patient who was admitted to CVH for severe suicidal urges. Despite, I think, 4 to 5 antipsychotic trials, she didn't really get any benefit from her severe symptoms of urges, and we had to send her to ECT. So despite the fact that the patient wanted ECT, the conservator was in agreement with ECT. Just because she had a conservator in place, we had to go to probate court. She underwent ECT for a period of 2 months. After that, she was on a slow taper. We tried to decrease and stop her ECT, but the suicidal urges came back, so we had to go back up and increase the frequency of ECT and then do a slow taper for a period of about 4 months. I recall, like, so many times we were in front of the probate court judge. Everybody in the room agreed that she will benefit from ECT. She wanted ECT and we would continue for ECT. I just felt that we just kept wasting the time of probate court by these repetitive hearings with this.
Excuse me, Dr. Jain, but you've reached your 3 minutes. Thank you.
Okay. In summary, I would just say this bill doesn't really touch any aspect of ECT other than just increasing the time duration. And I think this will really help us provide the care that these patients need.
Thank you for your testimony. And seeing actually, Representative D'Amico has a question. Thank you.
Thank you, Mr. Chair. I will try to be brief. Dr. Jain, thank you for coming and testifying. So we've heard a lot of talk today in talking about this particular legislation. We've heard about informed consent. How do you personally arrive at a conclusion as to whether a particular patient is capable of informed consent?
So I try my best to engage with the patient, try to explore like what exactly their understanding of ECT is. I try to connect with as many family members, get their opinion in like whether they feel that ECT is necessary or not. I usually, as at CVH, we do have the luxury of spending more time with the patient. So we can all often replicate some of the medication trials that have been tried previously. So I can recall like some of the most recent patient that I discussed. We tried at least 4 or 5 different antidepressants in order to see if she would have any benefit from these in terms of reduction in her suicidal urges. So I do try my best to rule out almost all psychiatric medications, including using very old medications like MAOIs, which are often not commonly used. Again, this is all after having a discussion with the patient, like, look, you are suffering, we want to help you not suffer, and this is a treatment option, this is another treatment option. So I try my best to get their understanding of what do they understand when they say yes or no. And only when I have a very coherent understanding from their opinion, and I see consistently an illogical or incoherent answer, that's when we proceed towards probate court.
Thank you very much. Thank you, Mr. Chair.
Thank you. Seeing no, Representative Miko. Oh, sorry, Representative Hoffman.
Thank you, Mr. Chair.
Habit now, sorry.
Thank you for your testimony. I was just curious, how do you handle individuals that you're describing when they don't want to participate with pharmaceutical drugs?
I think in terms of pharmaceutical drugs, again, I have the same conversation. Like, I try to engage with them in terms of what they understand about the medication. I often print out patient education pamphlets. I sit down with them, I talk with them. And this is not like a one-time conversation. The patients can suddenly stop treatment at one point because they are experiencing one or two side effects of the patient. So this is an ongoing discussion with the patient about like explaining to them, understanding their side of the story, like what are their fears, what are their anxieties about specific side effects. Again, it's not an all or none like for me, like, oh, you don't want to take my medication, so I guess you don't have the capacity. I try my best, and I have the luxury of having a very good team with a psychologist, a psychiatrist, a unit director, and a lot of educated and experienced staff members, MHAs here at CVH, who all kind of engage with the patients over the entire day. I mean, I'm only here for like 8 hours a day. They see the patient 24 hours. So they also engage in this discussion with the patient. They give me pointers like, look, this patient is really struggling with sleep. We maybe want to change the dose, or you want to move up and down. So again, it's an ongoing engagement with the patient in terms of like, are they actually understanding what this medication is doing to them or what their symptoms are?
Thank you for that answer. And if they don't understand, how do you proceed?
If they are unable to understand their symptoms or how the medication can potentially help them, then I engage with the conservator of person about what I intend to do. Once the conservator feels that this is a good enough treatment plan, then we proceed to apply. I get a second opinion for another treating psychiatrist on a different unit. They come by, they talk to the patients. If they agree that the patient also does not have the capacity, then we do a second opinion, and then we petition the probate court. And then we have the probate court hearing. And if the probate court judge actually agrees that the patient doesn't have the capacity, then he gives the conservator the authority to decide what medications to use. So I again go back to the conservator. We have a full another conversation like about what medications I want to try initially, and then we kind of take it from there.
Thank you.
Thank you. Seeing no other questions, we thank you for your testimony. The next person on our list is Tara Peda. Thank you for your patience. Welcome.
Thank you. Good afternoon, Senator Arnwar and esteemed members of the committee. My name is Tara Peda. I reside in Prospect with my husband and 4 sons. I am here today in support of Senate Bill 1191, an act establishing a pancreatic cancer screening and treatment referral program. In December of 2013, I visited my doctor after not feeling well. I had some intermittent pain in my lower back and right side that was concerning. I was sent for an ultrasound where nothing nefarious was detected. Almost a year later, I returned to my physician as the pain was getting worse and more frequent. I knew something was wrong and asked if we could pursue this further. My doctor was receptive to my concerns, and after several visits, including a CAT scan, MRI, biopsy, and PET scan, I was diagnosed with pancreatic cancer in September of 2014. At the time, I was 44 years old and found myself facing my own mortality. It was a dark time. I was scared and uninformed. I knew nothing about this disease except the staggering survival rate of 13% for those who make it to 5 years post-diagnosis. I scoured the internet for information as I needed to educate myself, knowing I had important decisions to make about my treatment plan. I was raising 4 young children and wanted to continue to be an active figure in their lives instead of a memory or a photograph on their nightstand. I knew the odds were stacked against me as I navigated my new reality as a cancer patient. I underwent surgery and 12 rounds of chemotherapy, which ended in May of 2015. The provisions set forth in this bill are life-saving proposals. It is a meaningful and powerful bill and a step in the right direction to combating this deadly disease. Establishing a public education and outreach initiative to inform Connecticut residents about pancreatic cancer screening services and the benefit of early detection is impactful. Providing patients with factual information allows them to make informed decisions about their health and treatment plan. The advantages of early detection cannot be denied. Had I not pursued the symptoms I was experiencing and gotten screened, I doubt I would be here before you today to share my story. Pancreatic cancer screening services is undoubtedly crucial for detecting this cancer and giving patients an opportunity to successfully treat the disease. The recurrence rate post-surgery for this disease is 44%. So creating a system to track and follow up on all the patients participating in the proposed program will ensure that they are being followed closely and screened at recommended intervals. I am screened every 6 months to ensure this evil disease has not resurfaced. Thank you for the opportunity to provide my testimony today. As of May of 2014, I have no evidence of disease. I know how fortunate I am to have survived this disease and be able to speak to you today on Senate Bill 1191. The proposal set forth can save lives for Connecticut residents. I'd be happy to answer any questions.
Thank you so much for your testimony, and thank you for encouraging us about the reality. There are not a lot of people who have a story like yours, and our goal is to have more people with a story like yours. So this is very encouraging. Thank you for sharing that.
Thank you.
Mr. McCarthy, he has a comment and a question.
Thank you, Ms. Petta. Yes, a comment. I just will note that your testimony is striking on many levels. One, that you are here to talk about this with us is truly a miracle. And I'm so thankful for that because you share an important message with us that early screening is important. And part of that message that you shared as an example for all of us was that you paid attention to the symptoms you were experiencing and you advocated for yourself and clearly had access to healthcare, which is one of the things that we're trying to provide here. But that message is so important, that the early detection, that all of us, that's one of the things that we can do is to pay attention to the symptoms we experience, recognizing that with pancreatic cancer, as we heard earlier, sometimes does not present those symptoms and doesn't give people the option. But your voice here today is incredibly powerful. Thank you.
Thank you.
Seeing no other questions or comments, we thank you for your testimony. We'll move on to the next person on the list, which is Dr. Timothy Shannon. Welcome. You're on, Dr. Shannon.
Thank you, Senator, and thank you, members of the committee, for having me today. My name is Dr. Timothy Shannon. I live in Branford, Connecticut. I am a physician who got my MD at the University of Connecticut and was on the faculty of the medical school at Yale. However, for most of my career, the past 35 years, I've worked in the research and development of new medicines to deal with devastating diseases. I've done this largely in Connecticut with Connecticut-based companies, but I also have lived and worked around the world in this mission. I'm here today in support of Senate Bill 1191, an act establishing a pancreatic cancer screening and treatment program. During my career in developing novel drugs, a large focus has been on treatments for cancer. And this priority was really established because only 15 or 20 years ago, it was thought that cancer would overtake cardiovascular disease as the #1 cause of mortality in the Western world. Fortunately, this has not been the case. And as you probably all know, overall, cancer mortality has been decreasing, and it will not overtake cardiovascular disease. And this is largely because of the public health investment in education and implementation of cancer screening for patients at risk. With these efforts, great strides have been made in reducing mortality from cancer, particularly in cancer where screening is routine, such as cervical cancer, breast cancer, prostate cancer, and colorectal cancer. Early diagnosis for any cancer really is the only path to cure, whether that cure is by surgery, radiation therapy, or medicines, or a combination of those. The longer the lapse in diagnosis, the less likely a chance for cure. While not as high profile as some of the other cancers I mentioned, pancreatic cancer is actually the #2 leading cause of cancer death in Connecticut, following lung cancer. And mortality from pancreatic cancer, unlike the other cancers I had mentioned, is actually increasing over the last decade. Notably, the window to cure pancreatic cancer is one of the most narrow of all cancers. The consequences of missing that window are dire. Patients where that window is missed, as our prior speaker mentioned, have a very, very poor prognosis with survival rates in the 5 to 15% range if the disease is not caught early. Education, identification, and screening of patients at high risk for pancreatic cancer is the only way to improve this dire scenario. This has been successful with many other cancers.
Dr. Shannon, we lost your voice. I think you got muted. Go ahead. No,
Yeah, sorry. Yeah. So in closing, we know how to do what we need to do. Nothing has to be invented. The screening guidelines for pancreatic cancer have already been developed by the medical experts. These will be submitted with my statement to the committee. It really is a matter of education of the healthcare community as well as patients, and making sure resources are available to the populations who may not have access to them to get the proper screening and treatment. The costs of doing this are more than offset by the costs that will be avoided, and lives can be saved. Thank you for listening to me today. Senate Bill 1191 is a wonderful idea, and I would be happy to answer any questions you may have.
Thank you so much for your testimony, Dr. Shannon. I see no questions at this time. We do appreciate your insight. Do you mind just sharing, like in 3 sentences, what are the things you think should be done for early identification?
Yeah, I think a lot of it is public health in the medical community. Again, I just don't think pancreatic cancer is top of mind like other cancers we screen for. Yet, it's a predominant killer in the United States and Connecticut. So I think education of both patients, but also community healthcare providers and getting this top of mind is critical.
Thank you. Thank you so much for your testimony, and we'll move to the next person on our list, which is Tom Swan. Not seeing him here, we move to the next person on our list, which is Sam Jordan. Welcome, Sam. Thank you for being here. Thank you for your patience with us.
Good afternoon, honorable members of the Public Health Committee. My name is Sam Jordan. I am on the autism spectrum, and I am an advocate for disability rights. I've lived in Enfield for my entire life, and I graduated from Connecticut State Snuntuck Community College's Advanced Manufacturing Technology Center back in 2023. I'm here today to oppose Bill HB 6837, an act extending the authorization of shock therapy by patients' written consent or probate court order, due to my concern about more aggressive non-ECT electric shock procedures under the bill's definition of shock therapy being easier to administer. Some disabled and autistic people, being much of which are unable to consent by law, in some cases are sent to a facility in Massachusetts known as the Judge Rotenberg Center, which is condemned by the United Nations Special Rapporteur on Torture, and are tortured with a painful electric shock device known as the Graduated Electronic Decelerator, or GED, for any behaviors found undesirable by staff. This device is not to be confused with the electroconvulsive therapy, or ECT, which is another form of treatment that does not directly apply pain. By contrast, this device applies shocks that are around 3 times as painful as was considered tolerable to a human adult on disabled people who interpret pain much more severely. The shocks are even powerful enough that in some cases it can cause burns and tissue damage. The fact that this bill makes it easier for this facility to allow those from Connecticut to be tortured by the GED electric shock device against their will is a slap in the face when it comes to human rights. The GED is frequently used for minor quote-unquote antecedent behaviors like getting out of a chair or raising one's arms. As according to the facility, these minor behaviors are aggressive and can lead to more dangerous ones, despite in many cases, such as said by Gregory Miller, these behaviors would not have led to a dangerous outcome. The GED is specifically designed to surprise the user so they would never expect the shock to come. Not only is it remote controlled, but at times the user would wear multiple electrodes at once, and as a video still said on the facility's website says, the use of multiple electrodes and surprise factor, quote unquote, really helps. In addition, clients reported they were forced to wear the device while showering and were shocked while asleep for behaviors from the day before. This and various other factors have led to the mental health decline of various clients who were formerly on the device, some saying that they were in constant fear of being shocked. In addition, the GED is a device that is usually only effective when the device is used for the rest of their lives. From their own studies, there are only less than a third of documented cases where this device permanently removed target behaviors without recurrence or the device after the device was removed. The others are either still on the shock device, some clients being on such for well over 20 years, or they reverted back to the state they were in before they were on the device. Their defense was found on an archived version of their website is that the device still serves a benefit like, quote, a pair of eyeglasses or an artificial limb. A painful electric shock torture device should never be compared to a prosthetic. Prosthetics are designed to help people, while torture is designed to manipulate people. It does not matter why the extreme pain is being given. If someone is being given extreme pain to punish or coerce, that is torture as defined by the dictionary and by the United Nations. The state of Connecticut needs to ensure that the safety of those with disabilities is not jeopardized by electric shock torture. This facility uses court approval processes like those outlined in this bill to approve disabled people for GED electric shock. Allowing this bill to pass makes it easier for them to approve these clients and puts their safety at risk. The conditions in this facility are not acceptable for anyone, let alone any person from our state. Thank you, and I'm willing to answer any questions you might have.
Thank you so much for your testimony, and thank you, Sam, for being with us this morning and afternoon, and it's still sort of afternoon.
Yeah.
Thank you. I don't, Representative Miko.
Thank you, Mr. Chair. Sam, thank you for coming to testify. Did you submit written testimony to the committee?
I have not submitted written
Okay.
testimony.
I would encourage you to do so. So we'll have it. So without spending too much of the committee's time, I'm not quite understanding. I missed the beginning. I didn't quite understand what your statement at the beginning. So you're telling us that passage of this bill will extend to this GED procedure that you
I
described?
presume that it will because the language is used in the bill. This language used in the bill refers to shock therapy. It doesn't specifically refer to ECT, and I fear that this GED treatment would also fall under the definition of, quote, shock therapy. And the fact that the facility does use court processes like this to approve such does concern me quite well.
Okay. Thank you for sharing that with us.
No problem.
Thank you.
Representative Hoffman.
Thank you, Mr. Chair. Oh, I had a question.
Oh, you have a question?
It was quite impressive how much information you got in that 3 minutes. That was like speedy, really, really impressive. Have you ever become aware or witnessed any individuals that have had to participate in this shock therapy that against their will?
So I've spoken to Cheryl McCollins. She's the mother of Andre McCollins, whom was at the facility for, I'd want to say, anywhere from 2 through 3 years in the early 2000s. He was actually part of one of the more infamous incidents regarding the facility where he was actually strapped to a board and shocked 31 times over 7 hours for refusing to take off his coat. And I'm repeatedly involved with her. I talk with her on regular, and she and I are working to hopefully get this GED electric shock treatment outlawed.
Well, thank you for that. Was she opposed to it?
Oh yeah, she was initially not opposed until she went to visit the facility. And then she found her son almost unresponsive, and she looked at the tape and the tape is available online. And she just saw her son on a board just being shocked repeatedly. It got to the point where he was hospitalized for 37 days, and it got to the point where his mother could not even hold up a TV remote without him getting flashbacks. It got that bad, and he still has not fully healed almost 25 years later.
So her opposition was disregarded.
She wasn't opposed at the time, but because of the way they kind of brought the treatment to it, she was initially not opposed to the treatment, but then she took him off the treatment after she saw exactly how the treatment was.
And so that was a long time ago. That was, you said, so that was over 20 years ago.
Yeah, that was over 20 years ago, but they're still using the treatment and they're still defending the treatment actively.
And they're still proceeding in that manner?
So they say that they don't strap people on a board anymore, but people are still shocked for the minor things like getting up out of a chair, raising one's arms.
Okay. Thank you. Thank
No
you
problem.
for your testimony.
There's a quick comment if you want to.
Sorry to keep you jumping up. Sam, I just want to thank you for spending the day with us. I think you've been here since we started at 11 o'clock this morning. I just wanted to, your testimony was very enlightening. And I just want to say thank you for being here and spending the day with us. So thank you. Thank you, Mr.
Thank
Chairman.
you. I think now we are good.
All right.
Thank you so much. And we move to the next person on our list, which is Michaela Fissel. You're remote. Welcome. You're on.
Hi. I just need to take a moment. That was very disturbing to hear. And as a person who has worked in behavioral health services for more than 17 years, the use of restraint, seclusion, force, and coercion is happening every day. I hope that we don't become desensitized to what Sam so eloquently and courageously shared here today. My name is Michaela. I'm registered to vote in Windsor, and I work in the role of executive director at Advocacy Unlimited. We're a peer-led nonprofit. We provide mental health, addiction, and trauma recovery resources. We've been doing work here in Connecticut for more than 30 years. For context, I've worked in behavioral health services for more than 17 years. I hold 2 master's degrees, and I'm a person in recovery from extreme childhood sexual violence, adolescent homelessness, and a myriad of other circumstances that probably should have killed me. Thankfully, I found holistic approaches to recovery that brought measurable and long-term benefits, enabling me to create a life worth living. I'm sharing this because I know the difference personally, as I also remember the deterioration of my mind and body as I was treated with polypharmaceuticals and limited options provided by conventional clinical treatment. While I've spent the past decade studying holistic approaches, I've also advocated for systems transformation here in Connecticut for more than 15 years. Recently, through my most recent master's, I reviewed the research on alternatives to medication and clinical treatment, and I found a breadth of literature that demonstrates the benefits of holistic approaches to recovery that far outweigh conventional clinical treatment offered by psychiatric facilities and outpatient services. It is important that you are aware that treating physicians, some of whom are testifying in favor of this bill today, receive funding from the manufacturers of the treatments they prescribe. This creates a gross and obvious conflict of interest that goes largely unchecked, while successfully increasing the use of electroconvulsive shock treatment funds their jobs and research studies. There are known adverse risks of ECT, including nausea, headaches, all the way up to cardiac events, including mortality risks. Additional points to consider are ECT medical devices are not approved by the U.S. Food and Drug Administration. There are no long-term studies that show ECT is safe or effective. It can cause brain damage, including permanent memory loss and neurocognitive injury. There have been many lawsuits brought against the United States, most recently in 2020, 2021, and in 2023, the World Health Organization and United Nations on Human Rights Office of the High Commissioner issued joint guidance to protect people against abuses in the use of specific mental health interventions, including ECT. There is no medical evidence to support the removal of current safeguards by increasing the time period for court-ordered ECT from 45 to 90 days and increasing the time for consensual ECT from 30 to 90 days. This is an effort amongst treating physicians to find efficiencies at the expense of safety and well-being of our most vulnerable members of our community. The bottom line is this bill is unnecessary. Current law already allows hospitals to apply for new court orders, and it allows for voluntary ECT if the patient signs a new informed consent document. As Sam shared, informed consent requires dialogue, time. Oftentimes, treatment is rushed, and folks aren't making an informed decision.
Excuse me, Ms. Fissel, but you've reached your 3 minutes. Thank you.
Do you want to just complete your sentence and your?
Yeah,
Yeah.
I would ask that you not only reject HB 6837, but I'd also ask that you take it one step further and convene a task force to evaluate the use of ECT here in Connecticut and begin tracking the long-term outcomes of folks who undergo ECT. Thank you for taking the time to consider my testimony. And thank you to Sam for speaking up before me. I really appreciated the space that you created.
Thank you so much for your testimony, and we'll move to the next person on our list, which is Meg Morelli. Welcome, Meg.
Thank you. Good afternoon, Senator Anwar, Representative McCarthy Vahey, Senator Summers, Representative Claritas Detria, and members of the Public Health Committee. My name is Meg Morelli, and I'm the president of Leading Age Connecticut, a statewide membership association representing not-for-profit provider organizations serving older adults across the continuum of aging services, including not-for-profit skilled nursing facilities, assisted living communities, residential care homes, home health agencies, senior housing, and life plan communities. I thank you for this opportunity to testify in support of Senate Bill 1199 and to offer our assistance in clarifying the intent and language of the bill. The concept of having an automated external defibrillator, an AED device, available in nursing homes and assisted living community settings is reasonable. And while most of our nursing home and private assisted community members already make AEDs available, it's important that if this becomes a statutory mandate, that the law is clearly drafted, particularly when it comes to assisted living communities. These are not difficult clarifications to make, and we would like to offer our assistance in doing so. Focusing on the assisted living language, in Connecticut, we don't have a statutory definition of assisted living facility. What's commonly referred to as assisted living in our state is a combination of assisted living services provided by a licensed assisted living service agency that are delivered in a managed residential community that is registered with the Department of Public Health. Recognizing that there are two entities, we first need to determine whose responsibility it would be to supply the AED, and that it's part of the building. It probably makes sense for it to be the MRC, but that would need to be determined. And then next we'd have to decide who would be responsible for ensuring the CPR training as well as the training on the AED, and that staff being available throughout the day. Since the MRC would not be in charge of anything clinically related, possibly this could be a shared responsibility with the ALSA. Well, once these roles and responsibilities are determined, we would be happy to provide suggested statutory language to the committee. We also want to raise the concern that some assisted living services are provided in affordable independent senior housing settings, including our 4 assisted living demonstration models, several HUD subsidized housing sites, and some congregate senior housing centers. In these settings, the ALSA services are part of the service plan delivered through the Connecticut Home Care Program for Elders. We would need to look more closely at these housing sites and may need to assist with the funding of the AED equipment and the training of sufficient number of staff. But additionally, the state congregate housing sites themselves are not classified as MRCs and may not have the staff on site throughout, might not have staff on site throughout the evening. As such, we would ask that the committee consider exempting the congregates and the other affordable housing sites from the certified staffing requirement. We thank you for this opportunity to submit testimony, and I'd be happy to answer any questions.
Thank you so much for your testimony. You have submitted your written testimony as well, Meg, right?
Yes, I did submit
Yeah.
it earlier today, so I'm not quite sure. I apologize
All right.
if you don't
Thank you
have
so
any
much.
answer.
Thank you for that. Seeing no questions or comments, we appreciate you staying with us today and your testimony this almost evening. Next person on our list is Kelly Moquette. Kelly, welcome.
We're gonna do it that way. Good afternoon, Senator Anwar, Representative McCarthy-Vahey, Senator Summers, Representative Claridis Ditria, and esteemed members of the Public Health Committee. My name is Callie Moquette, and I am the Senior Manager of Policy at Health Equity Solutions, a nonprofit advocacy organization with a statewide focus on advancing health equity through anti-racist policies and practices. Thank you for the opportunity to testify in support of SB 1192, an act concerning hospital financial assistance. Nonprofit hospitals are mandated to offer financial aid to eligible patients, yet barriers persist to adequately access these programs. According to the Connecticut Office of Health Strategy, an estimated $100 million of bad debt between 2016 and 2022 can be attributed to individuals who would have qualified for hospital financial assistance. During that same time, Connecticut hospitals invested less in financial assistance and bad debt in the state increased. HES annually conducts community conversations and surveys to gauge the health equity priorities of Connecticut residents. In 2024, HES utilized its annual survey to seek insight from Connecticut residents on their experiences with medical debt. Some key takeaways from the 184 survey respondents include 2 out of 3 respondents said they or a family member had experienced some form of medical debt. 62% of respondents had experienced medical debt, attributed their medical debt to an emergency room visit or to a hospital stay. 77% of respondents said they were not informed of financial assistance programs, charity care programs when seeking care. For these reasons, we are pleased to see the committee introduce SB 1192 and recognize the importance of building upon Connecticut's recent advancements in addressing medical debt. This includes the state's medical debt erasure initiative and the passage of Public Act number 24-6 in 2024, which prohibits the reporting of medical debt to credit rating agencies. While we are grateful for these initiatives, SB 1192 offers an opportunity to advance mechanisms to prevent medical debt rather than to address it once it already has occurred. Notably, this initiative is particularly vital in light of federal challenges, including the potential cessation of enhanced premium tax credits and changes to the funding mechanisms of entitlement programs such as Medicaid. These developments could lead to millions of individuals losing their coverage and becoming increasingly susceptible to acquiring medical debt. The enhanced infrastructure of SB 1192 will put in place to ensure that patients and their families can better access and be aware of the financial resources available to them to cover medical costs. Lastly, we recommend a few additions, which are outlined in our written testimony to strengthen the effectiveness of SB 1192. Our recommendations include adopting presumptive eligibility for financial assistance based on indicators of financial hardship, including individuals who are already enrolled in SNAP and WIC programs, including those with a household income below 400% of the federal poverty level, as already practiced by Hartford Healthcare, Illinois, and Maryland. Require the inclusion of contact information to the Office of Healthcare, the Office of the Healthcare Advocate, and link to the portal in every billing and collection notice. Require hospitals to direct patients to the Office of the Healthcare Advocate prior to initiating a collection process. We are grateful for the committee's consideration and respectfully urge the advancement of SB 1192 to address the accumulation of unnecessary medical debt by improving access to hospital financial assistance policies. HES firmly believes this proposal would be pivotal in addressing and alleviating the medical debt burden for Connecticut residents, as well as advancing equity. Thank you for the opportunity to submit this testimony in strong support of SB 1192.
Thank you so much for your testimony. Representative Kristen McCarthy-Vahey has a question or a comment.
Thank you very much, Ms. Moquette. Thank you. You got a lot of information in there during that time testifying, which is great. And I'd love to just kind of run through the other additions that you all would recommend to this bill. And thank you again to Health Equity Solutions for providing leadership in this conversation. So you talked about presumptive eligibility. So if someone is enrolled in WIC or SNAP, and you're saying Hartford Healthcare has done this, and notifying the patients of the options and the contact information. You talked about those, but I think there were a couple others that I wondered if you could just share a little bit more about those with us.
Absolutely. One of our recommendations is that the hospitals report annually in the community benefit report by race, ethnicity, and language. How many hospital financial applications were actually completed and submitted? How many were incomplete? We know that Connecticut specifically has extreme shortages when it comes to data, and we want to find out where those gaps exist, but we can't do that without collecting this data. We need to know by race, ethnicity, and language, especially because the hospitals are not currently required to report it out in that basis. And we know that they already do an annual community benefit report to the Office of the Health Strategy. So we'd like to see that included as well. We'd like to see oversight from the Attorney General's office. We know that several states neighboring us have already included uniform applications, but because they weren't mandated to be used or created, a lot of those states, such as New York, Maryland, and North Carolina, don't actually have a uniform application. And so as written, the bill conceptualizes the creation of one, but doesn't mandate an actual creation or use. And so we'd like to see a uniform application actually be mandated to be used by all Connecticut nonprofit hospitals.
That's great. And the last one I would ask about is the minimum income threshold of 400%. Can you speak to that one as well?
Yes. So right now, the federal poverty level is about $15,000 for a single family person of one, right? And so 400%, while it sounds like a large number, really isn't. And that's literally still working poor. And so we know that medical debt in our state is running rampant. We are grateful for Governor Lamont and his pathway to erase debt, but he's going to be addressing debt for 23,000 Connecticut residents, and over 280,000 Connecticut residents currently hold debt. We hope that by increasing the federal poverty level requirement, it will ensure that those who are already struggling to choose between meeting their basic needs, feeding their kids every day, no longer have to forego getting regular care and are able to get the financial assistance policies. Again, several hospital systems within Connecticut already do that. Hartford Healthcare and Yale New Haven hospital systems already offer financial assistance policies or have policies that exist that do 550% of the federal poverty level.
That's extremely helpful because you're right, 400% does sound like a lot, but the perspective really is good for us to hear. Also, just the 280,000 number, that is an enormous number. So that many people in our state are dealing with medical debt speaks to the need for this bill. So thank you again for your advocacy and work on this.
Absolutely. Thank you.
Thank you so much for your testimony, and we
Thank you.
appreciate it. Seeing no other questions or comments, we'll move to the next person on our list, which is Sarah Adams, who's available remotely. Welcome. You're on.
Hi, thank you so much, Senator Anwar and Representative McCarthy-Vahey and other members of the Public Health Committee. I'm here to take a few moments of your time today to talk with you about HB 6835, an act adopting the Physician Assistant Licensure Compact. I am currently a practicing PA here in Connecticut for the last 17 years in the field of neurosurgery, and I am also the immediate past president of the Connecticut Academy of Physician Associates. While working at the Neurosurgery Ayer Science Neuro Institute at Hartford Hospital, my practice there includes caring for patients with brain tumors requiring nuanced neurosurgical procedures, patients admitted with neurovascular emergencies such as aneurysms and arterial venous malformations requiring emergent treatments and extensive multidisciplinary critical care, and additionally polytrauma patients with severe brain and spinal cord injuries. My patients fall into two categories: patients who carefully chose the team at Hartford for their care, and then those who end up there by chance. These patients come from our own state, many from neighboring states, and even other outside countries for their care. This care courses are often very long, they're complicated, and followed by stays in rehabilitation or with family. Post-hospital care includes multiple visits, evaluations, multiple imaging studies, and many subspecialty appointments to ensure their optimal recovery. During post-hospitalization care, we often utilize virtual health visits to limit the burden and time or cost of transportation on these patients. The difficult part is that many of these patients end up in rehab centers or with family in outside state locations. That really limits my availability to continue continuity of care for these patients based on my licensing here in Connecticut. The compact would enable me to easily extend my practice licensure without the administrative and personal burden on the healthcare system as well as myself to be able to care for my complicated patients. An additional subset of patients that I see quite often in practice are those that are followed longitudinally, for known brain tumors with serial imaging annually or semi-annually. These patients may still choose to relocate, but desire continuity of care with their established team who's been following them for a number of years. Often I will virtually see them for imaging review, but this is limited by their location and again, my state licensure. The similar principle exists in patients in our neighboring states who wish virtual consultation for imaging review and surgical second opinion. As previously mentioned by Jason Privilege, who gave some earlier testimony, my current institution is within the bounds of the state, but I suspect, given the expanding landscape of organizational medicine, that this may not be the case in the near future. The compact will significantly help those of us who anticipate this change and will likely end up practicing regularly in multi-state offices and/or locations. The compact would certainly ease administrative, financial, and temporal burden on PAs who provide care in multi-state locations. It would certainly allow PAs from our neighboring states to fill the care gaps that exist here in Connecticut. And most importantly, it would increase patient access to care and improve continuity of established patient and provider relationships. Thank you very much for your time today, and I'm happy to answer any questions you might have.
Thank you so much for your testimony, Sarah. We appreciate the work that you're doing.
Thank you.
I do not see any comments or questions, but appreciate you and your colleagues for the work that you do every day.
Thank you so much.
And next is Judy Chen. You're on.
Hi, everyone. Good afternoon, and thank you for this opportunity to provide testimony for this very important public health issue. My name is Dr. Judy Chen, and I'm a psychiatry medical resident at the University of Connecticut, and I'm here to advocate for my patients who are too ill to advocate for themselves here at this hearing. I support Bill 6837 to increase the length of an ECT over objection decree from 45 to 90 days. In my short and early career thus far, I've had impactful experiences with patients who suffer from severe depression, psychosis, mania, and catatonia, as well as the challenges their family and friends face. I want to provide a brief case of a patient in her 60s with severe and repeated episodes of catatonia. She was not eating, drinking, bathing, or even speaking. In the last 4 years, she had over 10 hospitalizations, and this presentation was happening repeatedly. Mostly due to catatonia, a couple for other medical or surgical reasons that were actually difficult to treat due to the catatonia and her resulting mutism. Many of those admissions lasted over a month and required continued ECT in the outpatient setting after discharge. Her family supported ECT and was willing to bring her to every treatment needed, given how much the condition impacted her life. These admissions required ECT over objection, and she was unable to consent. Patients with severe catatonia may also be subject to unnecessary and high-risk medical procedures when they can't communicate their needs and symptoms, as catatonia can also resemble other life-threatening illnesses, including infections. For patients like her, 45 days is simply not long enough to both complete treatment nor see whether there is appreciable improvement in symptoms. Some patients return to baseline in a few treatments, others require many more. When 45 days are up, treatment is abruptly discontinued and delaying care, deteriorating clinically, worsening quality of life, and increasing medical costs. This bill is not taking away the restrictions and processes already in place for one to be granted ECT over objection. This includes independent examinations by board-certified psychiatrists, right of the patient to legal counsel, and proceedings through a formal probate court hearing. It would simply increase the length of the statute if granted by a probate judge. Thank you.
Thank you so much for your testimony. And I see no questions or comments. Thank you, Dr. Chen, for your testimony. We'll move to the next person who may be physically here, Katia Rueta Deli. Welcome. Thank you for being with us all day.
Yes, thank you. Dear Senator Anwar, Representative McCarthy-Vahey, and esteemed members of the Public Health Committee. My name is Katia Rueta Daly, and I am a resident of Vernon, Connecticut. I serve as a community engagement manager at the Health Care Advocacy organization, and I am here to express my strong support for SB 1192, an act concerning hospital financial assistance. We know that medical debt is a growing contributor to economic and health inequities. Disparities in income, wealth, and insurance coverage disproportionately impact communities of color, making them more vulnerable to the burdens of medical debt. Financial assistance policies, also known as charity care, are essential in preventing medical debt from happening. So I want to share our experience of my father's experience with navigating hospital financial assistance programs. After a blood test indicating that he had tuberculosis in his body. He sought an X-ray at a local hospital to determine whether he was contagious. At the time, he did not have health insurance, so we inquired about the hospital financial assistance program, and the hospital staff was able to provide us with a phone number to their patient navigator, whom I called multiple times a week for several weeks to discuss a possible payment plan. As my father does not speak English, I took on this responsibility to ensure we received the necessary support. And unfortunately, despite my repeated attempts, we were never able to reach this patient navigator. And we received the bill 9 months after he had received that X-ray. So from March of last year until January of this year, my father lived in constant state of stress, uncertainty about whether he had been billed, sent to collections, or if he owed debt that he didn't even know about. No one should have to wait nearly a year to just find out how much they owe. Patients should have timely access to financial assistance and clear communication from hospitals, not months of uncertainty and anxiety. My father's experience is a stark example of the systemic barriers and health inequities that exist within the hospital billing and financial assistance process. SB 1192 is critical in ensuring the hospital financial assistance is more accessible and equitable, and preventing patients from falling into medical debt and facing financial hardship. I additionally urge the committee to strengthen this bill by incorporating the following provisions: alternative income documentation. So applicants should be allowed to submit alternative documentation to verify income and determine eligibility for assistance. This flexibility is crucial for ensuring more people receive the support that they need. And increased transparency and accountability through hospitals be mandated to report on race, ethnicity, and language data regarding financial assistance allocations. This data should include a number of patients receiving assistance, those referred to collections, and those facing legal actions, categorized by REL demographics. And transparency in these processes will help ensure equitable access to financial support. Again, I thank you again for the opportunity to testify in support of SB 1192, and I strongly urge you to the committee to pass this bill. Thank you.
Katia, you packed up everything into those 3 minutes. I said, oh my
Yes.
God. You like have the whole bill ready there.
Yes.
Love it. Congratulations. This is
Thank you.
amazing. Good. Seeing no other comments, I think your testimony is very valuable, and what you and your organization are doing is some amazing work. So we appreciate you so much.
Thank you so much.
Thank you. Next is Adriana Lopez de Victoria Martinez. ¿Cómo estás? Bien.
No, okay. Good evening, Senator Anwar, Representative McCarthy-Vahey, and esteemed members of the Public Health Committee. My name is Adriana Lopez de Victoria, and I am a resident of West Hartford, Connecticut. I am also a recent graduate from UConn Storrs and a current Master of Public Health candidate at UConn Health. Today, I stand before you in support of SB 1192, an act concerning hospital financial assistance. I moved to Connecticut in 2021 when I was 18 years old to further my education at UConn. I came by myself with no friends or family in the state to help me navigate things such as accessing medical services and making sure they were within my insurance network. My junior year, after feeling ill for weeks, I decided to seek medical care, and a few weeks later, I received a bill in the mail for over $500, stating that my insurance would not pay for my tests. As a young full-time student who also worked and made just enough to pay for her expenses, my bill ended up in collections. I was luckier than many others. My bill was smaller than most, and I was able to pay it off eventually. Still, in the months it took me to pay it back, I continued getting bombarded with bills that provided very little information about my rights, with no payment alternatives and no support for patients unable to pay. As my pile of bills grew and grew, I felt dehumanized, not cared for, and more isolated than I already had been feeling in this state. While these services weren't at a hospital, my story echoes that of so many others who find themselves facing surprise hospital bills too large to pay back before they are sent to collections. This leads to people who, just like me, avoid seeking healthcare services altogether. I did not return to the clinic or any other healthcare services in the area during my time at UConn over a fear that I would end up back in the same situation or one much worse. Unfortunately, this is the case for so many others throughout the state, with Black and or Latina individuals disproportionately having these experiences. In the fall, I will be starting medical school, a dream that I have worked towards for more than a decade. I share this with you all because this is a lifelong dream that has been tainted by the reality that as a physician, I will sometimes have to ask my patients to make this difficult decision between being healthy and in debt or remain sick to avoid additional financial hardship. With this, I urge you to break this cycle and not continue condemning your constituents to this fate. Passing this bill would not only protect patients from accruing debt in the first place, but also increase medical trust and utilization of healthcare services before it is too late. I have included some suggested amendments to the bill language in the written version of this testimony for your review and consideration. These echo the same sentiments shared by Rosanna and Callie, who testified before me, and also Katia. And in summary, I implore you to please do your part in protecting the health and dignity of Connecticut residents. I strongly urge the committee to pass this bill with the suggested amendments. Thank you.
Gran testimonio. Congratulations.
Thank you.
This is your first one too.
Yes, it is.
Thank you for sharing this. This is very important and this is very real. And the reason for this bill is we can prevent this from happening. And we are preventing this without increasing the cost to anybody. And that's why this bill has so much value that the taxpayers aren't paying for this. The hospitals are supposed to do this. That is by law. And there's no reason why an individual like you and others should have had to have their life be impacted by this way. So thank you so much.
Thank you.
Representative Kristen McCarthy has a comment or
Yes.
question.
Oh, you're shocked. I have a comment. I just want to say thank you. This may be your first time testifying, but I know clearly this will not be your last time testifying. And as you framed that, I think that was an incredibly powerful thing that you said to us, that as a physician, that you shouldn't have to be having people make the decision between remaining healthy or being in debt. It's very powerful. Thank you.
Thank you.
Representative Kennedy.
Thank you. Thank you for your testimony. It was very well. I was just looking, I didn't see, are you going to submit your testimony in writing?
Yes.
So we can have it, because you mentioned in your testimony that you had some suggested amendments.
Yes, I submitted it earlier today,
Okay.
and it just must have not been added
Wonderful.
yet.
I look forward to reading those proposed amendments. Thank you so much.
Thank you.
Thank you, Mr. Chairman.
Seeing no other comments or questions, muchas gracias. Hasta luego.
Muchas gracias.
And next we have Adam Kay. Welcome.
Thank you. Senator Anwar, Representative McCarthy-Vahey, Senator Summers, Representative Claritas Ditria, and members of the committee. My name is Dr. Adam Kay. I'm a resident of Fairfield and a practicing radiologist at Advanced Radiology, as well as the chair of radiology at St. Vincent's Medical Center in Bridgeport. I do apologize for not wearing a white coat, as I know many of my colleagues do, but us radiologists don't wear them too often, for one, and two, because of the snow, I was actually sequestered here in my home office today. So I'm here today in support of Senate Bill 1191, an act establishing a pancreatic cancer screening and treatment referral program. About 4 years ago, myself and many others in my practice were closely affected by pancreatic cancer when one of our partners, Steve Cohen, a doctor who was a friend and mentor to me, was diagnosed with stage 4 pancreatic cancer after finding it incidentally on a cardiac screening exam. Steve was an amazing person, an even better doctor, and was well known to state legislatures. He was very involved in advocating for his patients, both at the state level and nationally, and battled his disease for a year before ultimately succumbing to it, leaving behind a loving family, a practice that to this day has a hard time replacing his intellect, his dedication, his passion for patients, and his mentorship of myself and many others in the medical community. Then just over about 3 years ago, this terrible disease struck me personally again as my good friend Allison, somebody who I went to kindergarten with, who's become one of my wife's best friends, and whose son is one of my daughter's oldest playmates, was diagnosed with stage 4 pancreatic cancer. Allison was undergoing screening for multiple cancers, not including pancreatic cancer, for her BRCA gene mutation, when she had some vague belly symptoms like bloating and pain, and eventually was subsequent imaging led to her diagnosis of stage 4 pancreatic cancer. Allison's an amazing human. She's battled her disease with courage, grace, and humor, and it is a battle that thankfully she continues still to this day with us. Pancreatic cancer is the leading cause. You've heard from You've heard from several people, including Mr. Varelli, who, beyond his excellent sartorial sense, is very knowledgeable about pancreatic cancer. So I will try not to repeat too much. But pancreatic cancer is the third leading cause of cancer-related deaths in the U.S. Its 5-year survival rate is less than 12%. It's often diagnosed late in its course when the disease has already advanced and spread to other organs like the bile ducts, the liver, and the stomach, and treatment options can be very limited. This is why pancreatic cancer screening matters. Detecting any cancer can save lives, but unlike breast, colon, lung, cervical cancer, there's no routine screening program yet for the general population. Screening for pancreatic cancer is typically reserved for individuals at high risk, such as those with a family history of the disease, certain genetic mutations, or variations or conditions like chronic pancreatitis. Technology is getting better, and we're getting a better understanding of cancer genetics, which is opening a lot of new doors in pancreatic cancer screening. And using techniques like MRI, studies like MRI that I do on a daily basis, is making it easier to screen patients and catch this deadly disease early and earlier. However, we need more widespread awareness and research investment to make screening accessible and effective for more people. This requires a collective effort by doctors, researchers, and advocates, but also by policymakers and legislators working together to build better tools and ensure that screening programs continue to get better and better at finding cancer while these patients still have options. By taking action, we can work toward a future where pancreatic cancer is caught early, treated effectively, and no longer carries such a devastating toll. Thank you for listening to my testimony today. I'm happy to answer any questions. And Senate Bill 1191 is a life-saving proposal. I'd be happy to answer any questions.
Thank you so much for your testimony, Dr. Kay. Representative Kristen McCarthy-Vahey has a question and a comment.
Dr. Kay, I just want to say thank you. I could hear the emotion in your voice as you were sharing about the people you love. And I appreciate that you're reminding us when we talk about numbers and statistics and things like number 3 in the nation, number 2 in Connecticut, it's the human impact. That is why we do this. So I want to thank you. I think it's very fitting that you followed a student who is headed into medical school for her first testimony. And Dr. Kay is a phenomenal example of a physician who has consistently advocated for patients in this building. So thank you for lending your voice to this cause.
Thank you for the kind words, Representative.
Seeing no other comments or questions, we thank you again, and we hear you loud and clear.
Thank you.
Next person on our list is Francisco Lopez. Welcome. Francisco Lopez, you can unmute yourself and you can turn your camera on. Going once. Going twice, Mr. Francisco Lopez. All right, moving on to the next one. And our list is Michael May. Yeah.
Hello. Hi. My name is, thank you to Senator Anwar, Representative McCarthy-Vahey, and other distinguished members of the committee for hearing my testimony in support of HB 6837. My name is Dr. Michael May. I am a psychiatrist working at UConn Health John Dempsey Hospital, where I serve as the medical director of our inpatient unit. I have lived in Connecticut for the past 20 years and am an alumni of UConn for my undergraduate, my medical school, and my residency training in psychiatry. And I oversee the treatment of our most ill patient population who are unfortunately often invisible to legislation and advocacy representation and go on to suffer as a result of often well-intentioned protections. As an educator of medical students and residents, I want to help educate the committee by illustrating a clinical entity our patients experience on the inpatient unit to explain why ECT is so vital to our practice of psychiatry. ECT is the most effective treatment for our patients suffering with a psychotic disorder who then progress into a condition called malignant catatonia. Psychosis is a disorder in the mind of a patient where they can no longer categorize their thoughts and they lose the ability to discern reality from fantasy. They are often barraged by frightening voices or illusions, at times not knowing whether they are alive or dead. When they spend too long in this state, they become catatonic. This is experienced as a state of complete disconnect from the outside world due to extreme fear that losing your grip on reality often causes. This condition can progress to malignant catatonia, as the intense and prolonged adrenaline response from their psychosis can lead to death by hyperthermia, heart failure, and other organ failure. This clinical problem, fortunately, is not common, but it is devastating when it occurs. Broadly, the only treatment for psychosis is a medication from the antipsychotic class. Unfortunately, this class of medication also worsens catatonia. Catatonia can be treated with a medication in the benzodiazepine class, but this treatment is akin to using Tylenol for a fever caused by an infection, whereas the antipsychotic might be the antibiotic treating the underlying infection. The only option that will treat both of these life-threatening conditions simultaneously is ECT. The mortality of this condition can be as high as 20% and higher when timely access to treatment is restricted. This is just one example of how this treatment can save lives. I support this bill because our patients already suffer enough without having to also face increased scrutiny or barriers to treatment. The existing legislation may benefit a small number of individuals by providing this safeguard, while unfortunately exposing our most severely ill patients to potential lapses in life-saving treatment. I feel strongly about advocating on behalf of these patients I treat, who are too chronically disabled to speak before you today about their experiences. I want to highlight that opposition to this bill by patients represents the opinions of our relatively less disabled population, compared to those who are most negatively affected by the current legislation. The individuals I am advocating for are not able to organize themselves to sit in front of you today or to convey their stories through written word. Thank you, and I invite any questions from the committee.
Thank you so much. So Dr. May, can I help understand something? Today, a number of patients had come and disability rights representatives that we value and respect, and nobody wants to support this. Can you help us break this down and help them understand why you support this and from a medical point of view, but also making sure that the individual's rights are protected when this is being suggested?
Yeah, I think, I think the advocacy groups that are trying to protect the rights of patients are doing really important work, and psychiatry has harmed a lot of people in the course of the way that it's been developed. I mean, in the very early stages of psychiatry, they used to pathologize things that we now celebrate, although the pendulum's kind of switching back. Things like homosexuality used to be called a disease. And so I think the work that they're doing is important, but when advocating, they hear the voices of patients who are able to speak for themselves, who are able to be seen by these advocacy groups. And yes, some of them have suffered greatly, and that is really unfortunate. But the piece that I think gets missed are the patients that are not seen by these advocacy groups. It's the patients that cannot speak on their own behalf because they're so disabled that they struggle to really live day by day. I'm not sure if I actually answered your question, but that's what
I think sometimes the people who are not in the room are the ones that everybody's trying to protect, and they may have a different experience and understanding. And it does not mean that even though people are disagreeing because they're looking at the problem from a different angle, but the intention for everyone is to be protective. So I think that's an important aspect to keep in mind. There were some medical students who had spoken earlier, and you are at UConn, right?
Mhm.
So and as we were asking them questions about informed consent, they were speaking at the level of a medical student, but you're an attending. So do you think you can answer some of the questions that were asked of the medical students?
Of course, yeah. So just generally, when we think of informed consent, it's the question that I always ask myself is I try to understand who this person that I'm treating is. What are they like when they are at their baseline? What are they at? Well, I ask people that know them well, tell me about your loved one. What do they value in life? What kinds of things do they believe in? And if they were in that state of mind, what would they want for themselves right now? And so I take all that into context, and then I evaluate the person and ask them really directly, what would you like right now? And I try to make sure that whatever they are saying that they want is in line with the person that I've come to understand, who is, when they're well and healthy, they want to live, they want to, So if they are telling me something that is not in line with that, if they're making a decision like, I want to forego treatment so that I can die, I understand that that is part of their illness, because when I ask their loved one that, is this what they would want for themselves in their normal state, and they say no, that's part of what I believe informed consent involves. There are some very specific criteria where we talk about, the capacity to consent, and, the medical student Jordan, he did a fantastic job of, I think, outlining the specific criteria that are involved. What I will add to that is, because I think someone asked him, what if a patient says, no, I don't want this, no, I don't want this, shouldn't that be enough? And I will pose it back to the committee. Let's say you have a loved one who's in the hospital and they're kind of confused. And the only thing that they know is that they're really scared and they don't want to be there, and they just say no, 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 no to treatment, no to treatment. As their family member, how would it be for you if you knew that the hospital just took them at their word and said, okay, well, then we can just, discharge you if you don't want any treatment. They end up going home and then passing away. That's what we're trying to protect against when we say that someone does not have capacity to consent to treatment. That's why it seems like that's why some people have the impression that if a patient gives us an answer that we don't like, that's when we start asking questions. It's because I think at the core of any person who's providing healthcare is trying to imagine, what would I want for my loved ones? If my mother were in the hospital, of course, I would want her to get, fully treated, and for her not to have a horrible outcome like that. And so I think that's really at the heart of informed consent. It is, what is the compassionate thing to do in this instance? What would I want for one of my loved ones?
So I think you're looking at the competency of that individual, but if you determine that the person is competent and they understand and they say no, that means no.
That's correct. If they say no, and this is in line with what they would want normally, and they can express their opinion
right
that way, yeah, absolutely.
So I'll break it down. So if there is somebody who has severe depression to the point of not reach the catatonic state, but they have been in that position, and if they are deemed competent, if they say that they want ECT, it's an easy answer, correct?
If they say well,
if they agree to it and consent to it, then it's easy. Then they get it.
Not necessarily. In fact, sometimes I would love to just give ECT to someone who I know needs it, and they're saying kind of superficially, yes, I want it. I do have to hear them kind of express that that is what they want, because that unfortunately is the law. That right. So even if they're agreeing with my decision, if it doesn't seem like they really understand what they're saying, we still go through the court. We still ask, Judge Daly, who spoke first earlier today, and we go to her and we say, look, this person wants ECT, but I don't think that they're able to make that decision right now. We agree with them, but please, help us make this decision on their behalf.
So no, I probably did not clarify my question. If a person is deemed competent and they say that they want ECT when it's medically indicated, then they will get it without having to go through the judge.
Oh, yes, sorry. I misunderstood. Absolutely. If they say yes, they want it, and we think that it's
So
necessary.
second scenario, sorry, I'm interrupting you. I just want to get these points quickly. If this, in the second scenario, if the person is deemed incompetent, but they have a conservator and they need medically an ECT, and the conservator says yes, they cannot get the treatment without the probate judge weighing on this.
That is correct. There is legislation that removes that right from a conserved patient. As soon as you're conserved, you lose the right to consent to ECT.
And what if the conservator says no and the person needs that? And what happens in that situation?
As the legislation is written right now, it doesn't actually affect anything. We still go to the court if we, the physicians, feel like this is the right thing, and then the judge does make a decision. That's just the way that the legislation is written now. I'm not saying that's, right or anything like that, but that is how it is currently.
Okay, and the issue comes down to is that it's a logistical challenge. Now, overwhelming majority, well, overwhelming at least from the numbers, from 150 down to 40 who needed it, and from Dr. Sukera's example, and of the 40, it comes down to 6% of them may need repeat treatment. So we're talking about a small group of individuals who would benefit from this legislation so that they would not have, or their loved ones would not have to take them to the probate court on a very regular basis. That's the conversation this time, is that those 6% or so of the patients of the total amount, they are the ones who may need some help, not to have to go to the probate court every 45 days. Is this how you understand this too?
Yes, I do understand that the patients who would benefit from this change are in the minority by a long shot. And I think that that's why we need to advocate for them. They go on unnoticed in society, and the things that they have to endure, the suffering that they already go through, I think that's why they deserve the protection from the state to decrease the barriers to the treatment that they really desperately need.
And there was somebody who spoke about some other kind of shock therapy was equal to ECT. Did you get to hear that testimony?
Yep, I've listened to every testimony today, and I can't, I don't really, I've never heard of whatever it is that they were talking about. It sounds like some kind of corporeal punishment that was being enacted on people, which is horrible, but I don't think has anything to do with ECT.
Okay, so I wanted that to be clarified because I know that if the general public was hearing about from that testimony, there's a mention of something that happened to somebody 20 years ago, but had nothing to do with ECT, but it was some kind of a electric thing that was going on, which that person felt was ECT, but it's not ECT. Can you confirm that in your understanding?
What he described, the GED thing, is not at all consistent with ECT.
Okay, I just wanted to clarify this. Thank you for that. I know my colleagues have some questions. Representative Andolphine, please.
Thank you, Mr. Chair. I just wanted to follow up. I might have missed something you said, but the scenario is the patient says no, the conservator says no, but the physicians think that this is needed. They go to probate court to get permission to do that?
That is a hypothetical situation that could happen with the legislation as it is currently written. Oftentimes that is, I think physicians are human and have compassion and will generally see that, okay, nobody wants this to happen, and it is within the right of, within the wishes of the patient, if we could assume when they were well. So it's just a hypothetical situation that can occur the way that the legislation is written as it is.
Well, I think it speaks to what Representative Anwar was, or Senator Anwar was speaking about with regard to agreeing with what the medical suggestion is. If the patient agrees and says yes, they move on. If the patient says no, then that's when everything goes through the process and the court process. We did have some witnesses or some testimony with regard to situations like that, so I'm not sure it's hypothetical, but I'll just leave it at that.
Well, the patients that were speaking today, I don't think any of them were conserved, or at least I did not hear that that was part of their situation. The conservatorship aspect of things, where you might go against both a conservator and the patient, I don't think I've ever encountered that before, but again, it's a hypothetical that could happen with the way the legislation is currently written, and we're not even touching any part of that piece of the legislation.
Thank you so much. Representative Biggins has a question and a comment.
Thank you. Thank you, Dr. May, for your time, and thank you for being here to answer some questions. One of my questions, I have two questions, if I can. How many patients do you see that after 45 days don't show any improvement?
So probably zero. I don't think I've ever seen a patient who did not get better after 45 days of continuous ECT, but honestly, if a patient is not responding at all in my practice, if they're not responding at all after 12 ECT sessions, I would be very unlikely to continue that treatment because, yeah, it is a lot to have to go through. And if it's not obviously helping, then I would stop it. I can't speak to what others would do, but to answer your question, zero. I've never seen a patient that met that.
Well, thank you. You also answered my second question with your answer to my first question, so I appreciate that as well.
Representative Reddington Hughes.
Thank you, Doctor. Doctor, to follow up on the last question, if that is the case with the people that, would be seeing some sort of positive movement in the first 45 days, then would you suggest that we safeguard this and say that in the event that they are seeing a positive movement in those 45 days, that this would apply so that we would not have a loophole, in which case somebody who was not seeing that improvement would have to endure 90 days?
I think in theory, that sounds like a wonderful compromise. The question is who's going to determine if they're getting better. And if the physician is the one determining that, then I don't know if that actually protects patients who are getting ECT when it isn't helping, right? In the case that there's some nefarious physician out there. And I think that, we've done a lot of thinking about this legislation over the last few months as we've been kind of meeting with people and getting opinions on things. And it turns out this is really quite complicated. There's so many fringe cases that, it's impossible to cover absolutely everything. But what we're trying to do is help in whatever way we can for this very vulnerable population.
But would you not agree that the amount of nefarious doctors out there would be so low that it would almost be inconsequential if we did that?
Your suggestion of if things are going well at the 45-day mark, that there would be like a continuation of that decree without having to go to the probate court. Is that what you're saying?
No, I'm saying that if this were to go through, that there would be a provision in it that would safeguard people so that they would not get stuck in 90 days if this was not showing any improvement. Because as it is stated, they would.
Yeah, I mean, I think having a safeguard for that in the case that there's something like that happening would be good. I heard some other testimony about codifying an appeals process where there's a stay of the order if a patient is appealing. And I think that, yeah, there's a lot of work that should be done on this so that we can make legislation that makes sense and both protects a lot of people and makes this accessible to people who really need it. So I'm fully in support of, yeah, really doing some more work on this.
Thank you.
Can I also clarify one more thing, Dr. May? Sorry, we're taking a lot of your time. So don't send us a bill. What I wanted to ask you was, are there conditions where an individual will need ECT on a regular basis, as was described earlier, for a case where an individual needs it after every certain amount of days, and that allows that young individual to be able to function as opposed to completely change, the personality completely change if there's a waiting time. So it's not like a one time and done or within 45 days and it's done. It's more of a ongoing treatment for a segment of that population.
Yeah, so the patient that Judge Daly was referring to, who has the regressive version of Down syndrome, that person needs ECT just to maintain a level of functioning that still does not allow them to really engage with life in the way that we think. It's there to maintain him, and if he were to stop, he would have an incredible kind of decompensation. That's the type of person that we're trying to protect, and that those are rare conditions, which is why I think they don't get much attention, but the quality of life improvement for that individual is so massive when they're able to get ECT regularly, and the barriers of, his poor mother who has to go to the court every 45 days to sit through a court hearing to hear a reminder of just how disabled her son is. That's someone who deserves our compassion and protection from something like that, or at least to decrease their suffering.
And who speaks on their behalf? Because I do not see anybody from the patient population come and speak on behalf of individuals like that who are benefiting from them. And the ones who spoke, they said, well, it's okay for them to keep going to spending like multiple days getting a lawyer and then getting to the probate court on a very regular basis. So who's speaking on their behalf?
I think, we are. I personally see all these patients. I treat them. I see how much their families suffer. And I think some of these advocacy groups don't see them. I think they have never interacted with individuals who suffer in that way because they're not, again, they're kind of invisible to society. Whereas the people who can speak, who are seen, who are able to get themselves to places and can sit in front of a laptop or in front of everyone whose voices are heard, they have people advocating for them. But I don't think anyone really advocates for the severely disabled who really do need this life-saving treatment.
I think that's what I wanted to make sure that people get to understand, that there's some people not in this room. There's some people whose voice is not in this room, and the legislation is for those voices. And it is not going to have a negative impact on other people because the number of people who are going to need this are very, very small, but it's very meaningful for them to actually have a protection for those individuals that are not able to come and speak, or their families are completely bogged down not to be able to be here. So I appreciate your time. Thank you so much for your testimony. Thank you.
Thank you.
And we'll move back to Sarah Hancock. Welcome. You're on.
Hello, honorable members of the Health Committee. My name is Sarah Price Hancock. Thank you in advance for allowing me extra time as an appropriate accommodation for using a speech generating device. I was that patient with malignant catatonia. Doctors who support this bill and maintenance ECT have no subspecialty training in biophysics or histopathology of electrical injury. I cannot speak for myself, so I must use a speech-generating device. Let's talk safeguarding taxpayers' money. Let's talk safeguarding taxpayers' money. I find it interesting HB 6837. Proponents omitted detailing that its passage means increased access to a 72% raise per treatment during fiscal year 2025 compared to 2024. One Massachusetts hospital reported completing more than 18,000 ECT treatments in 2018. Is it any wonder Connecticut hospitals want to remove barriers to shock treatment? The following things were not disclosed in my informed consent process or to members of this committee. While the psychiatrist speaks for giving ECT, I speak for those who need rehabilitation after they are injured. The committee should know upfront that ECT devices are not FDA approved. If rebooting a computer with a power surge was effective, none of our electronics would have surge protectors. According to the FDA, there is no evidence to support the claim that ECT is life-saving. Not even the FDA has evidence on record supporting this claim. Dr. Bennett Omalu, neuropathologist, who first identified chronic traumatic encephalopathy in the nation's football players, stated, electroconvulsive therapy must be viewed through two lenses: repetitive traumatic brain injury and repetitive electrical injury, because of natural laws governing electricity's contact with the human body do not bend for benevolent intent. The Journal of ECT explained that ECT involves the purposeful stimulation of the trigeminal cardiac reflex. But purposeful stimulation of the trigeminal cardiac is against medical ethics because of risk outweighs the benefits. Consequently, ECT causes major heart complications in between 1 in 15 and 1 in 30 recipients. 1 in 93 ECT patients die within 30 days. The leading cause of death is cardiac failure. In one study of electrical injury, the mean delay for onset of motor neuron disease is 44 months. Repeatedly pulsing nearly an ampere current through cranial nerves and brainstem for 8 seconds has consequences. I now live with symptoms of upper motor neuron lesion syndrome. In 2022, researchers examined 20 years of Medicare data and discovered people with a history of just 10 ECT treatments have more than double the risk of developing ALS before age 65. That risk triples after age 65. I had 116 ECT treatments. I am only 49. My neurologist told me at my last appointment that there is no treatment plan for my deterioration. For that reason, I feel that ECT is unmonitored, unregulated, human experimentation on unwitting participants. Extending its use with reduced informed consent provisions is inhumane. A vote in favor of extending ECT use without sufficient probate court barriers is a vote in favor of exorbitant medical costs associated with providing care for someone like me who develops delayed electrical injury. It is also a vote against protecting people like me from the overprescribing of ECT. Extending ECT use without reviewing the consent means the taxpayers will also be held financially responsible for potential lawsuits involving this gross abuse of human rights. Thank you for this opportunity to share real-world evidence on the immediate and long-term consequences of electroconvulsive therapy. Please vote no on House Bill 6837.
Thank you so much, Ms. Hancock, for your testimony. It's very important to get to hear your perspective. We appreciate your testimony. Is there anything else you want to add?
My written statement with all of the documented research and court outcome.
Thank you. We will look at your written testimony. We appreciate that. Thank you so much. Seeing no questions or comments, we will move to the next person. Again, thank you so much for waiting and being able to testify and share your experience. And I'm so sorry you went through so much.
Thank you.
Thank you. Next one is Michael Biondi.
Afternoon, can you see and hear me?
Yes, we can. Thank you.
Very good. So as you said, my name is Mike Biondi. I'm a radiologist. I've been living and practicing here in Connecticut for the last 14 years. And I'm also the current president of the Radiology Society of Connecticut, and I reside in West Hartford. Now, it's come to my attention that you've been here for a very long time and that you've learned a great deal about this bill. So we'll just reiterate very quickly what a terrible cancer that it is, and that the best way to deal with it is early detection. And that's where this bill is so wonderful, is because of the education that comes with it to help physicians to learn to actually check and learn and ask people's family histories, to check their genetics, and to see if these are truly the people that should be checked. Because obviously we're not going to be screening everyone. It's just a remote, small group of people, but it's really life or death for them. In our own society, we had a Dr. Stephen Cohen, a wonderful man, who was diagnosed and passed within months, which was terrible. So again, the best parts of the bill in my mind are the professional education that would come with it, and the registry. Any woman who's sitting in the room who's over 40 who's had a mammogram knows there's how well we follow that and how great it is and how important it is, because life gets very complicated and you may be the best patient on the planet, but people forget, and it's nice to have a reminder, a phone call or a letter or someone who's looking out for you. It's particularly important, not so much for like myself or maybe someone in the room. I've got a physician, he knows my history, he sees me every year, it's the same person every time. It's terrific. I think it's really important for people who maybe don't have their regular physician, who go to clinics, who are poor, don't have the best care, who get treated very quickly and sent out the door, and no one's asking them, did your father have cancer? How did they pass away? How did they get missed? And I think this bill would really help with those people. So again, we are a resource for you if you need anything, and I will cut this short. And if you have any questions, please feel free to ask.
Thank you, Dr. Biondi. We're so grateful that you're here. We have a feeling we'll be seeing you again later this year. Thank you for raising those issues around the registry and the role of for those especially who don't have access to primary care. Thank you.
Very good. Thank you.
Representative Zupkus has a question or a comment.
Thank you, Mr. Chair. Thank you for coming, Dr. Bondi. And so would you suggest, so when we talk about pancreatic cancer screenings, would you suggest that someone that has like an ATM gene go get tested? Or what kind of would be the parameters that you would say to a patient, you should go get tested?
The American Society of Gastroenterology is, they have a nice paper out on this with all the genes that they've identified. And those are the ones that you would tackle. A lot of that is above my pay grade as a radiologist. But I think the big one is a lot of these genes we just don't know. We don't know yet what they are. And so I think the real important point is, your grandfather passed away with pancreatic cancer, your grandmother, your brother, your aunt, your uncle, that's going to help identify people who have the gene that we don't even know yet.
Thank you. I happen to know someone that has that gene and went to a well-known hospital and didn't necessarily have in the immediate family, father, mother, brother, pancreatic cancer. But as you just said, I don't know about grandfather, grandmother, aunt, uncle. So I'm just curious because and I'm just using this gene because I just happen to know a little bit about it. But that gene, if you have it, your increased risk for pancreatic cancer are large. And so I was just curious if you had thought on, because this person was told, we're not going to screen you because your mother, brother, sister doesn't have it.
Well, I would think that they would be getting screened because it's got to start somewhere, unfortunately. Maybe their grandparents or parents didn't express the gene, but I would want to know because it's as other speakers have said, it's a terrible cancer, and the best way to treat is early detection.
Right. Thank you so much.
Thank you.
Thank you again for your testimony. We appreciate your staying with us and talking to us this evening. We'll move to the next person on our list, which is Kathleen Legrid. Ms. Legrid, you're on.
Yes, thank you. Hello, members of the Public Health Committee. Thank you for the opportunity to speak today. My name is Kathleen Legrid, and I'm here to testify in opposition to House Bill 6837. I'm a disability advocate, a current Partners in Policymaking participant, and someone who has received electroconvulsive treatment or shock treatment myself. I voluntarily received 17 shocks in a single course of treatment in the fall of 2018 over a period of about 2 months. Though the ECT doctors and my own psychiatrist might have described my new docile, amenable demeanor as an improvement, the truth was, at that point, I was little more than a zombie. I might not have felt depressed in the days immediately following ECT, but that was simply because my brain couldn't feel anything at all. Luckily, that zombification wore off in the months afterward, but the new reality that those ECT doctors left me with that they didn't get to see or experience for themselves was one of significantly reduced functioning, newfound cognitive impairment, and disability. The most severe and disturbing effect of the brain damage I received from my ECT was a sudden inability to retain new information. Essentially, I was no longer capable of learning anything in the same way that I had before. This has profoundly diminished my employment opportunities, my ability to work, and as a result of the ECT, I'm now on SSDI. ECT delivered a massive blow to my potential, my hope for the future, and ultimately my sense of self. There's not a day that goes by where I don't find myself wishing that I had made a different choice. Every day I grieve for what I have lost to ECT. Psychiatry has a massive gulf between its intent and its impact, and rarely, if ever, does it allow for evidence to come forward of that divide. Once someone is given a label of mentally ill, it is nearly impossible for them to be taken seriously from that point on. But I am here today of sound mind, and I wish to speak with clarity and in no uncertain terms. ECT for me and for many people is a profound, irreversible mistake. As an experimental trial, an error type of procedure, ECT deserves to be subject to continuous checks on its effectiveness, impact, and most importantly, the consent of the individual receiving it. For psychiatric patients receiving involuntary treatment who cannot simply revoke their consent at any time, like any other patient in the hospital could, These checks are crucial, and they must be done by someone other than the doctors whose personal livelihoods and professional reputations depend on the continuation of ECT and the appearance of its success. There's no such thing as too much consent, but there is unquestionably such a thing as too little, which is exactly what Bill 6837 would enact. Please reject this bill and keep these bare minimum 30 and 45-day safeguards in place. That was my written statement, but I'd really like to say something very quickly in response to something that came up with Dr. May's lengthy testimony regarding advocating for people who cannot communicate and be here for themselves. It is an assumption that is made to believe that if the person could be here and if the person could speak for themselves, that they would want this treatment, that they would agree to it. That is in no way guaranteed. It is an assumption, and it is a dangerous one at that. Thank you.
Thank you so much. Did you submit a written testimony, Ms. Legwood?
I have not, but I can if that is desired.
That will add to our insight, because some of our fellow legislators who are at other meetings would love to read what you have written as well.
Absolutely. Thank you.
Thank you so much. Seeing no other questions or comments, we'll move to the next person on our list, which could be Carmen Teresa Rosario. I think Carmen needs a translator. Is somebody who's going to translate for her? Okay, please, you can join in. Carmen, please go ahead. Teresa. Carmen Teresa Rosario. Teresa.
Yes. I know that she is currently in Puerto Rico and she lost power, so I don't know if that might be affecting.
Okay, so we'll move to the next person and then see if that's possible.
Good.
Next one is Sheldon Tobman. Sheldon, you're on. Welcome.
Thank you. Good afternoon, Senator Anwar, Representative McCarthy-Vahey. I'm Sheldon Taubman, the litigation attorney at Disability Rights Connecticut. That's the protection and advocacy system for Connecticut for people with a full range of disabilities. I'm here to testify about the impact of HB 6836, which would allow DSS under Medicaid to change to paying hospitals through fixed global budgets, the impact of that on people with disabilities. So let's talk about the troubling proposal on the federal level to block grant or impose per capita caps for all Medicaid payments. What we've heard from them is they want to save money, but they say they're doing it for efficiency and giving flexibility to the states. They make no reference to the fact that this is a fixed amount of money, which will put significant risk on the states for the goal of saving money. State officials here have roundly condemned these block grant proposals on the federal level because they would limit access to care. And yet the AHEAD proposal, which is what 6836 would authorize, intends the same block grant approach, but just on a lower level. Under this proposal, hospitals will have a direct incentive to deny care for individuals on Medicaid because they will no longer be paid on a fee-for-service basis for services rendered. They'll be paid instead a fixed amount of money per year. They will have a strong incentive not to serve Medicaid enrollees after the money runs out. And even before then, they'll have an incentive to stint on care because they can pocket the difference. And that's just like states would be incentivized under a block grant approach from the federal side. Although the proponents say AHEAD will apply to all payers, past experience in Connecticut is that the state can't control other payers. So in the end, it is only Medicaid enrollees who become subjected to it, which will make hospital providers strongly prefer patients from other payers who continue to pay on a fee-for-service basis. I know the proponents have said it's voluntary, but Dr. Dalal for DSS acknowledged there's a requirement of 30% participation for Medicare and indicated a target is the same for Medicaid. But even if it were truly voluntary for the hospitals, it will not be voluntary for the Medicaid patients subject to it who have to go to that hospital. The proposal ignores the harm from incentivized stinting under any block grant approach like this and offers no means to even monitor for it, let alone prevent it. And I should note that this will be imposed on hospital systems, and it may include all of their services, specialists, the whole range. Now, since CMS is under the Trump administration, the new Trump administration, that administration has demonstrated a lack of concern for the Medicaid program. So there's no reason to believe that CMS would step in to do anything to require DSS to reduce the harm from this block grant approach, which will incentivize directly non-service. As troubling as this proposal directly impacting the Medicaid program is, DSS and OHS move forward with this highly disruptive proposal without even providing notice, let alone consulting with the MAPOC. That's in direct violation of Connecticut General Statute 17B-28. In fact, they've still given no notice to the MAPOC, which is supposed to oversee the Medicaid program, including service delivery, and they've gone right to getting a grant from the feds. In sum, AHEAD is really just a proposal to save money by block granting Medicaid for hospital care, but under another name and with a lot of fluffy language about completely unenforceable intentions and talking about flexibility and equity. But really, just like the proposal to block grant the Medicaid program on the federal level, it threatens real harm to the most vulnerable residents of our state, people with severe disabilities that I represent, as hospitals are strongly financially incentivized to deny or restrict access to care. You can dress it up, but at the end, what's being proposed is a harmful program of block granting Medicaid. Thank you very much.
Thank you so much. You have a written testimony as well, Sheldon?
Yes, I do.
Okay. Very dense stuff, so I will have to read it a few times. Thank you. This is very helpful. Thank you. Seeing no comments or questions. Oh, Representative Miko.
Thank you, Mr. Chair. I just wanted to thank you, Sheldon, for submitting testimony. I look forward to reading your written testimony, as does the chair, the chairs. Did I hear you say at the end that this proposal was not presented to MAPOC in its proper form, or did I misunderstand that?
You heard that correctly. Actually, it wasn't presented to MAPOC at all. And the statute that I cited provides unequivocally 17B-28 through that legislation. It's mandated that DSS, that the MAPOC has to monitor planning and implementation of matters related to Medicaid care management initiatives, including but not limited to access and quality assurance. And also, more basically, the MAPOC is charged by statute to, quote, advise the Commissioner of Social Services on the planning and implementation of the healthcare delivery system for the Husky Health Program, close quote. I think that the reason this was not presented to the MAPOC as required by state law is because they knew if it was presented, a whole bunch of questions would have been raised. So they went ahead and submitted the application for the grant in March of 24. It was granted in July of 24. And now, February, they've still not even noticed the MAPOC. I think the MAPOC is owed an explanation for why this was bypassed and why they thought they could just disregard state law on such a proposal, involving radical restructuring of the Medicaid program.
And just one final question. So, I don't know that you want to answer this. Do you see any possible benefit to this change in the way this is being done? I know you pointed out several of the detrimental or deleterious effects, in your opinion. Do you see anything beneficial to this?
So I guess the honest
other than money.
Yeah, I think that this is about saving money, and I think it's all dressed up. Put lipstick on the pig, make it look like it's something fancy. It's going to increase. Constantly we're told it's going to address equity issues. It's going to be more efficient. It's going to provide flexibility. But in the end, all these models are the same. They put financial risk on the entity receiving the money. On the federal level, block granting coming from Congress, that would mean the states take on the financial risk. And now, of course, that the states would, if that happens, the states are going to be in a terrible spot and they're going to restrict access to care. It's the same thing on this level, even though it's said that the hospitals will have more flexibility to decide which services to provide, when to provide more services, and they won't be stuck by the supposedly rigid fee-for-service program or payment system. The bottom line is it puts financial risk on the provider, so they have a direct incentive to deny care. At the end of the day, they will want to save money by restricting access to care. So the answer to your question is no, I don't see any benefit unless your sole purpose was to save money. And then you're going to look at how much we're paying the hospital. You say, okay, now, of course, the hospitals are complaining they're not being paid adequately already. They say it's like 61% of what it should be. But in any event, that the plan would be to, cut the money to the hospitals. And yeah, I guess we might save a little bit of money, but at what cost to Connecticut residents with 1 million people being on Medicaid now?
And thank you for that. And just with the chair's indulgence, one final question. I obviously, you're because of your job and maybe even beyond your job, you're concerned about people with disabilities. Obviously, that's what you do for a living. Could you please explain to me just briefly, how is it that people with disabilities will be particularly affected negatively by this proposal?
Sure. I gave the example in my written testimony of a person who has a cardiac condition, but also has a serious mental illness or perhaps an intellectual disability such that their care is complicated. So they've got maybe a complicated cardiac treatment, which requires, fairly extensive service in the hospital. But because of their other disability, it's really difficult addressing the needs of this patient. The patient has difficulty understanding what's going on. So they're very, very labor intensive with a whole range of providers. If the hospital has already gone through its block grant for the year, can you imagine what the pressures will be to not serve that very expensive, complicated, disabled patient? It's just one example, but that's what we're talking about.
Thank you very much. Thank you, Mr. Chair.
Thank you so much. Thank you, Sheldon. And we'll move to our last speaker of the day. Wait, oh, you have a question? Sorry. Representative Claire Desditra. Sorry about that.
You blocked out my question. Thank you, Sheldon, for being here today. So quickly, if this block grant is roughly $12 million and they said it's 2 million that they're getting a year, that means there's no Medicaid adjustment for 10 years. So their hospitals are locked into this fee for 10 years. Now, I know we're talking about equity for patients, but what about the hospitals? Then what? And they run out of this money in a year. Who's on the hook?
Just to be clear, the $12 million is planning grant. That's not the payments to the hospitals. That would be almost basically nothing. But the planning grant presumes, and this was the CMS under the previous administration, and certainly we don't know what the new administration is going to do, but it presumes in order to get this planning grant, what you have, the deliverables, Representative, are that you have to have that kind of a payment system. So the hospital will be getting a fixed amount of money. And it's very complicated how you're going to calculate it. But again, if the goal is, as is pretty clear, to save money, it's going to mean that the hospital might be shorted. Now, you might say it's voluntary, right? Because that's their argument. Well, the hospital doesn't have to take it. It's just a choice. But there's all kinds of ways you can make something be kind of, they don't have a choice. Like, for example, continuing to underpay the hospitals. That would be one way to make it so that you offer a little bit of sweetener, which is that, well, we'll pay you a little bit more, but you got to take this thing. And then you're right. Then they're locked in. And as another pandemic happens, or who knows what, that's it. That's all the money you're getting. So it would be very concerning, independent of the $12 million.
Thank you for that explanation. And then to your point, so then what happens when their block grant runs out for the year?
It's very worrisome.
Yeah, exactly. Thank you.
Thank you.
All right. Thank you so much, Sheldon, for your testimony. And we'll come to the last person. That is Teresa, bienvenida Teresa, and Adriana vuelve.
Sí, pero parece que yo no tengo luz y se me está haciendo difícil.
She's saying she doesn't have power and it's hard for you. Teresa, ¿pero puede testificar?
No, es que no puedo llegar al papel, no me deja llegar. Como no tengo power, ¿tú lo puedes decir?
She's asking
Yeah.
to read her testimony because she can't access it because she doesn't have power. Okay, so dear Senator Anwar, Representative McCarthy-Vehí, and esteemed members of the Public Health Committee, my name is Teresa Rosario, and I am a resident of Hartford, Connecticut. I am a member of Make the Road Connecticut, and I stand in support of SB 1192, an act concerning hospital financial assistance. Medical debt is a major and growing contributor to the cycle of economic and health inequity. Racial inequities in income, wealth, and insurance coverage play a role in the prevalence and burden of medical debt. Financial assistance policies, also known as charity care, can help reduce how often patients incur medical debt and ensure that people eligible for assistance do not end up in collections. The experience I want to tell you about is my neighbor's, who started having pain on the left side of her waist. The pain started mild, but it kept increasing, and her daughter told her that she was going to take her to Hartford Hospital. They arrived at the hospital in the emergency room, where she had many tests done, such as blood tests and a CT scan to determine what was happening to her. Those tests took a long time, and she had to stay an extra day in the emergency room. They told her that they had found a small perforation in her lung, but she was not a smoker, and so the doctors discharged her without any treatment and sent her home, telling her to come back if the pain returned. She is retired and had health insurance that she paid for. 2 or 3 weeks later, she received a bill for $85,000 saying that her health insurance did not cover all the diagnostic tests of the 2 nights she had to stay in the emergency room. She called to ask what happened and was told that the plan would not cover the full bill, which was even more expensive. She continued to receive bills, but they never called to follow up on her condition. So she continued to get the bills and ignored them. It's been 5 years and she still hasn't paid her bill. Eventually, they stopped sending her the bill, and she doesn't go back to the hospital to ask what happened to her, nor does she go to the emergency room to ask for the medical records so that they won't charge her. She was left wondering, but they never treated her the way you would think a patient should be treated. It's been more than 5 years now, and she doesn't want to hear from the hospital that didn't follow up with her, but she still worries that at some point something might happen to her, or that she might get that bill again. Now she is a widow and would be even less able to pay that money. She would like there to be more accountability for hospitals so that these cases where patients are not treated well do not happen. Thank you for the opportunity to testify in support of SB 1192, an act concerning hospital financial assistance. I urge the committee to favorably pass this bill. Sincerely, Teresa Rosario.
Gracias.
Gracias, Teresa. Thank you so much.
Thank
This was
you.
very helpful. That's scary.
Yeah.
It's very real and scary.
Yes.
Thank you. Muchas gracias, Teresa. Thank you. We have no questions.
No tienen preguntas, Teresa. Gracias.
Ok, gracias a todos.
Thank you,
Okay.
Tom.
With that, seeing no questions, we are going to conclude our first public hearing. Thank you for everyone for staying back and being part of this conversation. And thank you for each and everyone who came and spoke today. Thank you. And thank you for all our colleagues who have been online listening to this important conversation. Thank you. Oh.
Now I have to go to my DTC meeting.
Oh, no, that's torture.